thrice daily cefepime along with hemodialysis was continued and other supportive medications were continued. On day 3, means 2 days after initiation of antibiotic therapy, she developed fever, tachycardia, vomiting. She became very irritable with fall in blood pressure, and thinking of sepsis, we sent blood culture, urine culture, X-ray chest was done, and symptomatic treatment given, and hemodialysis was withheld because of hypotension. Patient became more drowsy day by day, and ABG showed metabolic acidosis. In that point, on day 5th, we stopped cefepime. Urine culture and blood culture, which we sent 2 days earlier, came to be sterile. And patient was highly irritable. On day 6, she was delirious. She was again shifted to ICU. ABG was repeated. It again showed metabolic acidosis and lactic acidosis, and C31 generalized tonic-clonic seizure. This is her EEG done on day 6, which showed diffuse slowing of background, presence of diffuse epileptiform discharges, looking discharges, but actually these are periodic discharges with atypical triphasic waves. CT scan of brain was done. Injection lorazepam was given. Again, we did CSF analysis. This was the EEG done after few minutes of giving lorazepam injection, which showed much reduction of periodic discharges, and few triphasic waves are also seen. This is her CT scan of brain showing no structural abnormality and age-related atrophic changes. On day 8, patient became drowsy, but she was arousable. Her GCS slightly improved, and subsequently on day 9, her GCS improved and she became normal, and GCS became 15/15. On follow-up, the patient was undergoing regular hemodialysis on alternate day, and sensorium is completely improved. Coming to my third case, she is again a case of 54-year female case of hypertension, diabetes with chronic kidney disease on regular hemodialysis, admitted with complaints of weakness. Her vitals were, pulse rate was slightly high. She was having tachycardia, blood pressure was high. Routine investigation revealed hemoglobin was low, creatinine was high, and potassium was also high. She was advised urology consultation for AB fistula. Hemodialysis was done. Injection cefepime was given along with linezolid and continued with other supportive medication. On second day, means 2 days after initiations of antibiotic therapy, she had 1 spike of fever. Tablet paracetamol was given. 3 samples of blood culture and urine culture were sent. On day 4th, there was mild disorientation with hyperkalemia. Urgent hemodialysis was done. Patient became gradually drowsy. There was frequent myoclonic jerks, and she was shifted to ICU, and injection cefepime was stopped on day 4. ABG revealed primary metabolic acidosis with hyperkalemia. Anti-hyperkalemic measures were started. Urgent hemodialysis was done, and neurology opinion was given. EEG was done. It was so slowing of background, no specific abnormality, occasional triphasic waves. CT scan also didn't reveal any structural abnormality. On day 5th, GCS slightly deteriorated and became E3V2M5. CT scan was done. It was normal. CSF study didn't reveal any abnormality. Hemodialysis was done. On day 6, sensorium improved and there was no myoclonic jerks. She was shifted to HDU and underwent regular hemodialysis and discharged on day 15. Day 9. Sorry. Coming to my last case, he is a 73-year male admitted with complaints of decreased urine output, swelling of both lower limb. He is a known case of COPD, type 2 diabetes mellitus, hypertension, and chronic kidney patient. His vitals were elevated blood pressure. GCS was 15/15. There was pallor, pedal edema. Routine investigation revealed low hemoglobin, high potassium level, elevated serum urea and creatinine. Urine shows again 30 to 40%. He was put on NIV support. Injection cefepime was given. Hemodialysis was planned and 1 unit of blood transfusion given. On day 2, he had sinus bradycardia. BP was high. Nitroglycerin drip was started. Echo revealed global hypokinesia and ejection fraction was 46%. Holter monitoring started. Subsequently, BP remained high. ST elevation and T inversion seen in ECG. Cardiology opinion taken. Antihypertensive drugs was started and he was shifted to HDU. Sensorium gradually deteriorated. He became drowsy with sluggish response. Ultimately, neurology consultation given. When we saw his GCS was E3, V1 and M4, he was responding to painful stimuli. There was no focal deficit. CT scan brain was done. It was normal. EEG revealed generally periodic discharges. This is his CT scan brain, and this is the generalized periodic discharges seen in his ECG, which sometimes confused with non-convulsive status. Actually, in cefepime-induced neurotoxicity, we see two types of ECG. One is slow, typical triphasic waves, periodic discharges, and fast, atypical triphasic wave periodic discharges. This is a one kind of fast, atypical triphasic periodic discharges. CSF study was done and modafinil thyroxine was started and patient was shifted to ICU and fundoscopy was done, MRI brain, CSF study, everything came out to be normal. On day 11, patient was not obeying command. MRI I just showed, it was normal. All other parameters to rule out acute confusional state and encephalopathy was done and it came to be normal. On day 11th, we stopped the antibiotic cefepime and we did again EEG. We saw similar kind of EEG finding, but periodic discharges were intensity-wise reduced. And on day 12, means 2 days after stopping of the antibiotic, there was slight improvement. He was spontaneously opening eyes and grimacing to pain. All other reports which we sent came to be normal. And on day 13, his sensorium improved. Physiotherapy started and subsequent days sensorium was better and he became normal and discharged on day 17. So coming to my cases in a summary, all the patients which we received in our ICU had chronic kidney patient with severe impairment of their renal function. GCS was 15/15 at the time of admission and all have urinary tract infection and they received cefepime in high dose. All have GFR in the range of less than 10 or around 11 and on day after initiation of cefepime therapy, within 3rd to 6th day, they developed encephalopathy or toxicity symptoms. And after stopping of the medicine, encephalopathy or toxicity symptoms, neurotoxicity resolved within 2 to 4 days, and 1 patient died even after hemodialysis and stopping of the medicine. So coming to review of literature, cefepime is a 4th generation cephalosporin with extended antibacterial spectrum, which is effective against both gram-positive as well as gram-negative organism, including Pseudomonas. It is bactericidal agent, acts by inhibition of the cell wall synthesis, and it is primary metabolized through kidney. T-half is 2 hours in normal renal function, but can be increased up to 13 hours in case of renal dysfunction. Hence, dose adjustment is recommended in setting of renal insufficiency. Typical latency of encephalopathy and resolution depends on various studies. It says that the latency of encephalopathy onset is between 1 to 10 days of the initiation of the medication and resolves within 2 to 7 days following discontinuation. These are the symptoms of cefepime-induced neurotoxicity symptoms like consciousness changes, myoclonic seizure, abnormal behavior, mutism, ataxia, asterexia, hallucination, tremor, clonus, and hyperreflexia. As I told already, pharmacokinetic metabolism of cefepime. Cefepime-induced neurotoxicity is not restricted to only your cefepime. Other fourth generation and third generation cephalosporin can have also neurotoxic effect. Neurotoxic effects of cephalosporin can range from slurred speech, tremor, confusion, aphasia, agitation, coma, myoclonus seizure, and to non-convulsive status epilepticus in various studies done by other scientists. Non-convulsive status epilepticus has been reported in patients with renal impairment and with use of third and fourth generation cephalosporin such as ceftazidime, ceftriaxone, and cefepime. Mechanism of cefepime-induced neurotoxicity includes gamma-aminobutyric acid receptor antagonism, leading to GABA-A mediated inhibitor response, therefore generating a pro-epileptogenic activity. So, how cefepime-induced neurotoxicity? Excess cefepime in blood level, it crosses the blood-brain barrier and competitively inhibits the CNS A GABA receptor, leading to depolarization of the postsynaptic membrane potential and neurological symptoms like seizure, encephalopathy, and myoclonus. So, who are the patients who can have seizure potential? So, risk of seizure in patient not receiving dose adjustment for renal impairment. Those patients who have renal impairment, they should receive adequate renal adjusted dose, otherwise there is chance of seizure is there. From various study from 1996 to 2012, 59 cases were identified having non-convulsive status epilepticus with cefepime administration, and renal dysfunction was present 58 out of 59 cases. 56 of the 59 patients, cefepime dose was not appropriately adjusted for renal impairment according to recommendation of the cefepime level. It has been also seen that neurotoxicity can be also seen in patients with renal impairment who have adequately adjusted cefepime dose. Even neurotoxicity has been reported with normal renal function status patient. So we must be very careful in case of any neurological complication on administration of cefepime. Consider a cefepime-induced neurotoxicity and check EEG. Aggressive treatment with anti-seizure medication is not warranted, and cefepime discontinuation is the definite treatment. Sometimes hemodialysis can hasten cefepime clearance and may hasten the recovery process. So, impaired clearance of the drug secondary to acute or chronic renal dysfunction leads to drug accumulation. Inflammation imposed by acute illness may disrupt normal blood-brain barrier integrity, increasing the concentration in CNS. Typical presentation include altered mental status with reduced consciousness, appearing with a median onset of 4 days after cefepime initiation, and symptoms may progress to myoclonus and seizure without intervention or discontinuation. Symptoms improvement or clinical resolution of symptoms is achieved with a median onset of 2 days after discontinuation of the therapy. Emergency dialysis reduces time to clinical improvement by 1 day. So this is the recommendation by Fugate et al. Dose adjustment is needed in case of renal impairment. If the creatine clearance is less than 60 and between 30, there is 2 gram per day is the recommended dose. And if the creatine clearance is between 11 and 29, 1 gram per day is the recommended dose. And if the creatine clearance is less than 10, less than 1 gram is the recommended dose. And if the creatine clearance level is more than 60, full dose, that is 2 gram TDS of cefepime can be given. In all our cases have severely impaired, which I present have severely impaired renal function, and they all received 1 gram thrice daily cefepime, means a very high dose of cefepime, ultimately leading to cefepime-induced neurotoxicity. In various studies, this is the symptoms of cefepime-induced neurotoxicity. Diminished level of consciousness was seen in 80% of the cases. Disorientation and agitation was seen in 47%. Myoclonus was seen in 40%. Non-convulsive status epilepticus seen in 31%. Seizures were seen in 11% and aphasia in 9%. So we must be very cautious in ICU patient or inpatient with renal impairment cases who are receiving on cefepime therapy. Cefepime-induced neurotoxicity occurs most commonly when inappropriate large dose is administered in patient with renal dysfunction, but up to 20%, 25% also seen in patient receiving proper dose. Even I told, even normal person can have CNS toxicity secondary to cefepime. So we must be very cautious. Drug toxicity should be considered in all patients experiencing neurological deterioration in ICU patient. Further studies needed to understand non-renal pharmacokinetic risk factors for CIN, incidence and long-term outcome of CIN mean cefepime-induced neurotoxicity. As the incidence of cefepime-induced neurotoxicity is not uncommon, clinical awareness and prompt further investigation is warranted whenever there is new onset neurological deterioration in patient receiving cefepime. Renal dose modification of cefepime is necessary as the therapeutic window is very low. Thank you.
Thank you so much, Professor. Thank you so much. And let's proceed to our next keynote speaker, a professor and head of Department of Institute of Dental Sciences, Som Hospital, India. Let us welcome Dr. Sanat Kumar Buyan. There you go. Perfect. Yeah. You're on mute, sir.
Yes, is it audible?
There you go. Yes, you are audible.
Good morning.
Good morning.
Good morning, one and all. First of all, I want to give the thanks to CEO of Bialic, Mr. Rudra Satpathy. Because of him, I am able to get opportunity to be part of this conference on neurology and neuroscience. Now, coming to my presentation. Now coming to my presentation, that is orofacial pain. As you know, this neural origin, the pain is neural origin. According to the definition, it is an unpleasant sensation produced by the noxious stimulus carried to the central nervous systems where it is interpreted as such. Now coming to the evaluation of orofacial patient. Before that evaluation, important we know for each and every case, we should go for chief complaint, medical history, dental history and pain history. Now coming to the quality of pain. The quality of pain, for example, you may get itching type, throbbing type, groaning type, paroxysmal and some other combination of all. Now the duration, it may be most of the time it is episodic. The site of affected area, patient always point out the source of pain. Always we ask the patient, please outline the area. Once it is outlined by the patient, it is easy for the diagnosis. Now, what is the initiating factors? Before that, we should know what are the initiating factor occurring and before the pain start. And what are the exacerbating factor? The exacerbating factor, it may be either worsen or it may be reduced. The relieving factor, you have to ask the patient which time you relieve, whether it is relieved totally in between or we have to give some nerve block or any anticonvulsant agent. The associated sign and symptoms, it may be associated with some lacrimation, vomiting, nausea, rhinorrhea, photophobia and phonophobia and fever, etc. And before that, we should take the history, whether he has done any investigation previously or any treatment taken previously. Now coming to the physical examination. In physical examination, first of all, we should go for all vital signs examination. Then internal examination with oral cancer screening. Then go for the next head and neck examination, that is lymph node examination, TMJ examination, skin and orofacial and myofascial examination. Next is the cranial nerve examination, because we know this is the neural origin. We should know what are the nerves, that is cranial nerve, which are affected in maxillofacial area. So we should examine very thoroughly, find out any trigger zone is there, any hyperthesia or hypothesia or anesthesia is there or not. Then if it is there, then we can go for some anesthetic agent. We can apply some anesthesia, then immediately if it is neurological origin, then pain will reduce. Now coming to the imaging and special investigation. In the special investigation, we should examine, go for proper screening of cranial nerves and laboratory blood gas analysis, so laboratory blood analysis, MRI and bone scan. Now coming to the pain classification by origin. The origin may be a somatic pain originating from the cells like from the skin, mucous membrane, bone, joint or muscles. If it is neurogenic pain, then there must be some abnormality in the nervous system. Then psychological pain, it is relating from psychic cause where there no noxious stimulus is there, no abnormality in neural structure is there. Only it is related to psychological causes. Sorry. Now coming to the somatic pain. The somatic pain, it may be either superficial somatic or deep somatic. If it is superficial somatic, may be from skin or from mucogingival area. If it is deep somatic, it may be musculoskeletal or it may be from visceral. If it is a musculoskeletal, it coming out from the muscle or TMJ or from osseous structure or any from periodontal structure around the tooth. If it is a visceral, then it may come from the pulp, because the most common origin in the dental area, or it may be the gland, mostly the parotid or any salivary gland, or it from the ear or it from the eye, or it from anywhere from neurovascular area. Now, what is the neuropathic pain? In neuropathic pain, you may get either episodic or you may get continuous. If it is episodic, it may be either neuralgia or it may be vascular. If it is continuous, it is neuritis or defiant pain. In somatic pain, for example, to the superficial area which are coming, they express either it is the stimuli from thermal area or chemical one or mechanical, or there is some ulcer is there which is of either bacterial, viral or candid origin. Now the superficial pain, it present in the form either burning or pricking or it is localized. In the deep pain, from either from the muscle or from the joint or from the ligament. For example, the syndrome associated is calcification, that is styloid ligament, Eagle syndrome. Here it represents either jaw-lacking pain or it is referred pain. Now coming to the inflammatory pain is due to either collection some pus, or whether it is infected cyst or it may be pericoronitis. And the character of the pain, it is always throbbing and tender by the local lesion. And next, the referred pain, most the orofacial area, referred area, most the oral stool like maxillary sinus, or it may come from ear or from the eyes. And it represents in the form of deep pain. Now coming to neurogenic pain, first have come to the neuritis. It is an inflammatory changes of the nerve. It represents in the form of burning sensation. If it is neuralgia, then it follows the course of the nerve and of the central nervous system. If it is a vascular, generally it is a poorly localized pain, it is chronic and preceded by minor electric shock like pain. Now what are the causes of orofacial pain? First, the local causes. The most common area is from the teeth, that is means any disease to the teeth. Then next, the periodontium, around the tooth, disease from the periodontium. Then from the oral structure and perioral structure, oral mucosa, and anywhere from upper jaw, lower jaw, or it is from antrum and salivary glands, or it may from temporomandibular joint, or it may from ears and eyes, and it may from disease of the sinus or from the nasopharynx or oropharynx. Now coming to neurological causes, the neuropathic. It is very important, like trigeminal neuralgia, glossopharyngeal neuralgia, herpetic neuralgia, post-herpetic neuralgia, genetical neuralgia, Bell's palsy, and multiple sclerosis, intracranial tumors, and chorzalgia. In psychogenic causes, the things are coming like atypical odontologia, atypical facial pain, and burning mouth syndrome. The vascular causes like migraine, periodic migraine, paroxysmal hemifacial, hemicrania, giant cell, that is temporal cranial arteries, and referred friend, that is from cardiac arrhythmia. Now coming to trigeminal neuralgia, that is neurogenic pain. These are the very sharp pain, which is lancinating and shooting type of pain. You will find along the distribution of the trigeminal nerve, and there is always a specific trigger zone is there. And if you come to the etiology, it may be either demyelination of the nerve or vascular compression of trigeminal ganglion, or it will be a trauma or any infection in the nerve, or it may be idiopathic. Mostly this involve the second and third division, and the first division is very rare, but most common is the second division. It is very easy to remember. It is mostly you will find the cases, you will find the trigeminal cases that is after 40, that to most the female, then the right side of the mandible, you will find the daytime, and it is never cross the midline. Now coming to side, if you come to the clinical picture, you will get spasmodic contraction of the facial muscle, which is for hardly 10 seconds. If you observe very carefully to the patient, you will find that a twitching like is occurring. This is a very important observation and give the diagnosis. Like symptoms, you will find along the pain limited to 3 division of the cranial nerves only. And I told you it never cross the midline. The pain is described as sharp, stabbing and electric shock and red hot needle type and rapid onset, short duration with rapid recovery. And you will find there is a paroxysm there. This paroxysm stay for either for days or week for months. This trigeminal neuralgia does not affect the sleep. Pain can be provoked by touching or breathing the tiger's joints are there in the face and the perioral area. These are the picture, the triger's area are there, where if the touching is there, you get immediate pain. So here the two things we should remember in the differential diagnosis. One is there is a trigger journey is there, and second is there is a remission period in this pain. This is the only pain you will find the remission is there. Means there is attack, then remission, then is attack, there is a remission. And if you give local anesthesia, you will see immediate pain reduction. That is the diagnostic criteria. For diagnostic aid, we can go for CT MRI, where to exclude any tumor in the brain. And mostly the carbamazepine used as a diagnostic agent because it immediately reduces the pain. You have to differentiate from multiple sclerosis because the pain is same. But in this case, in multiple sclerosis, mostly affect the young person, and that it is not unilateral, it is bilateral. Next is cluster headache. Mostly you will find in the night time, and there is no trigger zone is there. Next is the post-herpetic neuralgia. You will find there is history of herpes zoster is there, and you will find some skin infection or the skin lesion is there. So which will help us to differentiate from post-herpetic neuralgia. Then psychological neuralgia, the distribution of the pain is unanatomical. There is no trigger zone is there. It is a vague pain and poorly localized. Now coming to the neoplasia. In the neoplasia, you can find there must be some tumor in that intracranial area. Next, then glossopharyngeal neuralgia. In the glossopharyngeal neuralgia, pain is always unilateral, almost the pain like trigeminal neuralgia, but the origin is from throat and the base of the tongue. Sometimes it radiating to the ear. Next is you have to differentiate from pain from dental origin like pulpitis or periodontitis or pericornitis. It is diagnosed because it can see clinically. Then pain of osseous origin. Most the important is a dry socket. Immediately after extraction, many people they will come on the third day. They complain there is a pain. So means it is a pain due to dry socket. And next is the acute osteomyelitis. And third, the last is this is the pain arising from temporomandibular joint. Many times you will get like a excruciating type of pain. Now coming to the treatment. So treatment is the carbamazepine is the gold standard drug, and generally you start with 100 milligram 2 times daily in the mild cases. If the pain is severe, then we can go up to 1200 milligram per day. But only thing, while prescribing the medicine, you have to speak to the patient. It causes there is anaphylactic reaction. Number one, number two, there is a reeling of head. So you have to be concerned about the patient regarding this. And another thing, those patients who are taking for month or years together, they have to go for investigation every 3 months. That is, because it causes a depression of the bone marrow, and you have to go for the normal finding of that is CBC. If this drug is not tolerated, because many times the carbamazepine is not tolerated by the patient, so or else if it is not tolerated or if it is not effective even after giving after 4 weeks, then you have to change the drug. That is second line of drug is the either anti-epileptic or tricyclic antidepressant. The most common drug is the after the carbamazepine is the gabapentin. So gabapentin is a very nice drug where all this reeling of head and the allergy is very rare. So you can go for that. Now, what are the peripheral procedure you can go for this? In the peripheral procedure, you know, the peripheral sensation start from sensory up to the entry zone of the in the foramen. So you can give some local anesthetic agent, thereby you can reduce the pain. That is an emergency measure, you can take it. And many physicians, they destroy the nerve by doing cryotherapy, alcohol therapy injection, and by nerve avulsion is used. So this technique is easily undertaken by either supraorbital approach or infraorbital approach or from mental nerve approach. Now at the ganglionic level, what treatment you can? At ganglion level, you can go for radiofrequency thermocoagulation, glycerol injection, ballooning compression, and radiosurgery, that is by gamma knife. Now go to surgical treatment. The surgical treatment is the trigeminal root resection, or you can go for intracranial surgery to remove any tumor which is compressing the nerve ganglion, or microvascular decompression, the MVD, or you can take out the loop which is giving the loop of the artery which is giving pressure. We can take the measure, thereby it can reduce the pain. So these are the small photograph, the entry path of surgery and how the artery and nerve are there. Now coming to the glossopharyngeal neuralgia. The glossopharyngeal neuralgia, almost the pain is sharp, same paroxysmal, electric shock like and radiating to the ear. And I told you it is also unilateral, but origin is mostly from the tonsils, larynx, soft tissue and posterior part of the tongue. And pain is also unilateral, like this trigeminal neuralgia, and it is unilateral and it is of short duration. Most of the patient experience the pain during swallowing, chewing and speaking and eating and drinking because it attacks the trigger area. And the diagnostic is if you give a spray in the pharynx area, immediately the pain reduces. It is mostly involved by middle ages and the elderly people. Female are more affected. And here the pain mostly you will find the left side instead of the right, what you will get in the trigeminal neuralgia. The etiology is vascular compression of the posterior intracerebral artery on the root entry of the medulla. Now, here the differential diagnosis is the Eagle syndrome. Here you will find patient will get discomfort during eating and he will get headache. And if he turn, pain on the turning the head to the other side. So this you can by differentiate from the Eagle syndrome, and treatment is same I told you, like trigeminal neuralgia, same carbamazepine and surgical decompression. Now coming to psychogenic pain. In the psychogenic pain, the atypical facial pain is coming. Here in atypical facial pain, which is mainly the vague pain, patient constantly pain, patient will tell I am getting pain throughout the day. Here there is no remission. It is associated with mostly depression and anxiety state. Here the female are more sufferer and mostly you will get after 50 years of age. It may be either unilateral or it may be bilateral. It may cross the middle. So you will get all features. Means there is no specific clinical diagnosis is there. Now coming to the sign, there is no causative factor detected cranial nerve are intact. And coming to the treatment, treatment is a psychotherapy and anxiolytic and antidepressant. Now next is the atypical odontologia. Here the etiology and symptoms are same as atypical facial pain, but patient every time will tell I am getting from the tooth. But by the time they must have visited to many dentists they have extracted many tooth, but still the pain is continuing. So it is a vague pain, very difficult to find out. Only the patient is telling from the tooth, that is the atypical odontologia, and very difficult to give the diagnosis and exclusion. Now coming to the pain of vascular origin. Here mostly the recurrent headache you will find with autonomic disturbances, that is aura. Incidence and age, usually you will find second decade. It diminishes with as the age progresses. Most you will find in the women, and 50% of cases you will find the history of migraine of the family. The etiology, you will find there is a constriction of the branches of the external carotid artery causing the characteristic aura, followed by dilatation causing the headache. Now the two types, one is classic migraine with aura, then migraine without aura. The classic migraine is characterized by abrupt onset of headache, unilateral and deep throbbing pain. Headache may last for 12 hours, affected the frontotemporal region, unilateral, then the secondary spread to the entire cranium. Headache is preceded by aura symptoms like prodromal symptom pre-headache, and patient causes there is lethargy. Aura include reversible sensory, motor and visual and speech disturbances. Visual disturbances like you will find the zigzag flickering of the light and there is blur vision. And sensory like there is numbness, you will get paresthesia and anesthesia of the face. In the motor if will come, that is unilateral muscle weakness of the face. Migraine without aura, it is unilateral. You will find throbbing, moderate to severe, accompanied by photophobia, phonophobia, nausea and vomiting. May aggravate by physical exertion. The precipitating factors are stress, psychological event, trauma, and vasoactive foods, chocolates and the banana. The treatment is, there is somatropine, that is a serotonin, and you can give some non-steroidal anti-inflammatory drugs, opioid analgesic and antiemetic. The differential diagnosis. So differential diagnosis many times it mimic and combine with the temporomandibular disorder. Any patient having temporomandibular disorder, they precipitate the migraine. So you have to be very careful before giving the diagnosis. And nausea and photophobia are not accompanied with this masticative and musculoskeletal disorder of the jaw and tooth pain of dental origin. Now, with this I conclude. In this orofacial pain, the most important part is the history and clinical examination. If we take the proper history and proper examination, then only you can find, because pain in the maxillofacial area is difficult to diagnose from where it is arising. So you need a thorough diagnosis, thorough clinical examination, then it is possible to give the best proper treatment and the diagnosis. Thank you all.
Thank you so much. Thank you so much, Professor. Next, let us welcome our next keynote speaker, the head of research and development, Neurophysics Therapy Institute from Australia. Let us welcome Dr. Ken Ware.
Lose.
Yes,
Okay.
it is now visible.
Okay, very good. I did actually try to get my video, because I have some videos to display during the presentation.
Yeah, you can actually just open it in your laptop, and then once you share, if you share your screen, just share the entire screen, and you can just switch window. All right.
Fantastic. Greetings from Australia, everybody. And first, I'd really like to sincerely thank the organisers of this event for giving us the opportunity to be able to present under such challenging circumstances. So thank you very much. So the presentation today is of course mainly focused on Tourette syndrome, and it's the work I've been interested in for the last 10 years or so. I'm trying to understand a little bit more about the mechanics of this condition, and certainly understand a little bit more about what are the sets of initial conditions that are most likely to give rise to this condition. And with the view of helping us to develop, more advanced psychophysical therapies to be able to deal with this. And we have been experimenting with this for some time, and have experienced a fair degree of success with it. But first, I would like to just speak about the history of neurophysics therapy a bit. What is neurophysics therapy? And in particular, introduce you to the award-winning documentary Calibrate, which is more or less a tribute to the work that I've been doing over the last 35 years by Academy Award nominee Steve Pawlowski. So it's been quite successful, and it just explores the lives of some of the people who've come to us from all over the world for therapy, in particular a lot of people with spinal cord injuries, so very complex, complete and incomplete spinal cord injuries. So, as part of the movie itself, like I said, it's a beautiful film. It's not an advertisement for so much for neurophysics therapy, but just a beautiful film talking about the people's lives and so forth. So if you have the opportunity to watch Calibrate, I'm sure you'll enjoy it. So what is neurophysics therapy? Well, neurophysics per se is a branch of medical physics and science, and dealing with the development of physical techniques, basically to gain information about the central nervous system and how we perceive and perception, cognition and action and so forth. And they're usually on a molecular scale with functional MRIs and PET scans and the likes. And neural networks and complexity science is some of the tools utilised to make sense of these data and to develop theory. Neurophysics therapy per se, I'm proud to say, has earned its own footprint within this branch of science because of the techniques that we've developed in terms of being able to see how a person is perceiving and interacting with their environment. So the specialised techniques that we use functional gym equipment to be able to do. And in particular, being able to recognise what we refer to as sensory perceptual errors that are giving rise to pathological conditions within the system itself, and then being able to have the same sort of tools then to be able to try to correct some of those conditions. So we've been quite successful with it over the years, and it's certainly not invisible out there. There's been a lot of stories, international stories about the success we've had, and one in particular, 60 Minutes, which I'll be talking about shortly, but in the BBC, so it's been fairly global, and had a victim of a Manchester bombing come out with a complete spinal cord injury that the results of that made the front page of the Daily Mirror in the UK. So like I said, it's not something that's invisible. It's a very open type of a thing that we do. Probably the most famous of those stories in some respects that really accelerate the awareness of neurophysics therapy was the work that I'd done with John McLean. He was a world famous para-athlete, and John had came to me in 2013 for some pain therapy, and that's all it was. He was in some chronic pain. John was the first paraplegic to swim the English Channel and to complete Kona, the Hawaiian Ironman. And as I said, he came to me for some pain therapy. And what I've basically been studying is the underlying kinetics of the human nervous system, and basically with this understanding that the natural resting state of the brain is chaotic, the central nervous system is chaotic in its resting state. And when we learn to transcend our normal experience of the world through some mild stimulation and relax, it starts to expose these underlying kinetics. And I want to be showing you the next couple of little film clips that we have in here. We'll be having a look at that and what that meant to me to understand with John. And the short story of all this is that after coming to me for that period of time, in 3 days, John took his first unassisted steps in 25 years and then went on to complete an able-bodied triathlon 18 months later. So we'll have a little bit of a look at this now. So as I was saying, we have these specialised pieces of gym equipment, and when a person learns to relax and just engage and initiate some movement just with a bit of mild stimulation, the system will gradually start to exhibit a type of tremor. Now, that's just the kinetics of the nervous system. As that starts to increase in value, we can learn about how the system is poised within its environment. We can look at those dynamics and see if they're noisy, if there's pathological conditions in there, because we can have a great understanding of what those dynamics actually mean. But for John, what it meant for him is as he started to relax, and we typically, remember, we're focusing on some pain issues here. So when he started to relax and transcend that, and as this tremor started to increase in velocity, and all he's learning to do is just stay out of it and just let his system evolve, the dynamics evolve, we started to see activity emerge beneath his legs. Now, John had no capacity to control he could control his right leg a little bit, but he had no capacity to control his left leg at all. Now, that increased in such value that you'll see on this next slide over here, that red machine is behind here because it actually jumped the cable off the pulley. And John's, like I said, he's a very good athlete, so there was lots of discharge coming from his body. And this is what happened next. So as you can see, they increased in value. Now remember, John could not voluntarily control those movements at all. And you'll see what happens when John disengages from that. And you'll see how his leg just flops back out the side, and he has to then pull it up. So he was quite confused about all that, and that's what sort of led me to say to John, well, I can't see why you're not walking, which he was quite challenged with at that first moment, because when you're saying that to a person who's been in a wheelchair for 25 years, it's not something they would take lightly. So but what it was, it clearly said that we can't possibly develop pathways that fast. His system had already created those pathways. It's just that the belief system and so forth doesn't allow people to understand that, and they don't have the techniques to expose his underlying kinetics. And there was some very precious footage here. This is quite historical footage of John taking those first unassisted steps after 25 years.
I haven't felt that straight for a very long time. Confident, yeah. So what I want to start running around here. Yeah. I do want to start running around here. Yes, yes.
Next week.
Just take your time. Just give it jobs to do. Don't get anxious. Just got to do the stone groups. It's good.
That's nice.
Yeah.
Then, as you can see on the right there, John has a book. It's quite a famous story, and as we speak now, they're in the process of making a Hollywood movie based upon that story. Something a little bit more visual with Kylie, the aggressive sarcoma that saw the removal of her complete hamstring, the sciatic nerve, and 3/4 of the leg of the adductor pathway. So it was pretty much a given as far as everybody is concerned at the time that Kylie was never going to be able to walk properly without assistance, certainly not be able to bend that leg voluntarily because there's no apparatus there to be able to do it. So, however, under the same conditions, it's just incredible how the system can learn to compensate for lesion given the right sets of initial conditions. And in the next slides here, we'll start to see Kylie performing some of these movements. And you can see how stable they all were, and there was complete control of the adductor pathway. If that wasn't working properly, those knees would be coming in towards one another. So you can certainly speculate on lots of things as to how that phenomenon is able to occur like that. But the reality of it is just the system, given those right conditions and the right framework to be able to calibrate itself to, hence the name of the title of the documentary, these systems will compensate for some quite aggressive lesions. So it's important to understand that the underlying kinetics of the nervous system, and what I've learned and studied over the years, when people start to transcend those states, we can start to see exactly how it's like a mapping out of how the system is interacting with the environment. And as I said, we can see noise in there, we can see all sorts of things, and we can see that in a system in that state, that why it's not functioning, or perhaps why there's some type of pathological condition there. But as the person learns to relax more, the system can very quickly start to get rid of those noise. And that's why neurophysics therapies has the reputation of being able to produce quite incredible results for people with long-term conditions and such very small timescales. Now, this is a bit of a clip from the movie Calibrate. So I'll just show you that.
The most amazing thing about neurophysics, where you're blown away by it, is the moment where you learn to let go and let your body do it. And usually the initial point in that is when you tremor.
So it sort of shows that then understanding all the characteristics and the dynamics and how those dynamics creatively evolve is something that's very important to understand. This is a presentation primarily on Tourette's syndrome, so we best move on to that. So what is Tourette's syndrome? Well, as we know, it's a neurological disorder and characterized by sudden, repetitive, rapid and unwanted movements or vocal sounds called tics. It's in that group of disorders called tic disorders. According to the NIH, the National Institute of Neurological Disorders and Stroke, there is no cure for TS. However, treatments are available to help manage some symptoms. So it's said to be every 1 in 100 children actually will develop TS. Tics usually begin to show between the ages of 2 and 15, the average age being 6, but we are starting to see that the average age of that is starting to come down even lower. Males 3 to 4 times more likely to develop TS than females. And most people experience their TS experience their worst symptoms in the early teens, and however, tics typically lessen as they become controlled by late teens. Some people can be chronic condition with symptoms that last into adulthood, and that's more the people that we've actually done the studies with. So what causes Tourette syndrome? Well, there's a lot of speculation, but basically the cause of TS is unknown, and current research does point to some abnormalities in certain regions of the brain, basal ganglia, for instance, and which seems pretty obvious, the frontal lobes and the cortex, and some of the neurotransmitters that they're speaking about, the dopamine, serotonin, norepinephrine. So there are often some coexisting fact conditions there commonly accompany Tourette syndrome. So it's attention deficit disorder, hyperactivity, anxiety, learning disabilities, problems falling and staying asleep, social skills deficits, sensory processing issues. How is Tourette syndrome treated? Well, unfortunately, there is no medication. There is no one medication that is helpful to all people with TS, nor does any medication completely eliminate symptoms. So it's pretty much a hit and miss type of an affair. And because they're mild, tics are usually quite mild, and some people they require no treatment. However, some treatments are medical for the people who symptoms interfere with daily functioning. As I said, they're more the people that we've been dealing with. So it's a list of some of the medications there that are used. So this is the profile of the people basically that we were working with. So over the last several years, there's been 10 patients involved, limited to higher functioning chronic TS patients. So it's not a pure sample by any means. There was 8 males and 2 females. And what's important, well, the main part of the process is looking about some sets of initial conditions, some baseline measurements we can actually take of any person really, that sort of gives us some indication of how well their system is perceiving and responding to the environment and how calibrated it is against that. So what we see with every one of these particular patients, that there was quite significant posture neglect. So they're very poor posture. And we know that everything in nature is being calibrated to that one true vertical constant that gravity supplies us. So every biological systems are being calibrated to that to be able to offset the effects of gravity. And for us, we have apparatus and compartment in our brain that actually help to do that. So we have all the basal ganglia and cerebellum that, of course, that do it. And when we've done our studies in the past and showing what the system looks like when it's got that perfect posture, and when we move it away from that posture, how much noise starts to build up in the system, and some of the other presentations I've done in the past relating to the onset of pathological tremors from, again, long-term posture neglect. And most of the time when you see people present with these pathological tremors is that they'll always have some type of forward lean, which is against that vertical constant. And when you have their eyes closed and you move them back towards that vertical constant, they generates lots of fear and anxiety. So poor compromised proprioception, very difficult for the person to, with their eyes closed, to bring their arms across their body and to touch their fingers, and likewise going from the finger to the nose. So it sort of shows that the hemispheres of the brain are reporting different things, and you'll start to see some hemisphere dominances appear, either the left or right hemisphere dominance. And proprioception is just nested within our perceptual landscape as to what we perceive to be a reality. So if we see errors in proprioception, because we're basically dealing with a scale-free system, it's very indicative that there's the person's perception of other things is not accurate. Now, it's not that they're purposely going out and making these false perceptions, it's just that how they're taking the information in and how it's getting downloaded into their system and they're responding to it. That's where these sensory perceptual errors occur. So it's important that we get some type of baseline measurements about that, because it's a good way of going back and checking if they start to improve in these areas and the disease, disorder, or whatever the condition was, is sensitive dependent upon these type of conditions. By altering these states where all of a sudden they can now perform these basic tasks properly, that's when we start to say, okay, now there's reliable structure and function coming back into the brain that's going to be much more beneficial to where they need to be but it's evidence straight away that neurons in their brain are firing differently to how they were before. For the symptoms to remain the same of whatever they've had, whatever the condition was, it would need the person to keep making the same mistakes. Neurons would have to keep communicating in the same way. So some of the other baseline measurements we took and what we noticed about these people, high sympathetic nervous system tone, where we start to see that what we call hypervigilance in there, particularly in the trapeze muscles, which are very sensitive to the sympathetic nervous system. We realise that as soon as we become tensed or anxious, we're going to tense up in the neck. So that's there's people have lots of tension in their neck there, the hypervigilance, lots of increased background tone. So if I see an image of the man moving the person's legs back and forth and with their eyes closed and them trying to relax, then when you start to do that, instead of them being able to relax and let you move their legs, they'll tense up very defensively as a result of that type of perturbation. When you're asking them to perform this basic, very fundamental movement of the cells. So as young children, we'll typically sit on a bench and we'll butterfly our legs backwards and forwards. And we don't think about that as children. It's just what the body spontaneously, these movements spontaneously emerge because the brain is constantly trying to synchronize itself. But when these particular patients were trying to do this, we've seen that there was lots of awkwardness with that. They found it very difficult to perform this basic fundamental movement. And this typically means that because of that, as they're walking around, every time they're putting their left foot on the ground, it's telling a different story to the brain to when they're putting the right foot down on the ground. So the hemispheres aren't working really well together. They find it very difficult to inhibit one leg and move the other leg, and vice versa. Standing on one leg with their eyes open is quite difficult for them. Standing on one leg with their eyes closed is almost impossible to begin with. So we have, like I said, these baseline measurements, and post-neurophysics therapy, after a few days, we go back and without any practice with any of these movements, we go and test that again. And we commonly see that these people have been able to improve quite significantly in these particular areas. So a little bit of a summary of the lens to view Tourette syndrome with that we've used through the approach set. So for the sake of viewing TS through the lens of a complex adaptive systems and chaos theory, psychology and nonlinear dynamics perspective, we respectively put aside all the existing medical research and information, protocols presently available on TS, and then we ask the question, what are we actually looking at here, and what do these random fluctuations, these tick events in these systems inform us of in relation to the state of the system and its relationship with the environment? So it's been well and truly identified that living complex adaptive systems are scale-free systems and fractal physiology, and what occurs at one scale of the system occurs at all other scales of the system, from the macro through to the micro at any point in time, space-time. And the relationship between events occurring in living and non-living complex adaptive systems, and other than human beings, and the events that we are interested in here at any point in time are also scale-free. And we'll be discussing that, the relativity between the connection we see with dynamics that appear pre-earthquake and earthquake, and how they present the same with people with epilepsy. So what we see, complex adaptive systems, the premises of it all are sensitive to their internal and external initial conditions, where tiny influences can have a major effect, and the basic thing of the chaos theory with the butterfly effect. So we're looking at some initial conditions back there before, when we're looking to take some baseline measurements, and we would say, okay, well, the events that are taking place in the system are very sensitively dependent upon what we've just seen. The idea is that if we alter these initial conditions, then it's pretty much like changing the algorithm, so to speak, that's giving rise to these particular states. So we somehow need to be able to perturb the system in a very structured and prescribed manner to be able to then allow and dispose of that noise, and to allow these new sets of initial conditions to give rise to that. And the famous Rule 30 over there from Stephen Wolfram, who was messing with that back in the early 80s, when he decided to let that Rule 30 just run the program, and started to see that it moved into a chaotic state. And as time went on and got up to, eventually they started to see the patterns that we see typically on shells and snowflakes and leaves perform. So it basically described the fact that nature doesn't need to have complex rules to generate complex patterns. All we need is some very simple rules, and that's what we've always been looking at through neurophysics therapy, having some simple rules to be able to look at, to view the system through, understand how the system is interacting with its environment, and what do we need to do to perturb that state if necessary, to allow from those new sets of initial conditions to bring about more favourable states within that person's system. So as we said here, we are actually looking at what we're actually looking at here through the, we ran down the wrong way. So baseline here, first we sense and then we perceive. So is the tick event either a rogue sensory percept that the individual has made, or a rogue motor response, or both? So we're looking at a sensory system. Are we looking at a sensory systems defect, a motor system defect, or both? So for the human being, perception means everything. How we perceive our world frames and organizes how we respond to it behaviorally. So if we need to alter behavior in any system that displays rogue characteristics, basically we need to alter perception. So we have over here one of the more interesting patients. So the top two channels, there's some of the data from that. The top two channels are EMG, which we'll put on the left and right trapeze. The middle two channels were left and right abdominal wall, just adjacent to the navel. The bottom two channels, the next two channels were the adductor process. So we're targeting these sensitive, vulnerable regions of the system. And then we have the ECG there, of course, and the EEG at the bottom there. So we could see the lead-in. So this was the person at rest before, seated at rest before neurophysics therapy. And we've seen the events occur. So as time went on, so this was a 15-second event that, because of the person was a little bit anxious, and it started to display this. But what we actually see there as it's taking place, it was a systems-wide event. So even though it predominantly was displayed outwardly through the neck and shoulders and the head and shoulders, we could see that it was taking place at all other levels through the abdominal wall and the adductor process at the same time. So that was very interesting, and it was very good information to be able to have. So as I mentioned before, the resting state of the brain is chaotic, and that's been well and truly studied and determined. And it's when the brain becomes less chaotic, that's when pathologies begin to emerge. So we're seeing on the right there some of the work of Lapamides and co. Back in the 90s. They had probes in these patients' brains who were in hospital because they were trying to identify areas of the brain they could create a lesion to inhibit, to stop these poor patients from having so many seizures. So there's basically five probes put in there, hence sort of different colours. And what they noticed about 50 minutes before the seizure would occur, the areas of the brain, these areas of the brain would become highly synchronized. And we're seeing that down at this bottom section here. And then the system would release that excess energy through the seizure itself. And that would enable it then to be able to return or get back into something would be a more normal state. So it was the system's way basically of disposing of the over-orderliness. So we're positing that these TS-affected systems are essentially over-orderly, regardless of what the title of their condition is. So these tick events can be considered micro versions of much larger scale events, such as an epileptic seizure. So we're looking at the dynamics up the top up here, and we've sort of seen that there was a high level of synchronization through the EEG, EMG components there that led to the sudden release when the tick event was occurring. And the tick event is the system's way of disposing of its over-orderliness. And that's what we were sort of focusing on, having that view. And what I said was interesting before was the fact that these long-term, very extensive studies have been done, and we see this data, comparative data to an earthquake. We see that it follows the same parallel distribution. So the seizure up on the top there is the red, and of course we have the blue for the earthquake there. When you overlay those two series data, we see it very following the same pathway. So the study involved lots of sensitive areas around the world, and the frequency of, so quite a few patients were involved in that study. And on the right there, we have some EEG of one of our patients who had chronic epilepsy. And this was, again, sitting at rest. So we see very high levels of synchronization before pre-neurophysics therapy in the 4 channels of the EEG that we took. And then post-neurophysics therapy, we've seen that that was all pretty much stable. And one of the other professors was presenting his data in the first presentation and displaying very similar pictures. So noisy inputs infer noisy outputs. So we're talking, the inputs would be our sensory system. So if the perception of the environment is hostile, I guess, in some ways, that's what the perception is, then it's going to inhibit the systems from its functioning in a proper way. And that's when the onset of that over-orderliness would become from. So it's observed in these patients that increases in anxieties levels increase the frequency and the velocity of their tick events. And we can provoke those events to occur by simply making the person more anxious or creating some type of perturbation. So we can see that the influence there that the limbic system has, the basal ganglia, and in particular the amygdala's direct influence on the brainstem, etc. And so neurophysics therapy involves, self-controlled hormesis-like perturbation to the system. So we've got to be able to sort of create a situation where we're most likely going to generate those type of behaviours, but at the same time, allowing the person to, instead of trying to inhibit those dynamics from occurring, just to let them go and try to increase them, just let them go and let them do what they need to do. Because most of the time when people have the tic events occur to them, they become quite anxious and concerned about it. So we're trying to coach them into not being concerned about it, just to let them go. And they really do start to reach a very high dimensional state. And then as time goes on, they start to settle into a much more steady state where we can perturb the system once again, and those type of events do not occur. So they're much more robust, and they find that out in the real world then they can navigate the real world in a much more orderly fashion and not have to be so concerned about these tic events just suddenly increasing, because they've learned to be able to control their arousal quite significantly in many different ways. So it's always treat the person and not the disorder when it comes to neurophysics therapy. So we need to correct sensory perceptual errors to elicit systems-wide improvements, and focus on working through what we call the grids to dispose of the sensory noise. So the particular exercise machines, they supply what we refer to as a background grid. So we can measure at any point in space-time effectively how the person is interacting and responding to the environment. And we can sort of see where there's perhaps overreactions to it, because given the conditions where they're in a safe, supported environment, there's no lions running around the room or anything like that, of course. They have all the control. All they're being asked to do is relax and go very slowly through these movements. And that's when we start to see these errors occurring, because sometimes they might be presenting with some fear and anxiety, which is all associative experiences that their system has had that it's referring to. And they have to learn to detrain those type of responses, because those responses are giving rise to, this is how their default is, this is how they're interacting with their environment all of the time. So they need to detrain those type of movements. So here we have that patient again, we presented in the first instance. So day 1 at rest pre-neurophysics therapy, then day 2 at rest pre-neurophysics therapy, and then day 3 at rest pre-neurophysics therapy. So we started to see that things were starting to look a lot quieter for that particular person. So that's my presentation, and I hope that you enjoyed that. And again, I'd sincerely like to thank the organisers of this event for giving us the opportunity to present. And many thanks to thousands of patients who've trusted in my methods over the many years, who've all contributed in some way to the making of neurophysics therapy where it is today. Thank you very much.
Thank you so much for that overwhelming speech. Thank you so much, Professor Kenware. Next, let us welcome our next keynote speaker, a practicing neurologist in Agra for 14 years. He has done DM in neurology from SMS Medical College, Jaipur. Has publications in national and international journals, presented various papers in national conferences, has special interest in neuro-ophthalmology, headache, and epilepsy. Let us welcome Dr. Vinay Agarwal. Morning, sir.
Good morning. Am I audible?
Yes, you are.
And the screen share option, is it?
Yes, I can see Zoom United. Yes.
Yes, now the presentation is visible to all?
Yes, it is. Please proceed, Professor.
Good morning, everyone, and thanks for presenting my clinical work on this platform. Thanks to organizers. Today, I will talk on rare clinical presentation associations of PRESS. PRESS is a short form for posterior reversible encephalopathy syndrome, which was first described by Henshay et al. In 1996 in his 15 patients. The common clinical manifestations of PRESS includes headache, altered mental functioning, seizures, and visual disturbances. The incidence of neurological signs and symptoms and questions in posterior reversible encephalopathy is, as the name itself says, encephalopathy is quite common, and altered sensorium. These two are the hallmark of this clinical condition. Fluctuations in blood pressure is seen in about 75 to 80% of patients, usually rise in blood pressure. Epileptic seizures is seen up to 75%, with up to 13% patients may have this status epilepticus. About 67% patients have visual disturbances, which may be in form of blurring of vision or hemianopia or visual field defects and even cortical blindness. Headache is also a very common presenting feature of this clinical condition, seen in up to 50% of patients. And focal neurological signs are very rare, like hemiparesis or weakness. This cranial palsy is very rare. So, it is basically a diagnosis with clinical features as well as imaging. So, neuroimaging is very characteristic, which reveals extensive bilateral white matter edema, which is which is predominantly in the posterior regions of the cerebral hemispheres. Although rarely, it can also be seen in other areas of brain like cerebellum and brainstem. So the uncommonness of this condition is not very common, and varied presentations makes it difficult to identify. Apart from the posterior location and subcortical involvement, there can be involvement of frontal lobe, basal ganglia, brainstem involvement, and rarely hemorrhage with reversible restricted diffusion have also been described in PRESS. These are the imaging MRI of the patient of posterior reversible encephalopathic syndrome, in which there is showing Day2 and flared hyperintense lesions, mainly in the posterior, this occipital and posterior parietal region, and mainly in the white matter, sparing this gray matter, which is characteristic of this condition. This is also known as hyperperfusion encephalopathy, brain capillary leak syndrome, or reversible posterior leukoencephalopathy syndrome. But now, the most commonly it is known as posterior reversible encephalopathy syndrome, which we call PRESS. Pathologically, it is thought to occur due to acute rise in blood pressure. When the rise in blood pressure overcomes the autoregulatory capacity of the cerebral circulation. That is, when the acute rise in blood pressure overcomes the cerebral perfusion pressure and the brain pressure balance, then there is leakage of fluid in the brain, predominantly in the white matter because of the less density of fibers in the white matter, and also more commonly in posterior circulation because the autonomic nervous system is less rich in the posterior circulation. So auto-regulatory mechanisms are less developed in posterior circulation than anterior circulation. So the imaging changes which we see are due to these two factors, that is subcortical in location and posterior location. But in up to 30% of patients of PRESS, blood pressure is not raised, and still we have changes of PRESS, both clinical and radiological. So other mechanisms have been postulated, of which endothelial dysfunction is important mechanism, which can caused by either the exogenous cytotoxins or endogenous cytotoxins. Endogenous cytotoxins as in sepsis or eclampsia, and exogenous cytotoxins as in chemotherapeutic agents. These called endothelial dysfunction, which leads to disruption in endothelial barrier and leads to seepage or leakage of the fluid. And apart from this, sometimes there is vasoconstriction, which leads to localized rise in blood pressure. There are several common clinical conditions which are associated with PRESS, most common being preeclampsia and eclampsia, sudden rise in blood pressure, immunosuppressive drugs like cyclosporine, tacrolimus, high-dose steroids, chemotherapeutic agents like cisplatin, carboplatin, cytarabine, methotrexate, autoimmune infections like SLE, renal disease, renal transplantation, and sepsis. These are the common clinical conditions associated with breast. As such, there are no established diagnostic criteria, but the suggested diagnostic criteria are neurological symptoms, as we have reviewed, in which there is predominantly features of encephalopathy plus visual disturbance. Imaging showing vasogenic edema, mainly in the posterior location and in subcortical region, and reversibility of clinical and radiological findings on treatment. Differential diagnosis is vast because of its various clinical presentation, like venous sinus thrombosis. Particularly, venous thrombocytosis is also very commonly associated with in postpartum patients due to anemia, sepsis, and dehydration. And breast is also commonly seen in preeclampsia and eclampsia. So it is an important clinical differential diagnosis. Then subarachnoid hemorrhage, intracranial hemorrhage, CNS infections, various autoimmune encephalitis, metabolic, toxic encephalopathies. These all will present in a similar manner as breast. Radiological differential diagnosis includes venous sinus thrombosis, posterior circulation, and reversible vasoconstriction syndrome. Early recognition and treatment are important to prevent neurological sequelae because if identified earlier, it is curable and both the clinical and radiological features are reversible. Now, after reviewing briefly about breast, here we will discuss very rare associations of breast, three very rare associations. So my first case is a 16-year-old female which was taken to local physicians for complaint of recurrent abdominal pain and behavioral abnormality for 2 months. She had a history of 2 episodes of generalized tonic-clonic seizures with altered sensorium, which lasted for 2 days after the last seizure. At that time, her plain CT was done, which was normal. She was normotensive according to the records. She was put on phenytoin and antitubercular drugs by the physician. After this episode, 1 month later, she presented to us with altered sensorium for last 3 days with severe abdominal pain. On examination, she was confused and disoriented with no focal neurological deficit, no meningeal signs, no abdominal tenderness, and no history of fever. Since her CT was done a month back, so we got her contrast MRI done, which showed changes which we have reviewed previously, typical of breast, and there was no diffusion restriction on the images. So we have a young female with abdominal pain, behavioral abnormalities, seizures. So we thought of porphyria, and her urine also turned dark on exposure to sunlight. The biochemical evaluation also reveals elevated level of urinary porphyrobilinogen and aminolevulinic acid. She was given a carbohydrate diet and IV glucose, to which she responded dramatically. At our center, we tried with IV glucose, although the treatment of choice is IV heme, but she responded very well to that only. Porphyrias are inherited metabolic disorders which are usually autosomal dominant pattern, maybe sometimes autosomal recessive or sporadic very rarely. And the porphyria may be either hepatic porphyrias or erythropoietic porphyria. Acute intermittent porphyria, the most common type of porphyria, and the neurological symptoms are also very common in acute intermittent porphyria. It's a type of hepatic porphyria. It is pattern of inheritance is autosomal dominant, and it is caused by deficiency of HMB synthetase enzyme in the heme biosynthesis. So, which this enzyme deficiency in the heme biosynthetic pathway leads to elevated level of porphyrobilinogen and aminolevulinic acid. These are the various types of porphyrias which are caused by defect in the gene at the various levels of the enzyme in the various levels. The most common is acute intermittent porphyria. In almost all the porphyrias, which are commonly seen clinically, leads to elevated level of porphyroglutagen and amyloidoglycolic acid, which helps in confirming the clinical diagnosis whenever it is suspected. So the neurological manifestations in porphyria may be acute neuropathy, which is usually axonal, pure motor, and proximal, mimicking GBS. So an appropriate clinical setting whenever porphyria should be ruled out in the case of GBS. And encephalopathy, which we have already seen various features of encephalopathy, like altered sensorium, seizures, headache, all these. There are various reasons from encephalopathy apart from PRES and porphyria. It may be direct effect of toxins with no neuroimaging changes. It may be due to hyponatremia, which may be due to diarrhea, vomiting seen in porphyria, or it may be due to hypothalamic dysfunction directly caused by porphyrin toxins leading to hyponatremia. So the neurological manifestations are mainly neuropathy and encephalopathy. Our patient had predominant features of encephalopathy. What are the various hypotheses of posterior reversible encephalopathy in porphyria? The first and foremost common is hypertension during acute episode may exceed autoregulation and will lead to vasogenic edema. Severe deficiency of heme may lead to decreased production of nitric oxide synthetase. Subsequently, vasodilatory effect of NOS-derived nitric oxide is lost, leading to localized vasoconstriction, leading to localized rise in blood pressure, and leading to PRES. Excessive porphyrin precursors may cause direct endothelial damage, followed by breakdown of barrier leading to PRES. So these are the various hypotheses of PRES in porphyria. So the learning points in this case is, first, we should think of porphyria, especially when we have a history of encephalopathy associated with abdominal pain, recurrent neurological deficit, behavioral abnormality, and we don't have any localizing feature or local tenderness or any feature of sepsis. Certain drugs, as in this case, in our case, she was put on anti-tubercular drug and phenytoin, may worsen porphyria because of their enzyme-inducing properties. So we should always avoid these drugs. And we should know that PRES can be seen in porphyria without hypertension. So, from therapeutic point of view, non-enzyme-inducing drugs like levetiracetam is the choice of anti-epileptic drug in porphyria, rather than enzyme-inducing drugs like phenytoin, carbamazepine, and phenobarbital. Our next case is a patient, a 50-year-old male, presented with acute onset flaccid paralysis, generalized seizures. He developed generalized seizures, altered sensorium, raised blood pressure on 5th day of illness when he presented to us. His illness started 5 days back. After seizures, he did not regain sensorium and remained dull and drowsy. So we got his MRI done, which was typical of PRES. In view of his flaccid paralysis, acute onset of 5 days duration, CSF and nerve conduction study was done, which was suggestive of this GBS or acute inflammatory demyelinating polyneuropathy. Secondary causes, especially vasculitis, in view of his imaging changes in PRES plus neuropathy and porphyria were ruled out. Initially, patient was treated with anti-epileptics, anti-edema, and antihypertensive, to which he responded very well. And after the resolution of encephalopathy, IVIG was started, IV immunoglobulins, for his neuropathy. So we have a patient who had clinical features of GBS with posterior reversible encephalopathy, who was treated nicely with anti-edema drugs and then followed by IVIG. So it is very rare, both the diseases, both GBS as well as PRES, and their association is still rarer. GBS predominantly affects peripheral nervous system without affecting sensorium, but it can sometimes affect sensorium when the hypoxic brain damage secondary to respiratory paralysis may lead to hypoxic encephalopathy. Our patient had altered sensorium without respiratory involvement, and MRI was suggestive of rest. Rest may develop after IVIG in GBS, but it developed in our patient without being given, he was being given IVIG. What is the proposed mechanism of this rest in GBS? First is autonomic dysfunction leading to acute rise in blood pressure, activation of sympathetic nervous system secondary to pain, which can also lead to rise in blood pressure and leading to stress. IVIG therapy will discuss later, and sometimes renal decompensation. So we should be aware of this lower coincidence of GBS and stress, and we should know that GBS is an independent risk factor of stress. Catecholamine levels correlate with dysautonomia in GBS, so it can be used as a biological marker. Catecholamine level can help us figure that which patient will develop complications secondary to autonomic dysfunction, of which stress is one. Both plasmapheresis and IVIG can be used to treatment, but it needs further research in any difference in outcome in stress with GBS, whether it is treated with IVIG or plasmapheresis, because IVIG itself is an independent risk factor for post-irreversible encephalopathy syndrome. So theoretically, plasmapheresis looks a better option in such patients. The last case is as a 5-year-old child who presented with ascending weakness of 5 days duration. Clinical electrophysiological study was suggested of GBS. Secondary causes were ruled out, so they started with IVIG, standard dose. On 5th day, he became encephalopathic with no neurological deficit, no fever, no meningeal sign, and no preceding history of headache. So we got his MRI done, which was to our surprise, was showing stress. He was given anti-edema drugs. His IVIG was holding the IVIG, and anti-edema drugs were given. And then once his encephalopathy resolved, we referred the patient to another center for plasmapheresis. So GBS association test, IVIG is standard treatment for GBS. Common side effects of IVIG are myalgia, headache, nausea, vomiting, fever, anaphylaxis, thromboembolism, and aseptic meningitis. Neurological side effects include headache, which is very common, aseptic meningitis, where we should suspect it whenever the patient is complaining of headache which is not resolving to analgesics and showing features of meningeal irritation, and CSF is done to rule out infectious cause. Rest is a rare side effect of IVIG, and rarely episode or palsy have also been reported with IVIG. Probable mechanism of rest of IVIG is vasogenic edema, cerebrovascular endothelial dysfunction, cerebral vasospasm, serum hyperviscosity, intravascular hypercoagulopathy, and platelet hyperactivity, and role of cytokines like interleukin-6 has been proposed as probable mechanisms of rest caused by IVIG. Right. So, suspect posterior reversible encephalopathy syndrome if patients develop neurological features after IVIG with disease typical MRI findings, that is posterior subcortical T2 and flare hyperintense lesions, and clinical manifestations of encephalopathy. So, to summarize my presentation, we should know when to think of porphyria. We should think of porphyria whenever there is a recurrent neurological illness of either CNS involvement or peripheral nervous system involvement with behavioral abnormality, and we should always test for urine for porphyria precursors, which helps us in clinching the diagnosis. We should know when to get brain scan in a patient of GBS. Apart from hypoxia, there are other causes like IVIG and autonomic dysfunction in GBS, which can involve brain. Therapeutic implications are there because the treatment is different, especially although there is no final consensus, but whether plasmapheresis or IVIG, which one is better, this needs further therapeutic or clinical trials. Thanks.
Thank you so much, Professor. Next, let us welcome our next keynote speaker. He has an extensive experience in the field of neurosurgery and spine surgery. After graduation in 1978, he proceeded to the United Kingdom to be trained in neurosurgery. After completing FRCS, he trained as a registrar in neurosurgery at the National Hospital for Nervous Diseases, London, and the Nottingham University Hospital. Senior registrar training was at Frenchay Hospital, Bristol, UK. Subsequently, he did a spine fellowship at the Royal National Orthopaedic Hospital, Stanmore, London. He has also obtained an FRCS in neurosurgery and was put on the specialist register for neurosurgery of the General Medical Council, UK. He returned to India to join the Indraprastha Apollo Hospital, New Delhi in August 1996. He has been in the field of neurosurgery for more than 35 years, since 1979. And continuously after postgraduate since 1983. He has set up a reputation for himself, particularly in the field of spine surgery. He is the Honorable Medical Director of Indian Head Injury Foundation, for which he conducts all the medical activities and educational programs. Let us welcome Dr. Rajendra Prasad. Morning, sir.
Morning. Thank you for your very extensive introduction. It's almost embarrassing, but thank you. So I'm going to share my screen now. And okay. Can you see my screen?
I can now. Yeah, we can see your screen. Please proceed.
Okay. As Jojo said, I've done this for 40 years now, but spine surgery is my specialty. And only in the last 10 years did I really focus on the causes of back pain. So we all treat back pain. And but recently, as I said, in the last 10 years, I've looked at sacroiliac joint as an area of interest and lumbar facet as an area of interest for back pain. Now, why am I presenting it to a mixed audience of neurologists and neurosurgeons? Because when we fail as surgeons to treat back pain, they would go to a neurologist, they go to your general physician. And so I thought that this area that even me as a neurosurgeon, it took me a long time to think that, listen, if back pain isn't getting cured, could it be because of the sacroiliac joint and the facet joint? So that's the introduction. And so now, why am I not moving to the next? Can you hear me?
Yes, okay. We can hear you.
So now, today's presentation covers the role of lumbar facet joint. So like joints in the back, joints in the limbs, those are big joints, knee joint, ankle joint, hip joint. But the facet joint, we don't take care. So we are all moving our neck, we move our lumbar spine, and we move because there are joints. So just like everybody has knee pain at some point in their life, you will have back pain at some point in your life. And arthritis of the lumbar facet joint, enough is not paid attention. So we talk about hip joint, knee joint, elbow joint, shoulder joint, but we never talk about the spinal joints. And that is a cause, as I said, in the last 10 years, I've focused a lot of back pain may well be related to that. And I found it is. And another very ignored joint is the sacroiliac joint. So we're going to talk today a little bit about those as a cause of failed back syndrome. Failed back syndrome is generally syndrome that happens after surgery has failed to cure. We'll talk a bit about that. How do you diagnose facet pain and SI pain? I'll tell you my experience over the last 10 years of 315 patients, that of all the patients who turned up for my back pain clinic in 10 years, 315 I thought had sacroiliac and facet pain, so I chose them. I'll discuss that. I'll review a bit of the literature, some case studies, and what are the conclusions. So SI joint, before MRI was well recognized as a source of back pain, sacroiliac joint as a source of back pain. And Mixter and Barr described this in 34. And for many, many years, 50 years, we were looking at SI joint as a cause of back pain. Then came MRI, and that was the biggest disservice. Of course, it had a lot of advantages, but there has been some disservice in terms of back pain. Now, if you look at this, it is a bulge, and a regular neurosurgeon, orthopedic surgeon would say, this is the cause of your pain, of your back pain. Well, it may be, it may not be. And if it isn't, then you've had unnecessarily back surgery. And so that there is that problem, that there is this which people of my age or even younger are going to have disc bulges, but is it contributing to pure back pain? We're not sure of that. And particularly if there is no leg pain to go with it. So we need to be sure on examination. And because of this MRI and these disc bulges that have been shown on MRI or degenerative disease, there's been a lot of lumbar spine fusion cases, and in the 90s and even now. And year on year, there's been an increase in fusion surgeries, particularly in US and Europe. And now we are following them like most things. And we are doing a lot of spinal fusion surgeries. And so we are having a lot of failed back surgery, because if your pain is because of sacroiliac joint, your back pain, then putting these screws is not going to help this pain. So SI joint is very underdiagnosed as a cause of back pain, particularly because MRI shows disc bulges. Now, SI and facet pain, these are important cause of failed back. Lumbar fusion surgery, what happens is when you fuse the spine, a lot of stress then comes, like in a multi-jointed system. If you fuse some of the joints and you still want to move, then the stress will come on the joints above and below. So what is below L5S1? Below and to the side is the sacroiliac joint. So if you're going to fuse and put screws in multiple segments of the joint, then the joint above and the joint below, which in this case is the sacroiliac joint, is going to get affected by adjacent segment disease. Now, adjacent segment disease is a disease of segments adjacent, above or below. Now, SI joint, we've totally ignored in our medical education. It's not enough stress is given during anatomy or surgical anatomy. And then subsequently, when I trained to become a neurosurgeon, in UK and whenever, nobody told me that this is an SI joint patient, pain patient. Can you treat it this way? So it was left to myself that when I saw a series of patients that I SI joint, it's a cause of your pain. And if you have lumbar fusions done, then 1/3 of them, according to the literature, is going to get sacroiliitis, not sacroiliitis as we know it with HLA B27 positive, but sacroiliac pain, 1/3 and even more. And, it's not, suppose you have SI pain and you end up fusing the spine because you feel the spine is the cause of the pain, the disc, then you've done a great disservice, because the complication rate of fusion surgery in the literature is 10 to 24%. And there are some series with 31%. So if you're doing an unnecessary surgery, you better do it without any complications. Not 1/3 of them will turn out with complications. Now, how do you diagnose? So now they come to you. I'm not talking about acute back pain, that 3 weeks, 4 weeks, those are muscle pains. Those can come and go. And everybody gets some back pain sometime in their life. But when they come to a spine clinic or they come to a neurologist, these people have been finished with their acute pain, they still have pain weeks and months later. So I appeal to you, to the audience here, that think, is this coming from the facet joint? Is it coming from the SI joint? Is it coming from the muscles of the back? Is it coming from the disc? Is it coming from the vertebra themselves? So if as I found in many of my cases, they're coming from SI joint, this is the typical 14-finger test. They'll tell you posterior part of the superior within 2 centimeters of the posterior iliac spine. They will just point that this is where it hurts when I get up from a chair, or particularly when I'm turning in bed. If you ignore that and you then say, okay, now let me look at your MRI, and your MRI shows this, that, and I'm going to operate, that operation is going to fail. So a sacroiliac joint or facet joint, which are joints in the spine over here, the patient will point that this is where, and when you press on those joints, there will be tenderness on those joints. In the sacroiliac spine, it will be here, or along the SI joint, the tenderness may be there. The history will be when I sit for long periods, my back hurts. When I stand for long periods, my back hurts. When I do extension of my spine, my back hurts, which means the facet joint gets crunched and you get pain. Or when I'm turning in bed, if it's SI joint, invariably, most people will not ask that. Do you have pain when you're turning in bed? And they say, yes, I can't sleep because when I turn, I get pain. And so that's how you diagnose it. And typically, on examination, there are some provocation tests, the Faber's test, and which is abduction and FABER test. We can do that. But for me, the history, the tenderness, and then the final test is the block. So if you give a local anesthetic and it takes the pain away, that means that is the source of your pain. So it can be, so I check for tenderness on the facet joint and the SI joint. And I wasn't doing that till 10 years ago, that I was actually touching the patient back and saying, listen, show me exactly where your pain is. And in most cases, it would be off the midline to one side along the SI joint, many cases, and some along the facet joint. And people would say, okay, let's do an X-ray and see. Well, the X-rays in these cases will be normal in a majority of cases. Unless you have chronic sacroiliac disease, you won't find sclerosis. CT and MRI will not show anything in the facet joint. It may show some sclerosis, but many patients will not show anything on CT. MRI may show in facet joint, you may show hypertrophy of the facet joint, but in many cases, it may not show that, but many cases will show hypertrophy of the facet joint, but SI joints will be normal on MRI. It may be normal in most cases. So what are the pain generators in the back? So you can come from a disc if you have a malignancy, if you have TB, if you have osteoporosis. It could well be coming from the vertebral body, but most cases, and disc, if the disc is involved in degenerative disease, it could be the source of back pain. And leg pain, we think, is entirely from disc pressing on the nerve. That may not be true, because I have found, and so does the literature say, that sacroiliac joint pain can occur up to here, halfway down the leg, up to the thigh, and in some cases, even up to the ankle. And that's what I found in many of my cases, that pain was radiating down the leg, and which was termed as sciatica. And if the MRI showed disc bulge, then that would get operated. So don't get me wrong. There is, I do treat disc disease and a lot of disc disease. And with sciatica, I'm talking about the group of patients who don't fit into nerve root compression on MRI, don't operate on disc bulges just because there is a disc bulge. You have to examine the patient, or it could be myofascial. So leg pain can be because of disc bulges, and it could be because of facet joint pain or SI joint pain. Facet joint pain typically would not go down the leg so much, a bit of the thigh, but mainly it comes anteriorly to the groin. And if patient says, I have back pain radiating to the groin, to the scrotal area, think of facet joint. And so in everybody doesn't end up with sacroiliac. If you have diagnosed SI pain, most of them will be treated conservatively. And so you need to think about that. And they don't need lumbar surgery. They need SI belt. They will need special SI exercises, which are different from lumbar extension exercises. And then we will treat them with blocks. And if you want to have a lasting effect, diagnostic block is just with bupivacaine. If you want a lasting block, you've got to add depomedrol, a steroid, and its effect may last for weeks. And then you may have to repeat that if that is the only option. I choose to give blocks, and then I do radio frequency, as with this patient here. And in my large series of more than 250 patients, the relief is for up to 2 years, some even more, some slightly less. So you don't need surgery. You can do, most of them will settle with conservative treatment. Those who don't and who've had physio, who've done their exercises, worn their belt, they don't get better, then they end up with blocks or radio frequency rhizotomy subsequently. So I looked at my 300 cases of chronic back pain, who I thought were because of facet or SI joint. Not all back pain, there may have been thousands I saw in 10 years, but 300 of them with chronic back pain, because on clinical diagnosis, they were facet joint or SI pain. So pure SI pain I found in 30% of cases. So I gave blocks only in 30%. But in a majority of them, they had both sacroiliac and facet joint pain. So these are patients who did not have disc disease, did not have muscle pain as a cause of pain, but they had sacroiliac joint plus facet joint. And if the block helped, and because blocks, like a dental block, a dentist gives you a block, it can only last for so long. A radiofrequency ablation of the nerve will last longer. Now, what I want to share today with you, the rest of the talk, is about lumbar surgery, lumbar fusion, that of these 300 cases of sacroiliac pain and facet pain, 75, which is 25%, 24% of them had lumbar surgery. So here I was thinking, okay, pure SI joint pain, pure facet pain is an isolated incident. It isn't. In 25% of cases, it is secondary to some surgery. It's a failed back surgery syndrome. They will come to a neurologist, they'll come to a neurosurgeon, orthopedic surgeon as failed back. Now, what are the type of lumbars? What type of lumbar surgery contributes to sacroiliac pain or facet pain? So we looked at this 75 cases and we found most of them were fusions, but not all. Some even after microdiscectomy a few weeks later will present as sacroiliac pain and leg pain. And you'll think, oh my God, my disc has come back or I didn't remove enough. But if you examine, it may well be sacroiliac pain or facet pain. Some of them will be because of following discectomies or laminectomies. That is a standard procedure for this surgery. So it can happen after that. So in my 75 cases, majority of them were following fusion. Because as I said, if you fuse the spine, the level above and below is going to take the stress. And don't get me wrong, there will be cases that need fusion. I'm not saying don't fuse parts of the spine that has injured, that has had a spinal injury, or parts of the spine that has TB or tumor. You will need to fuse it. But what I'm saying is, if they continue to have back pain or if they have new back pain, please focus on the sacroiliac joint or exclude it as a cause of pain. And please look at the lumbar facet as a cause of pain. And how many levels? So you think the more we fuse, the more pain would happen? Not necessarily. In our series, the majority of them have had 2-level fusions causing pain. Now, so today I have had a spinal injury, and tomorrow I've had a fusion. So if I were to develop facet pain of adjacent segment, or if I were to develop SI pain, when would it happen? So I looked at my 75 cases, and even in the literature, it can happen anytime, within a year, after a year. After 5 years, it can happen. It's there in the literature up to 15 years. And some of mine were up to 12 years. So 12 years after fusion, a person comes, says, I have back pain, and we say, oh, okay. And what is a standard procedure for such pain? Extension of the fusion. So you make it worse. Like most surgeons, spine surgeons, if they're not looking at the sacroiliac joint, if they're not looking at the adjacent facet joint and treating it with radio frequency, they will just put more screws above and more screws above, and then above and below, and then the patient has more fusion and more pain. Now, those that have come before 1 year could well be that it was an SI pain to start with, and you did surgery. So the patient will have persistent leg pain even after surgery. So those pains that happen immediately after your spine surgery, just think, was it any different, this pain from before, or is it a new pain? If they say it's the same, then you go back and look and see whether you've got the diagnosis wrong. And MODI is a Oswestry Disability Index, and you can see a score of very, very high on these patients. And as soon as we give the blocks and do the radio frequency, they come from maximum disability to minimum disability if you've got your diagnosis correct. So some case examples, and I was really surprised that this lady came from somewhere and a spine surgeon decided that, it's not good. Her spine is moving and that is the cause of pain. So even though her MRI showed only an L4-5 stenosis, so he did do a L4-5 decompression, but he put an L2 to S1 screws for her back pain. And to be fair to him, he put in dynamic screws. So they put a band, they put screws, they put a band which allows you some degree of mobility, but her pain persisted. So when she came to me, I looked and I said, look, this is SI pain, this is facet pain. This has nothing to do with these screws or nothing to do. So I did a block of the SI joint and her pain disappeared. So she's had pain since 2016, and 2019, I do a block and her SI joint block and her pain disappears. And then I just removed all the screws, allowed her spine to be mobile, and from a crippling state on MODI, she became with minimal disability and remains well 2 years later, just with treatment for SI pain by radio frequency. I've removed all the screws and she's still doing well. She hasn't come back. This patient of mine had a microdiscectomy, and I then happened to be traveling abroad and got a call that, oh, he's got severe pain. And I said, oh my God, I thought I did a good disc clearance. And we did an MRI and it was clear. And we examined, I came back, I examined him. He had sacroiliac pain, which resolved with physiotherapy. He didn't need more surgery. He just needed physiotherapy. It's settled. Now, this patient of mine was 130 kilos and severe back pain. He had both anterior and posterior surgery. His problem at that point went away, but 2 years later, he came back with sacroiliac pain, and I had to give him blocks and radio frequency, say 14, in 18, in 19, and now he is well 2 years later. It has nothing to do with the screws. It's just that those screws contributed to adjacent segment disease. So as neurologists, as neurosurgeons, I appeal to you that if somebody has had surgery and has failed to relieve his leg pain or back pain, look at the sacroiliac joint. There's enough in the literature, like this paper published in Pain Medicine in 2011. It showed that they took all patients that they did fusion on between 2007 and 2009. And of the 130 patients, 16% were after 2 blocks. So they gave blocks, not like me once, but 2 blocks. Some even give 3 blocks to be certain SI joint is the cause of pain. And 16% in their series had SI pain as a result. And then again, another paper in the Journal of Spine Surgery, 317 patients, again, 12%. This is from a major center in US. After several 2 blocks, they found that yes, 12%, but I suspect it will be higher if the if they just use one block and, the way I've been just keeping it simple, just identify your pain source, point your finger, do one block, and if that's the cause of pain, proceed to RF. Then dysfunctional sacroiliac joint following lumbar discectomy. So even if you, as I showed you, even if you've had a discectomy or a laminectomy, you can still have pain. So this paper in Journal of Orthopedics, Trauma Surgery, again, highlighted the same point. And then even you thought, okay, we won't do laminectomy, just with pedicle screws. We were treating this patient, and then they reported a case report that even after pedicle screw fixation, just percutaneous fixation, how can somebody develop sacroiliac syndrome, joint pain syndrome? Well, they did, because they fused L5S1, whether percutaneously or open. If you fuse the L5S1, there is a chance, 30% chance, at least between 20 and 30% chance, that they will develop sacroiliac pain. And then another paper which says, when you have lumbar stenosis, you are stooped, because that is a position that one finds comfortable. You bend forward, and at that position, the SI joint takes a strain, the facet joint takes a strain. So if, as in paper in CNS, presented at their annual meeting, they suggested that if you are a stooped position, you may have SI joint pain, and it can improve rapidly. That may improve rapidly after decompression if you're keeping an upright posture immediately after surgery. But if you don't, it may still be a cause of pain. So you have lumbar stenosis, very good surgery, decompression, resolves pain in majority of cases, 95% cases. Some patients, if they don't get an erect posture back, they will develop SI pain. And similarly with pain management, there's an update in Seminars in Spine Surgery which says diagnose it with the history, and then use blocks, use radio frequency, and you will take care of a majority of these so-called failed backs. So as I was showing, MRI, this patient had surgery, he had pedicle screws, T-lip cages. Is it really necessary? In some cases, like in this case, it wasn't, because even after that, he had SI pain and needed intervention. Or this patient who went on to have a lumbar disc replacement, huge, major operation. I do that, but I do it for the right case, I think. And these cases, all these screws put in, and then diagnosed as SI pain, and then at subsequent surgery, many years later, somebody put SI sacroiliac screws. Somebody put imagine somebody who started with SI pain should have had just physiotherapy or blocks or radio frequency, starts with lumbar screws and then not resolved, and then ends up with loads and loads of hardware. So now what I've done in the last few years is that I check patients of spine stenosis or disc even before surgery. I look out that do they in addition have sacroiliac pain? Do they in addition have facet joint pain above and below? And so in 31, since 2018, in 72 of my spine surgeries, lumbar surgeries, I found that more than almost half of them had some SI pain, which I intervened before the surgery or at the time of surgery. So not only did I do lumbar decompression, fusion, whatever I had to do, I also addressed the problem of the SI joint. And that has been my practice. So in summary, I say to all the audience, a mixed audience of neurosurgeons and neurologists, that SI and facet joint is a potential source of back pain even after spine surgery. So whether somebody has had spine surgery or not had spine surgery, if somebody has chronic back pain, look at the SI joint, look at the facet joint as a cause of pain, and certainly above and below of spine fusion. If they still have pain, it could be adjacent segment degeneration, and spinal fusion should be done very, very selectively in only those that have listhesis or have spinal trauma. Not everybody with back pain requires spinal fusion or screws or implants. So SI and facet joint, I keep hammering that is something, if you address that, a lot of pain and a lot of misery to a lot of people will be addressed. So examine them. Even if you were going to operate on them for something that needs surgery, you will be able to address the SI pain, which could be accompanying that, address it at the same time or before that, but at least diagnose it before that. Thank you very much.
Thank you so much.
How do I stop screen? So, okay. Thank you.
Stopped already. Thank you so much.
Thank you.
Thank you so much, Professor. And let's move on to our next presenter. Neurologist and head of neurology department of Hujati Hospital, Iran. Let us welcome Dr. Noshin Merbad. Sorry. Dr. Noshin Merbad. Am I audible? Am I? Can you hear me, everyone? Anyone?
Yeah.
You're audible.
Thank you.
Yeah.
All right, then let's proceed with our next speaker. All right. He is ranked among the top neurosurgeons in Mumbai by India Today magazine, the September 2020 edition, and awarded as the most promising neurosurgeon in Maharashtra. 2016 by Times Group for eminent work in rural India. After achieving the first position in MCH neurosurgery university examination, he worked as an assistant professor in Parent Institute for 2 years. Thereafter, he worked as a consultant and head of neurosurgery department in a high-volume trust hospital, handling complex neurosurgical and spinal cases single-handedly for 18 months. He owes his key interest in functional neurosurgery. He attained fellowship in functional and epilepsy surgery from 2 eminent universities in Japan. At present, he is working as a senior consultant neurosurgeon in leading corporate hospital in Mumbai for the past 3 years. Let us welcome Dr. Gurneet Singh Sone.
Yes.
Hi, good morning, doctor.
Good morning. Can you hear me? Am I clear?
Yes, you are clear.
Yes. Thank you. Thank you so much, Jojo. So should I share my screen now?
Go ahead, please.
Okay. Just give me a minute. 1 minute. Can you see my screen?
It's coming up.
1 minute.
Let's wait for it. There you go. It's up. Please proceed, doctor.
Just 1 minute. Just 1 minute. Let me open it up. Let me. Now.
Yes.
Yes. Are you? Yeah. Are you able to see me also? No. I think. My thing it's become blank. Is it?
No, sir. It's okay if your video, because the PowerPoint presentation really gets a very big bandwidth. So you may proceed.
Absolutely. That's the reason probably I'm off. Okay. So thank you very much. Thank you. At the outset, I need to thank the Second International Conference of Neuroscience and Neurology for inviting me for saying a keynote on one of the topics which is kind of dear to me. The important thing that when I was asked to present the keynote, I thought that what should I actually present, and I realized that that there is one group of neurological surgeries, a disease, a neurological disease for which the surgical treatment is quite well established. But in India, per se, we don't go ahead with many of such cases. So I thought this would be the platform where we have got a vast audience, and from neurologists to neurosurgeons to students to everyone are listening. So let us take that up. Now, this is today I'll be talking about movement disorder surgeries, a road less traveled. So let's go ahead. Before I start, let us find out what are these movement disorders. So these movement disorders are a group of neurological conditions that cause abnormal movements. Now it can be voluntary or involuntary. So when we say about abnormal movements, it can be slow movement, an akinetic or a rigid movement, which is further classified as akinetic or rigid syndromes. For example, Parkinson's disease, where everything is slow. There are multiple other diseases which come along with that. That is the PSP, the progressive supranuclear palsy. There is multiple system atrophies and so on. So if there is a slow kind of movement disorder, there would be a disorder which is fast, where there are a lot of dyskinesias or uncontrollable movements like the essential tremors, chorea, myoclonus, tics. So these come into the banner of movement disorders. Now, where is the major problem if there is a movement disorder? Now, this is into the extrapyramidal system. The pyramidal system takes care of our gross motor, but the balance is done by the extrapyramidal system, which is the basal ganglia, including the putamen, the globus pallidus, the caudate nucleus, the substantia nigra, the subthalamic nucleus, and the thalamus. So all this together form the area which takes care of the extrapyramidal system. So let me tell you a little of physiology. Now, what happens is the pyramidal tract comes from the cortex down to the spinal cord and to our muscles. This is controlled by two major systems. One is the cerebellum, which controls it. Another one is the basal ganglia, which controls it again. Now, cerebellum gives more of a balancing kind of a the behavior to the body, and the basal ganglia gives the slow the movements in the body, which is not which is very rhythmic, as we are doing or as we are saying. So that is done by the basal ganglia. So if any problem in this basal ganglia system or the tracts, we'll land up in one of the movement disorders. Along with a lot of movement disorders, there are three major movement disorders which I would discuss, because they form the full chunk. One is the Parkinson's disease, other one is tremors, and the third is dystonia. So let's move on to Parkinson's disease. As we all know, Parkinson's disease was named after Dr. James Parkinson when he wrote his paper on essay of the shaking palsy in 1817. From that time, we know Parkinson's disease. Important thing is that it is a chronic progressive neurodegenerative movement disorder. So why am I stressing on this? Is because if it is a progressive disease, then the patient will gradually become worsened to the extent that after some time the treatments would not work. So that is very important. So along with motor symptoms, there are a lot of non-motor symptoms also which are very, very important in Parkinson's disease. The annual incidence is very high, and if you see, every one person in a 500 people crowd will have Parkinson's, and out of 20 Parkinson's, one will be less than 20 years. So we are looking at many people having Parkinson's disease which are not actually being treated. Now, where is the problem happening here? The problem happens mainly because of the degeneration of substantia nigra, which is to be specific, pars compacta cells of substantia nigra, which gets degenerated. These substantia nigra cells produce dopamine, and once there is reduced output of dopamine, which either because of depletion of cells, or it could be because of inclusion bodies into the nigral cells or because of degeneration of the other basal ganglia, they give rise to decreased dopamine effect on the subthalamic nucleus. Now, this subthalamic nucleus has got an action which inhibits the cortex. Now, when it gets depleted, the subthalamic nucleus becomes strong and it depletes the cortex and gives rise to bradykinesia. As this picture shows, that our normal neuron has got a lot of dopamine, and normal movement is there, which we can see. But if dopamine gets depleted, we all get the movement disorders, as we can see. Now, what are the main clinical features? I will just say there are four main clinical features, motor clinical features. One is the bradykinesia, other one is rigidity, resting tremors, and postural instability. Let me show you one of the patients. Now, see, this is a patient who is unable to move his upper limbs. That you can see is very slow. Now here is unable to get up from the bed when I'm trying to do that. He is not even able to walk, and I have to support him for walking. His walking, his turning, everything is affected. So this is a typical case of a young Parkinson's disease. Here, this was so Parkinson's disease can be mainly rigidity, bradykinesia based, or it can be tremor based. So this patient did not have a lot of tremor. I will show you another patient which gets progressed for tremor. I always say that Parkinson's disease is a disease of time. It is not a disease of 1 year or 5 years. It goes on to 20 years plus and more before the patient gets succumbed. The prodrome actually starts about more 10 to 15 years prior. But as we can see in the early, we have got these three major things, and slowly things start becoming bad. And during the advanced stage, the patient has got somewhere where all the psychological features and non-motor symptoms becomes very prominent, making the patient very debilitant. So this is one of the other patients which has got severe Parkinson's disease, and you can see that he's got tremors. He is not even able to walk. See, you have to take him. So this is in the off phase. That means when the medicines are taken off, this is how he behaves. Now, the treatment for it is mainly the first treatment is to give dopamine. We give levodopa to the patient along with carbidopa. And the response to this dopamine is very important for my talk today, or for the surgical part which I am talking about. That is the deep brain stimulation or lesioning. This response, if response there, then only any of the patients will get benefited with deep brain stimulation. The other combinations are dopamine agonists, the MAO-B inhibitors, the COMT. What are the other non-conventional treatments is apomorphine infusion and the device-assisted treatments. But mainly we are looking into deep brain stimulation or lesioning. Now, when does this deep brain stimulation come into picture is what I'll tell you. Now, the most important thing that there is a level 1 evidence that these deep brain stimulation helps these patients, and this has to be done at the right time. Previously, it was told that in the late disease, after 5 years or 10 years, we do deep brain stimulation, but now it has been proved by the early stim trial that you have to do these stimulations in the early part. That means after about 3-4 years of the patient having Parkinson's, the patient is done deep brain stimulation, and you can see that there is effect. It is not an end of life care, and appropriate patient selection is very important. As you can see, the photo that I had put, kind of a timeline, where in 97 they had told only for tremors, and then the STN-DBS became approved in 2002. 2003 has been told for an advanced disease, and 16 you can see that they are saying that it's an early Parkinson's treatment is required. Now, what is the indication for surgery? First is certainty of diagnosis. It is very, very important that the patient has got an idiopathic Parkinson's disease and not associated with any other syndromes. So a pure Parkinson's disease, and IPD is what we tell, is very important. We have to identify the the symptoms and the disability by the UPDRS score. We have to document that there is improvement by the pharmacological treatment, at least 33% improvement after taking Syndopa. But when we take Syndopa after a particular time, the patient starts having aware of effect of Syndopa, and the patient goes into an early off phase. On phase is when the Syndopa is given and the effect is on, and the off phase is when the Syndopa effect goes off. So at the start of the Parkinson's disease, the on phase lasts for a long time. It lasts for about 6 hours, 8 hours, and slowly it reduces to, I have seen, to about 1 hour or less, and the patient again gets back and wants Syndopa again. What are the complications of Syndopa? What happens is when Syndopa goes out of a particular level, the patient starts having dyskinesia. So after a particular stage, we need to have a surgical treatment. The cognitive status is very important. A patient with dementia and other mood disorders will not help with DBS, so we need to see that. The upper age limit is usually we keep here as about 75. What has been seen that the outcome is very good. The tremor, bradykinesia, rigidity, dyskinesias, motor fluctuations all get improved with this, and we have seen about 70 to 100% improvement in dyskinesia, about 30 to 100% in reduction of the off time. The tremors significantly go off, and so overall it's benefit. Also in the non-motor symptoms, we have seen that there is improvement in the patients. When you see over the time, the patient has got an on time without dyskinesia Syndopa effect has improved from 27% to 74%. That only means that we cannot stop the medicines immediately, but with the medicines we will be able to control and give lesser degree of lesser medications of Syndopa, so that the dyskinesia doesn't happen. Now, hello, yeah. So now also it is seen that the DBS keeps on helping the patient for more than 5 years. 5 years also. Hello, there is some disturbance. Hello, yeah. We have also seen that there is a tremendous economic benefit on the medicines. It has been seen that the amount of money patient spends on the drugs significantly reduces in 12 months after the DBS. Now let me move on to the next thing, and that is tremor. Now tremor is, as I had told before, it is an hyper movement or involuntary rhythmic shaking of the parts of mainly the hands or the head. There are different types of tremors. The most common is the essential tremor, and which we have seen that it is very, very common. The other types are Parkinson's tremors or a dystonic tremor. Now, if you see on this tab, this is one type of tremor of the patient which is having. See, the patient is unable to hold his hand straight. He is not even able to write down. See, he is not even able to write down. And on this side, see, so he is not. So such patients cannot sign. They have got a lot of problems with in their daily activities because they are not able to do things. Right. This is a dystonic tremor which we have seen. See, she has got dystonia, and along with that, so this is only a left-sided tremor that she has got, and a dystonic tremor. The treatment, we have tried with medications like beta blockers. It helps sometimes, it doesn't. Botox injections help. Physical, speech, language, and occupational therapy also. But mainly what helps is surgery. And surgery, either it can be a stereotactic radiofrequency lesioning, or it can be a deep brain stimulation. Let's see dystonia. Now, dystonia is a disorder which is characterized by involuntary muscle contractions, which cause slow repetitive movements or abnormal posture. Some of them are painful, some of them are not. They can be inherited, that means it can be a genetic cause or acquired, or it can be just idiopathic. It is classified according to the age, like if it is a child less than 12 years or an adolescent or an adult. It also classified according to the area of the body involved, focal or segmental, because our treatment changes with this. And there's an or with the underlying cause. If it's a genetic cause which we call as primary, we have to check for the gene called DYT1. And secondary causes can be medications or other things. Now, this is one of the patients who's got cervical dystonia. Now, he is unable to hold his neck straight when he's sitting. Similarly here, see. So while walking also he's got cervical dystonia. Other thing, so this is a generalized dystonia of the patient having segmental with generalized. He is not able to sit, he is not able to do this, not even able to write down. See, so severely debilitated. For the treatment of dystonia, there is a three-tier approach which we take. One is with medications. Botulinum toxin plays an important role in dystonias like blepharospasm and cervical dystonias. And surgery is a major role, again stereotactic radiofrequency lesioning and deep brain stimulation. Now, important thing is when I'm talking about surgery, now I'll come to the topic of surgical. We have to decide about that which are our targets for particular disease, which is very important because these targets are about 1 millimeter or less. It becomes difficult to find out and to localize it. Any problem on the surrounding area will give rise to weakness and it will be debilitating to the patient. Now it can be, now we take a VIM nucleus of the thalamus for an essential tremor. A subthalamic nucleus is taken for Parkinson's disease or dystonia, and a globus pallidus internus nucleus for, again, Parkinson's disease and dystonia. So I have localized this on an MRI scan. And the MRI scan, you can see this small area is the VIM nucleus along and which is very very near to the internal capsule. So any problems can give rise to trouble. Same is the subthalamic nucleus where this lesion is there, very near to the red nucleus. So and the globus pallidus internus, so the whole globus pallidus, the inferior part and the medial part, very near to the internal capsule. And this is the optic tract, so very near to that. We need to be very precise while doing this surgery because any problems will not be pardoned. So let me take you to a tour through this DBS procedure. Now, how do we do this procedure? We do this procedure either frame based, which is the standard of care. We have also started a non-frame based DBS, but this is very less, not done majorly. And so the frames which I use is mainly two, either the Lexel frame or the CRW frame. Both of them have been based on the principle of the center of an arc principle. So here what am I using is the Lexel frame. First step is the frame fixation. Under local anesthesia or the scalp block, we do this frame fixation. As you can see on this patient, see. So as you can see, the frame is fixed here under local anesthesia, and we have to make it very accurate to the orbitomeatal line. Otherwise, if this frame goes off in an abnormal way, then our procedure gets defeated. We have to make it tighten to the extent so that it doesn't get loose, and then our frame looks in this way. It looks good. So this is how the frame is, and then we have to use something called as an MR box, for which we will put the frame, we will attach it on the frame and take it to the CT scan room or the MR room for doing our further procedure. Now the next step of the surgery is taking the patient from the OR to the CT scan room, where we take the measurements along with the frame. Before this, we have already fed a 3 Tesla MRI of the patient into the planning station. And after this is done, then we do the planning. We overlap the 3 Tesla MRI. Now you can see this 3 Tesla MRI, which is put, and our major area of interest is this. This is the subthalamic nucleus that we can see very near to the red nucleus. We have to first find out the ACPC line, that is anterior commissure posterior commissure line, which is here. As you can see, it's about 30 times increased image, so it's a very small line that you can see here. Then is the time for overlapping the CT image, which has been taken with the frame with the previously done 3 Tesla MRI, and we find out our point and we take our targets. Now this is the anatomical localization. So on the anatomical localization, we find out our X, Y, and Z coordinates, which are very, very important. This we have done it for the right side subthalamic nucleus. This is for the left side. We take both this, note it down, and then is the time to take the patient back to the OT, where we do a positioning in the patient. Patient is kept supine with about 10 degrees flexion. The head is fixed to the table. The C-arm is kept in place, and the draping is done with in the way that our head side is towards the surgeon, and an awake patient is on the opposite side, which can be accessed by the neurologist and the anesthetist. Now this is the Lexel stereotactic arc. Now here we put our X, Y, and Z coordinates, and then we fix that into our into the frame, which we have already done that. There are two important things in this. One is the star drive and the micro drive. Now these are important for us to localize or to go in precisely millimeter by millimeter. Now this one full circle is 1 millimeter. So by millimeter, we put our electrodes inside to reach our target. This is how our target looks, our frame looks after it has been fixed. Now it is the time for doing the craniotomy. Now after we putting the arc, we find out, localize the area where our craniotomy or this the electrode would go inside. At that area, we do a small craniotomy, as you can see. Now after the anatomical localization done previously, now is the time for physiological localization. Now physiological localization is done by MER recording system or micro electrode recording. Now here what we can see, the micro electrodes are slowly placed inside. They are first connected to the machine, and then we see whether going inside millimeter by millimeter, whether we are reaching our target or no. Now here, once we start that, you can see that the subthalamic nucleus has started firing, as my neurologist friend is saying, and then you can see that it is going slowly more 1 millimeter when we went inside. This is our target. You can see the target which is there. So 2 localizations done, anatomical and physiological. Now it's the time for clinical localization. While doing the clinical localization, the neurologist checks the response of the patient slowly when millimeter by millimeter when we are going inside with our electrode, and the rigidity, the eye movements, this kinesias, everything is checked, as we can see that. Now here, once we reach the target, we see that the response is very good. So on table, we know that the patient has got a very good response. Now here we can see that the bradykinesia, as is told, is known, and he's faster than the neurologist. So he's become, so this is very, very gratifying. So the next step is to put the DBS electrodes. Now here slowly we put the DBS electrodes inside over the area which has been masked. and that is put with under the fluoroscopic guidance. Now, here where the C-arm role comes into, and the DBS is put accordingly. Now, bilaterally, the same procedure is done, and then our is fixed there by using a button. There is a button which helps us to fix the electrode. Now is the time to place the IPG or the battery. Now the battery is tunneled from the head to the to the infraclavicular area where we put the pacemaker for any of our other patients. So that area is where the battery is put after making a pouch. This is how it will look. This is after the operation. We take an image again to see and confirm whether our pre-op and post-op images were equivalent or no. And now here we can see that on imaging and reconstruction, we can see this is the subthalamic nucleus, and our electrodes are both inside the subthalamic nucleus. This is how the DBS is done. Now let me take you through how a lesioning is done, a radio frequency lesioning. Now this is a full video which I will show you, where we are doing a VIM thalamotomy for a patient with tremors. Now this patient has got bilateral tremors, but we are going to treat his right hand first because he is a right-handed person. He is unable to sign. So first is the stimulation given, where the patient will feel a transient dysesthesia, and then the lesioning is done after confirming by at 70 degrees for 30 seconds, and then that is at the 0 millimeter level where we have localized it anatomically before, and we can see that he is showing a good response. The right hand tremor is almost disappeared. Now going down 2 millimeters below, we do another lesion, which is again 70 degrees for 30 seconds, and 4 millimeters we do another lesion, and this we see that the tremor is completely stopped of this patient, and this is how it happens. Now let me take you through some of the cases which is showing some response. Now this is our patient which I had shown you before, and now we see how is the response post surgery. The patient was not even able to move, is quite fast. He's able to walk on his own. This was his previous thing that he was able to do. Right. This is another patient which I had shown you before, and this was his post-operative. See the way that he is sitting stable, no tremors. He's showing a very good response. He's able to move that. Is walking it without trouble. Very gratifying. Now I'll show you the same patient for tremor which I had shown you. This is the same patient for tremor which you had seen. Now this is post-operatively. See, post-operatively you can see his hand. He has got no tremors, no resting tremors, no action tremor. He is able to, yeah. See, he is able to do his things. Another girl who had a right-sided tremor. See, which is quite severe. Post-operatively, a very stable hand that she has. Now our patient of dystonia. This is the generalized dystonia which I had shown you. This is 1 week after we did a pallidotomy. A lesioning was done on this patient on the left side, and see the way that he is improved. He is improved significantly just 1 week post this, and 3 months after the left pallidotomy, we see that he has showing significantly good response. Another patient of dystonia, generalized dystonia, where you can see that the patient is not even able to walk. He's got neck, trunk, upper limb dystonia. We did a lesioning on this patient, and this is the same patient, a different person it looks like once we have seen. very gratifying result. Now, before I show you this video, I want to tell you a specific type of dystonia, which is called the musician's dystonia. Now, here there is a case of a drummer who had a dystonia in his left upper limb, and you can see that. You see his hand gets tight while doing this thing, and he misses some of the notes. Yeah. So intraoperatively, we have to check. Now here we do a, a ventro-oral thalamotomy, where we do a lesioning on that. And after thalamotomy, you see that his hand movements have become very, very good, to the extent that he's playing it very well now. So with all the three cases, I will tell you the reason for me presenting this today is the prevalence of tremors. Now, if you see in India, we have got about 400 patients of tremors in 1 lakh population, about 250 of Parkinson's, and about 50 of dystonia. Approximately about 6.5 lakhs to 10 lakh patients presently present. And how many cases do we do in the whole of India? Is about 500 to 600 only. As against in US, they actually they at least do about 4,000 to 5,000 thousand cases every year. Now, why is this? This is because of the lack of awareness. That is the reason that I had decided to present this today. So my take home messages for everyone is that movement disorders are common in India, and surgical treatments have good outcomes. And these surgeries are very, very well available in India. Thank you. Thank you very much. Can I stop my screen share now?
Yes, go ahead, please.
Okay, I did that.
Thank you.
Thank you. Thank you so much.
Doctor, thank you so much.
Thank you. Yes.
Let me go ahead and call on our last keynote speaker for today. He is a professor of spinal injuries, Keele University, consultant surgeon in spinal injuries, United Kingdom. Let us welcome Professor W.S. L. Masri. Doctor, you're not audible. We cannot hear you.
Can you hear me now?
Yes, thank you. Please proceed.
Shall I go from the beginning or?
Yes, please.
Yeah. Sorry, ladies and gentlemen, I was unmuted myself, basically.
No worries.
I'd like to thank the organizers for inviting me to present to you this afternoon, and also I'd like to thank Miss Anupriya for her informing me regularly about this conference. For 5,000 years, ladies and gentlemen, patients with spinal injuries died a miserable death. The first record was documented in a papyrus 5,000 years ago, and the scribe who wrote this papyrus decided that after having treated many patients, spinal cord injuries is an element not to be treated. The patients did not die from the cord damage. They died from the effects of the cord damage, which is mainly a combination of complications that easily developed, that easily progressed until they killed the patient. And the main ones were respiratory, infective, renal failure, and septicemias. The condition remained with a very poor outcome until the Second World War, when Sir Ludwig Guttmann was given the task to manage the soldiers and the officers coming back from the front with tetraplegia and paraplegia. His instructions were to make sure that these patients are as comfortable as possible and have an as dignified life, end of life as possible. What Guttmann did is really, rather than do that, he studied why patients did develop these complications, how they can be prevented, and what he did actually is to study every effect of spinal cord damage, and found out that it is really the dynamic and unstable nature of the pathophysiological impairment, especially the autonomic system, together with the sensory impairment and loss that resulted in the easy development of complications. Now, that's all very well enough. The problem is that was compounded by the fact that the patient with spinal cord damage doesn't feel below the level of the injury and does not have the usual expected symptoms and signs that the clinician expects to be able to make a diagnosis. So the complications developed and progressed without the clinician sometimes being aware of their development for some time. To compound to the problem is the very small incidence of the condition, which in the United Kingdom is about 10 to 15 per million per year, which means that a general district hospital that serves 250,000 population in the UK will not see more than 4 patients a year. When you come and think about the different level of injuries, the different densities of injuries, it is not possible to treat these patients adequately in isolation and outside a dedicated spinal injury center. So very quickly, what Gottman did is to demonstrate that all the complications of spinal cord injuries can be prevented, that the disability can be minimized in for every impairment, and that the patient can actually have the minimal inconvenience and maximum independence that he can develop within the restraint of the density and the level of the lesion. Gottman also realized that by giving good attention to all the non-medical effects that really are the main problem of the patient during the first few days or weeks when they do not know what the prognosis is, by giving attention to these problems, he could reassure the patient and vocationally retrain them and ensure that the family members are supported well enough to enable the patient who does not recover and does not regain full independence to provide some of the care at home in the community. What Gottman also did state categorically that in order to achieve a good outcome, one needs a patient-centered model of service delivery from the very first few hours of injury to manage the spinal cord damage together with every system impairment and malfunction simultaneously, ensure complications are prevented and give the patient the best chance for either recovery or adaptation to his disability. And for this, you need a good multidisciplinary team of knowledgeable healthcare professionals in the condition and with experience in the training and experience in the condition. And so these patients can, with appropriate treatment, live reasonably enjoyable, long, dignified, productive, and often competitive lives. And I'm sure you've seen them in the Paralympics and Olympics. And this patient was back to work after he's been to my hospital for 3 months and has since found a partner and fathered children. What Gottman also did observe, and 3 main important observations, that a number of patients made significant spontaneous neurological recovery irrespective of the radiological presentations on X-rays, that's what was available at the time, and without any surgical or other intervention. He also realized that the outcomes following laminectomy were poorer than those of conservative management. And he also noticed that some medical and surgical complications can be responsible for neurological deterioration. So in the mid-60s, Hans Frankel, and those of you who are senior enough to remember the Frankel classification, decided to study the neurological outcome of patients with spinal cord injuries. And he made an astute observation that the neurological outcome depended on the presence or absence of long-tract sparing of sensation and of sensory motor functions. So he found that 60% of patients who have sensory sparing only, long-tract sensory sparing, usually down to S2, are able to walk again. Sorry, 60% of the patients are either able to stand or stand as well as walk again. And 70% of patients with long tract sensory motor sparing are able to achieve standing or standing and walking. And that is without any intervention whatsoever. So you may already know about the Frankel classification. He actually classified them in 5 classes. Frankel A, no long tract sparing at all. Long tract sensory sparing only for Frankel B. Long tract sensory motor sparing of no functional use for Frankel C, and sensory motor sparing to the ability of stand and walk in Frankel D. Frankel E are a normal sensation. And this is the grid that Frankel used. The first letter is the classification of the patient on admission, and the second letter is on discharge. And this is the original, copy of the original Frankel grid. And to be honest, without reference to this publication, it is very difficult to actually appreciate the prognostic factors of neurological recovery. He published this in 1969 in the journal Paraplegia, and this journal is available on the Spirit website, which is an educational charity that you can find on the website. So my main, I have actually been fortunate enough to be taught and mentored by both Sir Ludwig Guttmann and Frankel. And during my 12 years training at Stoke Mandeville Hospital, I examined each of the 612 patients Frankel did include in his classification and his study as well. And my main contribution there was to find that patients with pinprick, specifically with pinprick sensory sparing, did a lot better than patients who would appreciate a pinprick as a deep pressure or only had posterior column sensory sparing. And that was published in 1989 from my department in Oswestry. So in the UK, at least, the majority of the patients with spinal cord injury were treated conservatively up until the early mid-80s, when the CT scan and the MRI started to come into the armamentarium, the diagnostic armamentarium of spinal cord injuries. So the influence of the CT scan and MRI have been very interesting, because obviously they showed us a radiological manifestation that we didn't see before. And unfortunately, it also had the disadvantage of a more mechanical approach to the spinal injury, and with, you know, in the 80s and 90s, quite legitimate concerns about the biomechanical instability or malalignment, canal encroachment, neural tissue compression, further damaging the spinal cord. Some people felt that by surgical intervention, there may be a window of opportunity during which surgical intervention may hold the cascade of changes in the spinal cord following the damage. And sadly, some operated on the mistaken belief that surgical stabilization facilitates early mobilization and is equally beneficial to patients with and without spinal cord paralysis, without really realizing that during the stage of spinal shock, a spinal cord injury patients has a lot of unstable vasomotor disturbances and does not react as the neurologically intact patients in most ways. Other kind of semi-indications came, which pleased the powers that be in deciding the model of the shape of the model of service delivery, like speeding up rehabilitation, preventing the complications of recumbence, shortening hospitalization time, and saving money, none of which is actually been proven for the last 40 years, and sadly, the opposite of which is what we see in our daily practice. I do not wish to spend a great deal of time discussing these because that would take another half an hour on its own. But all the complications of recumbence are not because the bed caused the recumbence. It's due to the poor management of the recumbent patients. You can imagine the difficulty of a nurse or a healthcare professional trying to actually look after a patient with postural hypotension, or assist coughing a tetraplegic or hyperaplegic patient against gravity while in a wheelchair, or relieve the pressure on sacrum and ischial tuberosities to prevent pressure sore, or carry out intermittent catheterization while the patient in the chair, or clear bowel incontinence, and so on and so forth. Patients with traumatic spinal cord injuries do not benefit from early mobilization during the stage of spinal shock. So really from the 80s onwards, we had a tsunami of surgical interventions, which really by just before taking up my appointment as a consultant in spinal injuries in Oswestry, because I had seen a number of patients not achieving what I expect them from the prognostic indicators of recovery to achieve, and because I have observed a number of patients deteriorating, not from further biomechanical instability, but from the complications of spinal cord injuries like hypoxia, anemia, hypotension, septicemia, and so on and so forth. I decided to take myself to the States, where having trained with all the good people in the UK, I went to the best places available in the USA and spent 6 months unpaid sabbatical with Paul Meyer, Tom Ducker, and William Sweet, and then the Veteran Association with NROC. And I came back with the impression that sadly, that even though I'm a surgeon myself and I had high hopes that surgery may further improve the outcome of spinal cord injuries, I must admit I was not impressed with the outcome, despite the fact that the skills of the surgeons could not be faulted at the time of the surgery. And basically, over the last half century, these are the mechanisms by which I have seen patients either not achieve or neurologically deteriorate, having gone through the records of those who were referred to me after surgery and carefully studied them. So the surgeon can be a very skilled surgeon. However, the outcome does not depend entirely on the skills of the surgeon. The anesthetist needs to be as aware of the pathophysiology of spinal cord injuries and relatively recently, some of you may be aware of the work of Kwon, who actually found that by surgically decompressing 21 consecutive patients and measuring the CSF pressure at the site of the injury and below, that what he expected to see, a reduction of the CSF pressure, which would have actually resulted in an improvement of the perfusion of the spinal cord. He saw exactly the opposite in 21 consecutive cases. So he found that the CSF pressure increased and not decreased, which has implication on the perfusion pressure on the spinal cord. So anyway, I'd better move on a little bit quicker. I was appointed as consultant surgeon in spinal injuries in the Robert Jones and Agnes Hunt Orthopedic Hospital. This is a purely orthopedic hospital. I was in charge of the Department of Spinal Cord Injuries. And I retired in 2014. I will now present a few patients just to show you the results of active physiological conservative management of patients without any surgical intervention or any other intervention of patients admitted to my department early. And these patients, some of them are over 30 years since their injury. So they were all treated with bed rest for 4 to 6 weeks, followed by bracing for another 6 weeks. None of the patients had surgical decompression, surgical realignment, these patients, or surgical stabilization. For realignment, I usually carry out a closed reduction within the first 48 hours from injury and not after that. After 48 hours, all the problems that I've seen and I've done myself, I felt are related to timing, because after 48 hours, when the spinal cord is at its, when the edema is at its most prominent, one could damage the spinal. So if a patient comes after 48 hours from injury and the spine is not realigned, I would leave them, and I'll show you the result. All these patients that I'm going to describe have had significant neurological impairment, despite the fact that they initially presented with a severe compression of the spinal cord or severe canal encroachment. They have all missed the window of opportunity. And this is the first patient, a 22 years old patient admitted within 1 day of injury in Frankel B. Sensory sparing, pinprick sensory sparing down to S2, no motor sparing whatsoever. These are his original records. No voluntary movement in the lower limbs at all in July. By November, he actually recovered almost all power in his legs. And that is the patient. I think this picture was, this video was taken about 16 years post-injury without any intervention, surgical or otherwise. The patient recovered almost completely, and you can see now, for the sake of time, a painless, almost full range of movement. And you can see the radiology. I do not need to go into great details. I'm speaking to an audience that this is another patient who was involved in a motor accident in 2004, 16 years old, came with a bony injury in T12, Frankel B. So no motor power at all, sensory sparing only, and he had both T12 and L3. He improved to Frankel D on follow-up. He had come 2 days, 1 day following injury, and you can see no motor score in the lower limbs. On discharge, he had 47 out of 100. And you can see not the terribly exciting MRI. Still got a kyphotic deformity, but it's a stable kind of kyphotic deformity. A full painless range of movement, which is sustained for about now since his injury. Now, this is not published yet, but I looked into a group of 37 consecutive patients presenting in Frankel B, again, sensory sparing, no motor sparing whatsoever. And this is the highest, lowest, and a median number of days between injury and the first return of flicker of movement in the lower limbs. Well, anywhere really. And you can see it ranges for the cervical injury between 1 and 35 days, for the thoracic between 5 and 45 days, and for the low thoracic up to 20 days. The median is 10, 8, and 3. So, but what I'd like to bring up to your attention is that a patient can be paralyzed for 35 or 45 days and not show any sign of recovery. So if I carried out any intervention, surgical or otherwise, and the patient didn't recover to that degree, would I ever know whether the patient had a really deteriorated in main term? Because if they do not recover, it's a catastrophe. But or not. And surely, if I carried out any intervention during this period and the patient recovered, with all the knowledge I have, would anybody be able to convince me that it wasn't my intervention who helped the patient recover? So these are issues that we all need to think about. And this is the progress of these patients. And basically, at about 7.5, 8 weeks following injury, one could predict the outcome of the Frankel B patients with pinprick sensory sparing. And the motor power then is likely at around 8 weeks, is likely to double at 1 year following injury. Now, all the patients with pinprick sensory sparing down to S1, S2 will walk. 73% will walk with without any support or with one stick, 19% with elbow crutches, and 8% will intermittently use a wheelchair as well as stand or walk. So these were the Frankel B patients. Now I'm going to show you a few Frankel C patients, and this first one is with a C5 injury, admitted about 2 weeks following injury. Okay, she was initially thought to be Frankel B in the referring hospital. By the time she had come to us, she was Frankel C with motor power, but useless motor power functionally when she presented. And you can see she's got a bilateral dislocation, and you can see the degree of cord compression. She was treated with active physiological conservative management of her spinal cord together with every treatment perimeter malfunction. No complications were allowed to develop. And as you can see here, the lady has recovered completely, including bladder and bowel function. And you can see the range, a very good range of movement, which is painless. For the sake of time, I'll move on. This is another patient who was in the Welsh Guard and came to me also 2 weeks following injury. He was in Frankel C. He presented in 1987, and you can see his D9 injury. And basically, following conservative management, he led an expedition to the roof of Africa 3 years following his accident. And 2 years later, he led another expedition to the roof of America. And as you can see, he also has a good range of movement, which is completely painless. Okay. So if you don't mind, I'll move on. Yeah, he actually, his progress was witnessed by the Prince of Wales, who was the chief of the Welsh Guard at the moment. This is another lady. I'm just going down the spine. RTA 1987, admitted in Frankel D, discharged only after 12 weeks following hospital. This is her initial motor score, 78 out of 100. She reached 98 out of 100 in 12 weeks time. And that is, you can see the degree of canal encroachment, right? You can see the degree of canal encroachment here. She has a nasty kyphosis, and the spinal canal has remodeled a little bit, but there is a residual. So basically, she has, I'll just move on. Right, okay. So basically, you know, I know these radiological pictures do not please the eye, neither mine, believe you me, but without any intervention on the spine, you can see what has been achieved. It is not the radiological presentation or the radiological features that determine the neurological outcome. And I think this is the last patient I'm going to present. Basically, she was on holiday in Greece and had a fall of 30 feet, about 10 meters, and you can see the burst fracture of L3, the degree of cord compression, and she presented in Frankel C, actually, not D, and you can see the patient running with. Okay, I'll speed it up a little bit. Anyway, these are the picture of the patients so that we save a little bit of time. These are not anecdotal cases, ladies and gentlemen. I have, for those interested, I've collected about 200 of those, only the ones who agreed for me to use their material for presentations. We have published most of our work. There was Professor Kato, who's professor of spinal injuries in Tokushima, in Japan, was spending a sabbatical with me, and he independently looked at my material, which he didn't believe initially. That's why he came to my department. And anyway, to cut a long story short, he found no correlation between the degree of canal encroachment and the degree of neurological deficit on presentation, nor the degree of canal encroachment and the degree of neurological recovery on discharge. That was published in Neurotrauma in 1993, and he reviewed a patient with cervical spinal cord injury in Frankel B, C, and D, and confirmed the results of what I have mentioned. This was published in Spine in 1996. We also published our results in with complete injuries in the Journal of Bone and Joint Surgery, and basically there are the prognostic indicators of neurological recovery in the zone of partial preservation, which is the 3 segments below the last normal segment. Usually complete patients with complete injuries do have some partial sparing in 3 segments, up to 3 segments below the last normal level. So the recovery in this zone of partial preservation dependent mainly on if the neurological level was higher than the bony level, one could almost be certain that the neurological level will drop down at least to the bony level or below. And obviously the preservation of some sensation in the zone of partial preservation was also a good prognostic sign of recovery. Now, early mobilization during the stage of spinal shock, I keep on harping on that because it is a kind of parroted as an indication for surgery. Remember, these patients have severe postural hypotension, and there is about a 10% incidence of neurological deterioration, usually temporary if one puts the patient back to bed straight away. The vital capacity of these patients do not improve when they are verticalized during the stage of spinal shock, nor after the stage of spinal shock, but the drop is its most severe during the stage of spinal shock. And then the concentration of the body weight on the ischial and sacral tuberosities, and really all this is detrimental to patients. We've known since 1955 that verticalizing patients with spinal cord injury reduces the vital capacity, doesn't improve. What about pain? If I need to say something, I had 2 people audit the pain in my department. Yahiel Gottfried came from Israel in 1987. He found a 5% incidence of pain. Kalke from Germany, spinal surgeon again, he found an 8% of all sorts of pain. So, do we operate in our orthopedic hospital in Oslo? Yes, we do, of course, but it is the minority of the patients. I would say no more than 10%. Neurologically intact patients with biomechanical instability, they can go home within 2 to 3 days following the surgery. They don't need this intensive rehabilitation. Pure ligamentous injuries with no bony spinal vertebral injury at all, they take a very long time to heal. In my experience, it's best to operate on them after 3 weeks when the blood-brain barrier has settled a little bit and when some vasomotor reflex recovery has occurred. In patients who neurologically deteriorate, we do not know what the outcome of surgery is for those patients, but it is safer to operate on them. Having said that, I have patients I didn't operate on and they recovered completely. Mentally challenged patients, you cannot trust them or to cooperate with conservative management, and patients with uncontrolled epilepsy, or patients who make an informed choice, knowing the advantages, disadvantages, and risks of surgery and of poor non-operative management. So these are my conclusions, ladies and gentlemen. Local and general spontaneous neurological recovery at the site of the cord damage and beyond are very common following spinal cord injuries. The injured and physiologically unstable spinal cord is at risk of further damage, not just from the mechanical insult, but from a number of complications arising from almost each and every system of the body, which, if not prevented, will damage the spinal cord. The simultaneous adequate management of the spinal injury, together with the multisystem impairment and malfunction, is extremely important to achieve good results. Pinprick sensory sparing within the first 72 hours from injury is likely to be invariably followed up by excellent functional recovery from the myotomes adjacent to the spared dermatomes in both complete and incomplete injuries, as I said, either in the zonal area for the completely injured patient or in the lower limbs in the incomplete patient. The extent of motor recovery at 1 year could be reasonably well predicted at 7 to 8 weeks following EG. The most important message, I suppose, which doesn't please many people, is that the radiological finding of malalignment, canal encroachment, and cord compression on X-ray, CTs, and MRI scan are of no prognostic value in the adequately managed patient. They are of a poor prognostic value in patients who cannot be adequately managed conservatively. Early mobilization during the stage of spinal shock is a figment of imagination and counterproductive to the patients. My second conclusion is that should surgeons wish to operate, they need to have around them a team of healthcare professionals, both clinicians and nurses and physios, who are knowledgeable in the condition and well trained in looking after these patients. Because, as I stated earlier on, there are a number of mechanisms that can that would damage the spinal cord further, either operatively or post-operatively. Finally, ladies and gentlemen, this is my statement. There is no elevator to success. A quick operation on the spinal, on the spine, whether to stabilize or decompress, does not treat patients with spinal injuries, and one has to spend the time and effort into looking after the spine as well as every system of the body. Finally, thank you, ladies and gentlemen. And I'm happy to take any questions. I know that there are some neurosurgeons. Sorry?
No, go ahead, please.
Yeah, I'm happy to take any questions. I know there are neurosurgeons and orthopedic surgeons in the conference, and I'll be happy to challenge on any of the statements I have made.
All right. Anyone? Do you have any questions or feedback? All right, no questions. Thank you so much for that very beautiful motto. I like it. Thank you so much, Dr. Masri, Professor Masri.
And thank you all for inviting me. Yeah, thank
you. Our pleasure. All right, everyone. Let's go ahead and I think it's lunchtime in India. Let's go ahead and take our lunch break and be back at exactly an hour. We will be opening the breakout room after lunch. So if you are included in the technical session 1, please. If you are included to technical session 1, please stay in this main room. And if you are included in technical session 2, go on to join the breakout room 2. If you are having problems, please message us in the chat box that, hey, I want to be moved to session 2. All right. And I would like everyone to please, to remind everyone, especially the presenters, to please be mindful of the allotted time for the presentation. So you are allotted like 8 to 9 minutes for the presentation and a minute or 2 for the question and answer. And I would also strongly recommend to please make sure that your presentation is already ready, up and running on your computer, so that once your name is called, it will just automatically pop up once you share the screen. Right? And I think that's about it. See you guys after an hour. Oh, one moment. I need to take your big smiles today. I forgot to get my remembrance today. My apologies, guys. Can you please give me your big smile? I request everyone to please go ahead and open their cameras and I will just take a quick remembrance of our faces. Thank you, Miss Neha. Wow, beautiful, beautiful eyes. Everyone, thank you. Hello, hi everyone. Hi, Miss Kumarish, you're beautiful. All right, one moment. Please hold your smile for like a minute because I have 3 screens and I have to take it like, 3 times. All right. For the first page, everyone, 1, 2, 3, say cheese. Gosh, I look like a ghost. The light is too high. All right, second page, hold on. Say cheese.
Third.
Third page, say cheese.
Audio. Third.
Oh my God, thank you so much, everyone, for your cooperation. Let's go ahead and proceed with the lunch. See you guys after an hour. Bye-bye.
I will definitely take that.
Hello? Hello, everyone. Please advise your colleagues to come into the meeting room, and we will start in 5. Let's wait for everyone to come in. And again, this is a gentle reminder. Just please be mindful of the allotted time for your presentation. All right. You're allowed, presenters, please make sure that your presentation will run up to 8 to 9 minutes for the main presentation and a minute or two for the question and answer. And I believe that you all have the schedule. Please make sure that your presentation is up and running so that when it's your turn, it's easy to share. Right. I would just like to welcome and give thanks to our session chairs, Dr. Surjit Sahu, Professor and Head of Department, Department of Psychiatry, IMS, and SAM Hospital, India. Dr. Namit Singhal, Director and Neurosurgeon, SS Hospital, India. Dr. Jeba Chitra, Dean and Professor, Department of Neurophysiotherapy, Kahir Institute of Physiotherapy, India. And Dr. Anjan Desai, Principal and Head of Department, Department of Physiotherapy, SPB, Physiotherapy College, India. All right, we will have our sessions, 2 sessions. So session 1 will stay here in the main room and I will be your moderator. Session 1 group is about cerebrospinal complications. Now we only
me, Dr. Surjit, asking Jojo that whether Dr. Namit Singhal is there or Dr. Neurologist from some hospital will join as a chair. Is there a change?
Oh, sure. You may go ahead and welcome Mr. Can I have his name?
Dr. Srikant Sahu, perhaps.
Is he in?
Dr. Srikant Sahu perhaps might be joining, perhaps. Just see whether Dr. Namit Singhal is there or Dr. Srikant Sahu. Who will join?
No problem. All right, I would like to also to welcome from some hospital, India, Dr. Srikant Sahu. Yeah. And we have one breakout room, which is the session 2, which will cater the parallel session 2 about neurophysiotherapy. All right, go ahead. So those who are included to the neurophysiotherapy, please join the breakout room and Divine will be your moderator. Well, with no further ado, let me welcome again our session chair of cerebrospinal complications. Session chairs, Dr. Surjit Sahu.
Okay.
Dr. Srikant Sahu and Dr. Namit Singhal. And let us welcome our first presenter, oral presentation by Antarika Samantha from University of Calcutta, India. The topic is about impact of volunteering activity in social work on psychological well-being among young adults and an explorative study.
Yeah, hello. Should
Hi.
I?
Yes, please.
Okay. So is it visible?
Yes, it is. Please proceed.
Okay, so first of all, good afternoon, everyone, my respected chairpersons and the audience. I would like to thank IAN and BioLeaks for giving me this opportunity to present in this esteemed conference. I'll be presenting a topic that is slightly different from neuroscience, which is mostly covering the area of behavioral science. So without wasting any time, I would like to proceed. So my title, the title of my study is Impact of Volunteering Activity in Social Work on Psychological Well-Being Among Young Adults. So currently I'm pursuing MPhil in clinical psychology from Amity University, Gwalior. But when I had conducted this study, I was in University of Calcutta pursuing my master's. So a brief background or introduction to my study. Over the years, I had witnessed a lot of my close people volunteering in different spaces and social organizations, and who had benefited from doing so. So I wanted to explore this area a bit further and study if volunteering does really affect the mental well-being of the volunteers. So, from the perspective of neuroscience, if you may say so, the act of volunteering actually floods our brain and body with the neurotransmitter dopamine, which contributes to feelings of pleasure and satisfaction, and also oxytocin, which is nicknamed as the love hormone, and it helps us to connect to others. So, volunteering has been proven to be beneficial for one's psychological health over the years across many nations. Previously, researchers have pointed out that a wide range of evidences of volunteering and growth of psychological well-being and increased empathy and its related facets. And effects of volunteering in social work have been majorly studied among older adults and not much among younger adults. So this was one of the pivotal reasons why I wanted to study the effects of volunteering on the psychological well-being of the younger population. And also, in our country, that is India, there are many organizations which provide volunteering services, but not many studies have been done to really understand what happens to the psychological well-being of the volunteers when they actually perform their activity. The aim of the study was to explore the relationship between volunteering in social work for underprivileged children and mental well-being in young adults in respect to interpersonal reactivity and general mental well-being. The objectives of the study would be to assess, to determine whether there is any difference between volunteers and non-volunteers in respect to their general psychological well-being and interpersonal reactivity, which is further divided into perspective taking, fantasy, empathic concern, and personal distress. And the second objective was to understand if there is any effect of gender, that is male or female, on the scores achieved by the participants in terms of the measures used in the study. And third, to determine if there is any association between the variables in the study. In the methodology section, a purposive sample of 100 individuals were taken within the age range of 21 to 30 years. 50 volunteers and 50 non-volunteers were considered for an analytical type of cross-sectional study after screening them via an information schedule. And then they were administered 2 questionnaires, that is the General Health Questionnaire 12 and the Interpersonal Reactivity Index. Duration of the study was 1 year. The inclusion criteria for the sample were age range was taken between 21 to 30 years, education, graduate or above, hailing from upper or middle ACS, volunteering in NGOs dedicated to the welfare of underprivileged children in Kolkata for more than a year, not undergoing any physical or psychiatric treatment. Exclusion criteria, anybody below 21 years or above 30 years were excluded. Education below undergraduate or undergraduate were excluded. Hailing from a lower socioeconomic status. Volunteering with an NGO for less than a year or for a few months. Or volunteering in a NGO outside of the city. Or with NGOs which are dedicated to welfare of special populations like autistic children, AIDS patient, volunteering in old age homes, and not willing to respond to questionnaires. Variables for the present study were perspective taking, fantasy, empathic concern, and personal distress, which are facets of interpersonal reaction. And the second would be general mental well-being. Tools used, information schedule, interpersonal reactivity index. I couldn't include the tools or the questionnaires here because of some cropping issues since they were very long, but these tools are very easily available on the internet. So interpersonal reactivity index and GHQ-12. A brief statistical analysis statistical analysis was done by computing the means and standard deviations of the scores of each group. The collected data was found to follow a normal distribution. So parametric statistical calculations using SPSS version 17 were done, namely students t-test, two-way ANOVA, and it was further analyzed by Pearson's correlation and regression analysis. The results showed that volunteers differed significantly from non-volunteers in terms of general mental well-being. So the F value provided here is showing that there is a significant difference between the two main groups in respect to their mental or psychological well-being. The findings also showed that there is a significant effect of gender on mental well-being and personal distress. So here the F values of mental well-being differs between males and females, and also how personal distress control or taking differs between the two genders. Also, significant positive correlation was found between general mental well-being and interpersonal reactivity scores under the facets of perspective taking, fantasy, and empathic concern. Also, personal distress was found to be inversely associated with mental well-being among volunteers, which means that which can be inferred as volunteering induced positive mental growth in the volunteers, as a result of which their personal distress decreased. This was found in the study. And then perspective taking and fantasy were also found to be respective predictors of empathic concern. Empathy, if a person has a higher level of empathy, that means the person have better understanding of others' problems. They can take others' perspectives, and they have a better imagination of others' problems. A brief discussion of the results. So the result which we got at first was a significant difference between the two groups in respect to general mental well-being. Studies supporting the result would be active volunteering over the years have shown remarkable effects on one's mental well-being and has increased mortality rates among volunteers. For example, volunteering association membership contributes to decrease psychological distress and buffers the negative consequences of stressors. A study in 1998 had shown that. Then a study also in 2001 showed the bidirectionality of the relationship between volunteering and the person's mental growth, which says that people with greater personal well-being, like people who are predisposed with greater personal well-being, tend to volunteer more often than people who are not. And also, people who volunteer a lot has better personal well-being. It was also found in the present study that there is an effect of gender on general mental well-being. So a study in 2015 showed that women improved their self-esteem significantly more than men from the age of 15 to 23, which covers the population taken for the study. And it also showed that women were more satisfied with their life than men at the age of 23. Men had a better body image, less anxiety, less depression, and fewer somatic complaints than women. Independent of age, across gender, anxiety declined and somatic complaints also became fewer. The third finding would be personal distress was a facet of was found to be inversely associated with mental well-being. In a study by Delphine Greenberg in 2018, personal distress was positively related to maladaptive strategies and negatively related to adaptive strategies among participants. The next finding would be personal distress and gender. From the findings, it was found that personal distress, according to gender, are significantly correlated, have shown different reactivity towards personal distress control. Studies have found that women are more prone to anxiety and experiences comparatively more distress when they witness another individual in distress. And lastly, perspective taking and fantasy were found to be respective predictors of empathic concern. Like I said before, like if a person has more empathy, then they can put themselves in others' shoes and understand their problems more. So it was found in the study that volunteering does affect a person's levels of empathy or empathic concern. Some long-term volunteers expressed that they were able to look beyond their own needs in a study by Elias Sudhir Mehrotra, Nimhans, 2016. So the implications of the study would be the present study sheds some light on the importance of volunteering among young population, being beneficial for their psychological health and development of related facets that might help them in being personally and socially competent. Some limitations would be the study was conducted with a sample size of 50 participants per group, with only volunteers from Kolkata working for the welfare of underprivileged children and non-volunteers who were also based from the same city, excluding individuals belonging from lower SES, thus affecting the generalizability of the study. And it also did not consist of a qualitative probing, which needs to be done to understand the experiences of volunteering and its associated effects in their lives. Recommendations: a study should be conducted with a larger sample size and across all the socioeconomic statuses. It should also be conducted with volunteers across the life course to assess the effects of volunteering in their lives. And a qualitative study should be conducted with volunteers where narratives of their subjective well-being shall be recorded. Conclusively, it can be said that volunteering does have a significant effect on the psychological well-being of young adults. And general mental well-being and personal distress varies according to gender. Perspective taking and fantasy are causal factors of empathic concern. Acknowledgements would go to my supervisor in the University of Calcutta, to whom I'm highly indebted. My parents, gratitude to my parents, my teachers, and my friends and seniors from the same department. And lastly, my classmates for the endless support, and to IA and BioLeaks for giving me this opportunity to present my paper. Thank you.
Thank you so much. Do we have questions from our chair?
So do you think that there is some gender difference of analysis?
Sir, yes, sir. Actually, when I was doing this study, I found it in the results that there is a difference in gender on how much of psychological well-being is gained through volunteering. Like we could see that personal distress control increased when people were more empathetic. So volunteering showed that people who do social work or altruistic work for other people or underprivileged people, they tend to learn more about the societal adversities of other people, and thus their level of empathy also increases and they tend to show lesser personal distress.
Thank you.
Thank you, sir.
Thank you so much. And I would like to take this opportunity to properly introduce one of our session chairs for today. He is an associate professor and head of department, neurology department, IMS and Thumb Hospital, BBSR or DISHA. Let us again welcome Dr. Srinkanta Kumar Sahu.
Thank you, Jojo. Thank you.
Thank you so
Very
much,
nice
sir, for
introduction.
joining us today. All
Thank
right.
you. Thank you.
All right, let me go ahead and move on to our next presenter. Let me call on an oral presentation by Jaya Sakti from Vinayakam Mission Medical College, India. It's a topic about differentiating effectiveness between ankle brachial pressure index and arterial Doppler using peripheral vascular disease in type 2 diabetes mellitus.
Good afternoon, madam.
Good afternoon.
Yeah, ma'am.
Go ahead and share your screen, please.
So I'm just sharing my screen, ma'am. Just wait.
All right, perfect. Please proceed.
Good afternoon to everyone. My topic is about differentiating effectiveness between ankle brachial pressure index and arterial Doppler USG in peripheral vascular disease in type 2 DM patients. Introduction. It's a peripheral. First, you have to see about peripheral arterial disease. It's a major macrovascular complication of diabetic mellitus. A patient with diabetic mellitus have increased prevalence of peripheral arterial disease. However, due to associated neuropathy, common symptoms such as claudication often masked. And such patients often diagnosed late when limb-threatening ischemic, any ulcer is already set in. Arterial color Doppler ultrasound and ankle brachial pressure index are easy, non-invasive method, often underutilized tools for diagnosis of peripheral arterial disease in diabetic patients. Peripheral vascular disease is a major macrovascular complication of diabetic because of unique involvement of distal pattern of vessels and invariable association with neuropathy, and peripheral arterial disease has a greater prevalence in diabetic. And then definition you have to see peripheral arterial disease. It's nothing but is a thickening of the arterial wall, result in the progressive narrowing of the arteries of upper and lower extremities. PAD most commonly affects the leg. PAD is the marker of advanced systemic atherosclerosis. Lower extremity peripheral arterial disease affects the iliac artery, femoral, popliteal, tibial, peroneal arteries, or any combination of these arteries. Patients with TM tend to develop the peripheral artery disease in arteries below the knee. These are the vessels pictures. Important risk factors. Diabetic mellitus cause endothelial and smooth muscle cell dysfunctions in peripheral arterial disease. Smoking, CKD, hypertension, dyslipidemia, genetic predispositions. Peripheral vascular disease is diagnosed by definite history of unexplained cramps and nocturnal cramps, skin changes like diabetic dermopathy, including ulcers. If one or more of peripheral pulses are absent in one or both our limbs, and absence of pedal pulses in presence of palpable popliteal pulses is classical finding in diabetic arterial disease because of relative involvement of tibial arteries. It's a pathophysiology. What is the mechanism of a peripheral arterial disease? Atherosclerosis, which causing narrowing of the vascular lumen, and the vascular remodeling also happen, which causes thickening of the vascular wall. Endothelial dysfunctioning, which causes decrease in nitric oxide production. And then thrombosis also forms, which causes vascular blockade. It is result in the reduced vascular blood flow, development of skeletal muscle ischemia, and result in the peripheral arterial disease. We have to look for ABPA. It's nothing but how to calculate ABPA. It's nothing but systolic blood pressure calculated in lower extremity, higher systolic blood pressure, and then higher systolic blood pressure measured in upper extremity. We measured in both upper limb and both lower limb in lying posture. And ABPA is very specific and sensitive technique with 95% accuracy in detecting the peripheral arterial disease. And abnormal ABPA is considered as a marker for future cardiovascular disease, even in absence of any symptoms. ABPA value more than 0.9 is considered as a normal. Less than 0.9 considered as some peripheral vascular disease in one or more arteries of the legs. These are the pictures to calculate the ankle brachial pressure index. Objective of the study to determine the strength of the ankle brachial pressure index versus color Doppler USG in diagnosis of the peripheral arterial disease in type 2 DM patients. Methodology. Source of the subject patient who are attending the medicine OPD in VMC Karaikal from India. Study design observational prospective study. Sample size 711. Prospective study period 18 months. Methodology. In the present study, data was collected from 711 subjects are divided into 3 groups. First group 600 type 2 diabetic mellitus with symptomatic or not for peripheral arterial disease. In type 2, 61 type of diabetic mellitus patients. 61 type of diabetic mellitus patient diagnosed with clinically treated patients. In type 3, 50 patients without diabetic. The ankle brachial pressure index, medical records and physical examination performed in all patients according to cardiovascular risk factor. The results of the study indicates abnormal ankle brachial pressure index in 49% more than 50 years and 42% less than 50 years are observed in this group 1. Considering clinically treated patients, a peripheral arterial disease prevalence of 39% was observed. Among these, 48% were less than 50 years, 32% were more than 50 years. The forward stepwise regression model was developed with type 2 DM duration and sedentary lifestyle found to be an independent variable predictor of severity of peripheral arterial disease related to ankle brachial pressure index. These are the result. Out of this, ankle brachial pressure index in right limb abnormal for 35, normal for 65 patients out of 100. In left limb, 38 abnormal out of 100, normal for 62 patients. For bilateral limb involvement, 33. Okay. In comparison with the color Doppler ultrasound ankle brachial pressure index in this peripheral vascular disease, non-peripheral vascular disease, ankle brachial pressure index. In ankle brachial pressure index, peripheral vascular disease is diagnosed 37 patients. Non-peripheral vascular disease is diagnosed with 53 patients out of 100. In this patient, sensitivity was 92.5%, specificity was 88.33%, positive predictive value of 84.09%, negative predictive value of 94.64%. In this distribution of color Doppler ultrasound of study of the patient, both they are more or less same as that. It's not that much difference in both legs. In conclusion of the study, in the present study suggested that in type 2 DM patients, ankle brachial pressure index should be measured by diagnosis. In addition to the sedentary lifestyle was strongly associated with presence and severity of peripheral arterial disease. Thank you, ma'am.
Thank you so much. Do you have any question from our chair?
So I request Dr. Srikanth to ask question.
Okay. Now, actually, what is the normal ankle brachial index in a normal person?
Less than 0.9, sir.
0.9. In type 2 diabetes mellitus, what we observed?
Sir, most of the patients having normal patients having atherosclerotic changes, sir. Even patient having asymptomatic, certain patients having ankle brachial index, but certain patients having normal ABPA, sir. Most of them. The person having long-term diabetic patients, they having ankle brachial pressure index is significant, sir. Less than 0.9.
Okay. Okay. So you think diabetes in a long term may cause cardiovascular disorders or like that?
Yeah, definitely, sir. Definitely, sir.
Okay.
Long-term diabetic with poor control, sir. Long-term diabetic with poor control. That's the thing.
Poorly controlled diabetes, more prone. Very good.
Yeah.
Have you taken the bias factor, just like age, sex ratio, high lipid dyslipidemia, and hypertension? These are whether taken in account or not?
Yeah, sir. Yes, included in studies, sir. Dyslipidemia, hypertension also included in this study, sir.
Okay. Whether you found that diabetes is an independent risk factor for?
Yes, sir. Even diabetic with not only hypertension, even long-term diabetic with poor control, HbA1c and all, sir, more than 8 and all, long-term diabetes, the patient having higher chance of developing peripheral arterial disease, sir.
Okay. Thank you.
Thank you, sir.
All right, good job. Thank you so much for that precise presentation. Next, let me call on oral presentation by Dr. Neeti Mishra from SPB Physiotherapy College, India. The topic is about prevalence of psychosomatic distress and its association with quality of life among patients of non-specific low back pain in South Gujarat.
Good afternoon, everybody. Is my screen visible?
It's coming up, Dr. Neti. One moment. It's not coming up. Oh, there you go. Perfect. Please proceed, doctor.
Is my video visible? Okay. So, good afternoon, everybody. The topic of my presentation is Prevalence of psychosomatic distress and its association with quality of life among patients of non-specific low back pain in South Gujarat. Psychological factors as depression and somatization are considered along with a high level of disability as risk factors for developing persistent low back pain. Furthermore, low back pain and psychosocial distress are two of the most frequent reasons for seeking healthcare and sickness absence. However, over the last 2 decades, there has been increasing evidence for psychosocial and psychological facets being crucial in understanding of pain perception and subsequent disability. It is furthermore suggested that psychological factors, that is emotions, beliefs, avoidant behaviors, are linked to poor outcome of rehabilitation process in low back pain patients. These low back pain related consequences may compromise their quality of life and increase their long-term health care expenses. The DRM, that is Distress Risk Assessment Method, is a simple method of classifying patients into those showing no psychological distress, those at risk, and those who are clearly distressed, either due to primarily somatic or depressive symptoms. The SF-12 is a multi-purpose short-form generic measures of health status. The SF-12 scale can be self-administered by face-to-face personal interview, telephonic personal interview, or by computer. So coming to the need and significance of studies, so with the increasing incidence of low back pain in world and high percentage of these low back pain symptoms becoming chronic despite of new rehabilitation regimes, there is a need for supplementary studies to explore the potential relationship between psychosocial and psychological factors, pain, and their influence on disability. Since little is known about these variables, that is pain, anxiety, and depression, and the quality of life in patients with chronic low back pain, hence, more studies need to be investigated to show the correlations between the psychological factors, that is psychosomatic distress, with quality of life. Now coming to the aims and objectives. So my first aim of the study was to find prevalence of psychosomatic distress among patients of non-specific low back pain in South Gujarat. And the second objective was to find the association of psychosomatic distress with quality of life among patients of non-specific low back pain in South Gujarat. Coming to the methodology part, the study design was cross-sectional with population of 25 to 55 years of age group having chronic non-specific low back pain. The sampling technique used was purposive. The study duration was almost for 6 to 8 months. The sample size calculation was done on the basis of prevalence formula, and it was calculated to be 230. The study setting was different clinical, orthopedic, and physiotherapy OPDs of South Gujarat. Now, the following patients were included in the study. That is, the patients referred with primarily non-specific low back pain, age group 25 to 55 years, willingness to participate, and the patients having back pain for more than 3 months, that is, chronic back pain patients were included. Following patients were excluded, that is, patients receiving any third-party payer funding, patients with any primarily neck pain or mid-back pain complaints, patients with language, reading, or comprehension barriers that would limit adequate completion of the study paperwork. Patients were also excluded due to other reasons, such as scheduling conflicts or other medical issues. Now, coming to the procedure part, patients were initially screened for inclusion and exclusion criteria, as well as for their potential willingness to participate. Potential eligible candidates were selected and were detailed described about the study. Participants with chronic non-specific low back pain who gave their consent completed a battery of questionnaires covering a range of socio-demographic, clinical, and psychosocial features along with DRMS questionnaire and SF-12 questionnaire. Now coming to the statistical analysis part, the software used was version 22 IBM. The descriptive statistics for socio-demographic variables, DRMS score, and SF-12 were carried out. Prevalence was calculated using percentage, and the Pearson correlation was done to find the association between psychosomatic distress and quality of life in non-specific low back pain patients. Now coming to the result part, the mean age of the participant or the subjects was 52.7, the mean BMI was 28.84. Of the total 230 patients, 32.17% were normal, that is, they did not have any psychosomatic distress, whereas 50.43% were at risk for psychosomatic distress, 6.95% were distress somatic, and 10.43% were distress depressive. So overall, the percentage prevalence of psychosomatic distress in non-specific low back pain was 17.38% in age group of 25 to 55 years in South Gujarat. Coming to the tabulation forms, so first we will see table 1 and 2, which actually illustrates the descriptive statistics for age and BMI. So we can very well see that the mean age was 52.70, the mean body mass index was 28.84, the total low back pain duration, which included, of which patients were included, was 136.82. We can also see the classification of the BMI, that is 26.08%, were having the normal BMI, 38.26% were actually overweight, and 22.60% had grade 1 obesity, and 6.95% had grade 2 obesity, and 6.08% had grade 3 obesity. This table illustrates the percentage of the DRMS variables that we actually discussed in the result part. That is 32.17% were actually not having any psychosocial distress. 50.43% were at risk. 6.95% were had distress having somatic symptoms, and 10.43% were distressed but having depressive symptoms. This table 4 illustrates the mean and standard deviation of SF2L physical component summary and mental component summary. Then we have the table 5, which illustrates the correlation between the psychosomatic distress and quality of life. Here we see that the Pearson correlation have been used, and the p-value is 0.001, which shows that there was significant correlation between the psychosomatic distress and the quality of life. Here we see that there was a positive relation between SF12 PCS and SF12 PCS and DRMS, whereas there was a negative correlation between the SF12 MCS, that is mental component, and the DRMS. These are the graphs which shows the significant correlation of the SF12 physical component summary and mental component summary with the psychosomatic distress. Now coming to the discussion part. So clinical and psychological research tends to give greater self-expression to patients about the level of their health in many domains, where many researchers have studied the quality of life for patients suffering from chronic diseases and pain, including chronic low back pain. Many studies have indicated that there is a decline in the quality of life in people with chronic low back pain. Even there are several studies that have confirmed the correlation between them. Now, in the present study, the significant correlation was found between psychosomatic distress and quality of life in non-specific low back pain patients. So there are also studies which reinforce the data that patients with lumbar spine signs and symptoms have a high prevalence of anxiety and depression, and therefore any professional who treats those patients should take psychosocial factors in considerations. The World Health Organization also considers low back pain to the leading cause of disability, low quality of life, and low performance. And the majority of the cases are non-specific cases, and back pain is one of them. So mostly the psychological problems, they arise in the chronic stage. So we can think that when a low back pain is becoming chronic, then we should think of that some psychological problems may be in the patients. So also, Hong et al. Conducted a study in Korea recently published to assess anxiety, depression, sleep problems, and healthy quality of life in patients with low back pain. The study concluded that patients with chronic low back pain exhibit a marked functional disability and a significant decline in the mental state, and a marked decline in the quality of healthy life. The study recommended that patients should be evaluated in order to provide appropriate psychological care. So coming to the conclusion of the study, so the study concludes that there was significant correlation between psychosomatic distress and quality of life in non-specific low back pain patients. The percentage prevalence of psychosomatic distress was found to be 17.38% in age group of 25 to 55 years among chronic non-specific low back pain patients in South Gujarat population. There are some limitations to this study. So the information bias might have influenced the data collection, whereas all information about mental health was collected as self-administered questionnaires. Although the participants were instructed thoroughly before filling in the questionnaires, there is a tendency to give socially acceptable answers to questions regarding behavior and mental health. So this influence might have led to an underreporting of the impact of psychosocial variables. Now, future recommendations. So future research should focus on how to address the impact of psychosocial strain in treatment strategies for this group of patients, and conducting studies on integrated psychological therapy programs with doctors and physiotherapists in order to achieve the desired priority in the treatment of patients with chronic low back pain and related psychological symptoms, especially anxiety. And definitely, the author would like to acknowledge the cooperation of the participants in the data collection process. So references, and thank you. Any questions?
Thank you so much. Any questions from our chair?
It's a very nice study, and also previous studies also show that near about 1/5 to 1/4, around 20 to 25% of the people of non-specific pain also they develop depression. What was the scale used for your assessing depression?
Sir, I have used a distress and risk assessment method. So this distress and risk assessment method is basically a screening method of screening the questionnaire for the psychological assessment. So this questionnaire consists of modified Jung depression questionnaire and modified somatic perception questionnaire. So when we combine, if the modified somatic perception questionnaire, the score is more than 12, then the person will be considered normal. And if the in modified Jung depression, if the score is more than 17, the person will be considered as normal. So we have taken both the somatic and the depressive symptoms into account. So if whether the patient is having only somatic symptoms, so we have isolated that also. And if a patient is having depressive symptoms, then we have isolated that also. So if we screen at the first stage the chronic low back pain patient, that whether they are suffering from any somatic or depressive symptoms, then definitely we can refer to them to the psychological care, and also as a physiotherapist or doctors, we can have a better treatment rehabilitation regime for them.
Thank you.
Thank you so much. Thank you so much, Doctor. All right, let me go ahead and call on the next presenter, oral presentation by Pooja Motar from MGM School of Physiotherapy, India. The topic is about effects of high voltage pulsed galvanic stimulation for constipation in acute stroke, a randomized clinical trial.
Is my screen is visible?
Yes, it is. Go ahead, please. Share your screen. I'm sorry, proceed.
Good afternoon to all the chairpersons and participants. I'm Dr. Pooja Motar, Assistant Professor from MGM School of Physiotherapy. So my today's topic is effect of high voltage pulse galvanic stimulation for constipation in acute stroke, a randomized clinical trial. Introduction. As we know in the stroke, it is a cerebrovascular accident in which there will be reduced blood supply to the brain, leading to loss of consciousness and functional impairment in the patient. So the prevalence of stroke is globally increasing, with a predictable 70 million new cases anticipated by 2030. In 2020, the stroke has accounted for 6.3 million deaths and ranked second in the list of death due to any diseases. As we know, when the patient is suffered by stroke, it comes with disability and many complications. Among that, recently it has been found, the literature has suggested that constipation is a common symptom among patients with cerebrovascular disease. So the patients with acute stroke are more vulnerable to the development of various complications. The presence of even one medical complication leads to an independent predictor for poor prognosis and severity and type. Literature have shown that according to the stages of stroke, that is acute, subacute, and chronic, it was found that 41.6% has constipation in acute, 31.5% in subacute, and 22.6% in chronic phase. Whenever the person suffers from stroke, it affects the brain-gut axis. This brain-gut axis helps in maintaining the brain-gut interactions which are responsible for the motility and secretion of gut. When the patient is suffering from stroke, they have affection in this brain-gut axis, which leads to constipation in these patients. There are various factors which also influence, which hello. Hello. Hello, ma'am.
Yes, sir. Yes, doctor.
I'm audible, ma'am.
Yes, you are.
There are various factors which are also responsible for the constipation are hypothermia, dysphagia, insufficient intake of dietary fiber, physical activity, side effects of medications, which leads to constipation in stroke. All these factors affect the bowel emptying, peristaltic movement, and absorption capacity of the gut. The patient suffers from painful bowel movement, rectal burning during or after a bowel movement, rectal bleeding, and incomplete bowel movements. All these leads to the negative effect on physical, social, and psychological functioning and quality of life in patients with acute stroke. So the need for the study will be helping in improving the physical, social, psychological, and quality of life in patients with acute stroke having constipation. It will also help to raise the awareness among physiotherapists about the intervention for constipation in acute stroke. Because most of the people knows that the constipation has problem in chronic stroke, but recently the research article says that patients also have constipation in acute phase. As well as rehabilitation, many physiotherapists ignore and forget to consider bowel management in these patients. The findings from this study will be a baseline data for interventional boon in the patients of acute stroke having constipation. This would help the physiotherapist in beneficial and management and benefiting the patients for favorable outcomes in constipation. This study will help and motivate future researchers for more large-scale studies, including interventional research such as longitudinal studies, etc. The aim of the study was to assess the effect of high voltage pulse galvanic stimulation and conventional physiotherapy exercises for constipation in patients with acute stroke. These were the review of literature for my study. These reviews supports that there is a prevalence of new onset of constipation in acute stroke, and which is also related to the dependence and use of bedpan during defecation. Then materials and methods. This study was conducted into the tertiary care hospital of Belgavi. The study design is pre-post study design, and it is a randomized clinical trial. The targeted population was both male and female who had constipation in acute stroke. Duration of data was 12 months and the sample of size was 28. The collection of sample was by non-probability sampling and convenience sampling. The instrument which was used in this study was high voltage pulse galvanic stimulator machine, which is a short duration and low frequency current with high voltage, having frequency of 1 to 20 microseconds and with voltage of 0 to 150 microvolts. This was the portable machine which I have used in my study. Then the inclusion criteria. The patients were included on the basis they were willing to participate in the study. Diagnosed from the Rome second criteria. This is the criteria to diagnose the patient on whether he is having constipation or not. So the Rome second criteria defines constipation as fewer than 3 bowel movements per week. It includes subcategories, that is straining in defecation, lumpy or hard stools, sensation of incomplete evacuation, anal obstruction, manual maneuvers to facilitate. And then the third is all type of stroke, both male and female above 18 years, first onset of stroke, able to understand the commands. The patients who have cardiovascular, respiratory, structural diseases in rectum or colon, prior history of constipation, disturbance of consciousness, and any other congenital, malignant, autoimmune disorders were excluded. The outcome measures which were included in the study were patient assessment of constipation symptom questionnaire. It was a 12-item questionnaire having reliability of 0.70. The patient second outcome measure was patient assessment of constipation quality of life questionnaire, which was 28 items questionnaire, and the reliability was 0.9. Procedure. The Institutional Ethical Committee gave the ethical certificate for the proposed study. Before the enrollment of the subject, they were segregated based on the inclusion and exclusion criteria. The aim and procedure of the study was explained to the patient and their caretaker, and written informed consent was taken. And the pre-post values of all the outcome measures were assessed. This is a flow chart showing the allocation of the patients. In beginning, 34 patients were screened, out of which 6 were excluded on the basis of inclusion criteria, and they were randomized. The remaining 28 were randomized into 2 groups, Group A and Group B. The Group A received high voltage pulse galvanic stimulation, whereas Group B received conventional physiotherapy exercises. In each group, there were 14 patients. Intervention. Group A received HVPG stimulation, which was given for 30 minutes, 3 sessions per week over a period of 3 weeks. And the patient was in supine lying position. Group B received conventional physiotherapy exercises that was also for 30 minutes, 3 sessions per week over a period of 3 weeks. It included isometric abdominal muscle training and abdominal massage, which was along the sigmoid colon, ascending colon, and descending colon. So also, in the end, both the groups were recommended to follow the dietary modifications, which were fiber intake of 250 grams and 1 to 2 liters of water every day. Statistical analysis was done by SPSS version 23. The homogeneity of the data was checked by chi-square test for gender, age, and BMI. The comparison of outcome measures within the group was done by dependent test, and between the group was done by independent tests. These are the result of the study showing within the group for the outcome measure. Within the group, the results showed that the values were highly statistically significant for both symptoms questionnaire and quality of life of the patient. The table 2 shows the values regarding between the group for the symptom questionnaire and quality of life. Between the group, it showed the significant values were seen for the symptoms, whereas there was no significant difference seen in the quality of life between the group. Discussion. As the result of study showed that the symptoms, there were improvement in the constipation symptoms in patient with acute stroke. The group A showed improvement. That can be because the possible reason can be HVPG current, which has a short duration and low frequency, leads to stimulation of deep neuroendocrine nerves. As it helps in stimulation of deep neuroendocrine nerves, which can lead to the increase in gut motility and decrease the clonic transit time. The group B received, the group B also showed improvement in the symptoms of constipation. This could be because this could be due to the abdominal exercises, which causes the indirect synergic activation between pelvic floor and lower abdominal muscles, leading to defecation. Also, the slow circular clockwise movement along the line of colon in the abdominal massage, which helps to promote clonic and rectal motility to train intestinal function. The result of the study showed that the quality of life was significantly improved in Group A. The probable explanation for this can be the stimulation observed in HVPG is also a monophasic pulse with a double peak configuration current, which recruit type 1 and type 2 muscle fibers, thereby increasing the strength of abdominal muscles and the patient's improvement in the patient's symptoms of constipation. In the current study, it was shown that quality of life was not significant, but there was clinically it was a clinically significant in quality of life. This can be because of the neurological effect of conventional physiotherapy exercises, which help in activation of stretch receptors and reinforcing the gastrocolic reflex, causing increase in motility of gastrointestinal tract. Conclusion. The present study concludes that HPPG and conventional physiotherapy exercises were beneficial in betterment of symptoms and quality of life in subjects with constipation in acute stroke. Furthermore, it was observed in between group comparison, high HPPG was more advantageous than conventional physiotherapy exercises in terms of symptoms improvement. Limitation of the study was neither the subject nor the physiotherapist were blinded. This would have prevented the biasness in the present study. A long-term follow-up could not be assessed due to short duration of the study. Future scope, the study can be taken up to assess long-term effect of high voltage pulse galvanic stimulation in acute stroke subject with constipation. These are the references. Thank you.
Thank you so much for that presentation. Question from our chairs.
It's a very nice presentation and also treatment along with this improvement of quality of life. I request Dr. Srikant Sahu, please ask question.
Yes, thank you, sir. Actually, this is a very good study actually, because we are seeing constipation is mostly affected also in the acute stage, not on the chronic stage. But the only demerit is during chronic stage, actually the other disorders like diabetes, hypertension, other risk factor, these are the other risk factors for stroke. But this will also contribute to the chronic constipation. So if the study will be conducted in acute stroke with acute constipation without any history of any constipation before, then it will be more beneficial. And also this is mostly because we are not observed this actually, because we are most of the physiotherapists usually keep this bowel care. Okay, so this is a very good study, and if further studies will be known, further study with a longer with a large group, not only the 28 cases are only taken. So in a large study, it will be beneficial.
Yes.
We can conclude whether it is beneficial or not.
Yes. Yes.
Okay. Thank you.
Thank you so much. Next, let us proceed with an oral presentation by Dr. MJ Haja Abdul Nazir from Vinayakam Mission Medical College, India. The topic is about prevalence of leptospira serovirus among the icteric patients in the coastal region of Karaikal.
Good afternoon, madam. Thank you for this opportunity. Good afternoon, sir. Good afternoon to everyone, sir. Sir, am I audible?
Yes, you are, and I can see your screen. Please proceed.
Yes, madam. Thank you. Thank you very much. So here I'm going to present my topic about the seroprevalence of leptospira among the icteric patients in the coastal region of Karaikal.
Go ahead, and please have it in presentation mode. Thank you. There you go. Perfect. Yes. Proceed, please.
Yes. So coming to the introduction of the study, leptospirosis is an emerging zoonosis caused by the pathogenic Leptospira species. Usually it is called as a Weil's disease, and the most common source of this infection is the contaminated soil and water with the urine of carriers. These carriers are nothing but the rodents, dogs, cattle, pigs, etc., which is having this organism in the urinary tract, which can be shed in this soil and water and can access the source for infecting the human beings. And those persons who are getting exposed with this contaminated environment are most prone to this infection and can lead to the leptospirosis. And this can be also caused as a occupational hazard among the farmers, sewage workers, animal handlers, etc., where they are frequently having this contaminated environment, handling this contaminated environment and getting infected often. Here, the person-to-person transmission of this organism, Leptospira, is very, very, very rare, because here human access the dead end of this organism. So there is no chance of transmission from one patient to another patient. Here, the incidence of leptospirosis is most common among commonest thing in the post-monsoon period. Here, the patients are having some characteristic features such as febrile illness, which is the most common thing, and then headache, continuous fever with the prostration, severe myalgia, and some patients may have the conjunctival suffusion also. Here, the patients who are not treated properly, in due course, they may lead to certain complications such as meningism if the organism attends to the brain, and then jaundice also having the possibilities of jaundice, and then hemorrhages may be this may lead to hemorrhages, and then renal failure, cardiac arrhythmias, muscle weakness, etc. These are the major complications which the patients can may get during the disease progression. And leptospirosis is usually underdiagnosed because of lack of awareness among the diagnosis, and then we are having the varied clinical spectrum of diseases which is having the same characteristics, and very difficult to diagnose also. Okay, so these are the major complications. I mean, these are things which because of which we are not going for the diagnosis of leptospira. Hence, this leptospirosis, even the patient is having the leptospirosis, it can be treated as a pyrexia of unknown origin, PUO. But we are having some molecular techniques which we can use to detect the leptospirosis in the early period, but it is not often used for the diagnosis of leptospira. But if the leptospira is diagnosed early, means the early diagnosis and then appropriate treatment will halt the disease progression and also will reduce the morbidity and mortality rate among the infected patients. This study aims to explore the seroprevalence and the clinical features of leptospirosis in patients with the acute febrile illness from the coastal region of Karaikal. Here, the objective is to detect the seroprevalence of leptospira, means the leptospira IgM antibody by using the ELISA method. Coming to the methodology, it's a randomized prospective study conducted in Department of Microbiology in Medical College, Karaikal, for the period of 2 years. Here, the patients, the recruited patients, the febrile illness patients who are attended the medicine OPD from the coastal region of Karaikal were included in this study. Here, the sample size is about 195 patients are included in the study who are having the illness for about 7 days, acute febrile illness for about 7 days. The blood sample was taken from the 195 patients, and it was the serum was separated from those patients and was being tested for the IgM antibody against the leptospira by using the ELISA method. Coming to the results of the present study indicates 19% of the patients who are visited the medicine OPD with acute febrile illness for about 7 days of illness were being identified with the seroprevalence of anti-leptospira IgM antibody. Here, the male is having the preponderance of male was about 25 patients was observed as seropositive when compared to the females, where it is 12 only. The majority of the leptospirosis patients were belong to the occupation of fishing and related activities, other related activities such as agriculture with 8%, sorry, 21%. The common clinical presentation were found to be the myalgia and the jaundice. Some patients may also having the co-infections along with the leptospira, which is recorded at 15%. So this is the results of based on distribution of leptospirosis patients based on the occupational. Here, fishing occupies the major occupational hazard with the 33 point means around 34%, and followed by the agriculture 20%, nearly 20%. So since it is a coastal region, patients who are coming to our college are mostly the fishermen. Hence, this occupational hazard is more towards the fishing. And distribution of the patients based on the clinical features. Here, the fever already usually fever is the major means symptoms, most common symptoms, and myalgia occupies the most common symptoms apart from this fever with a 93%, and jaundice occupies the second thing with the 83%, and followed by the headache, chills, rigors, hepatomegaly, oliguria, abdominal pain, etc. And among the study population, 11% of the patients were having the conjunctival suffusion, which is very rare. Coming to the conclusion of this study, in our study, the seroprevalence of leptospira was found to be 19% among our study population, and the prevalence of the leptospirosis was observed in people involved in fishing area and related activities, followed by the agriculture workers. Thank you, madam.
Thank you so much. Any questions from our chair?
So this is a study where we are able to see the leptospirosis sexual zoonosis related infections very much prevalent in the coastal area. But thing is that how randomization is being done, because actually when the patient presents with fever, and second is being most important problem complication is with the jaundice.
Yes,
how randomization is being done?
So here the randomization is nothing but the patients who are having all inclusion criteria. All the patients who are having 7 days of illness are included in the study. Like that it was done. So here no point of randomization itself, but it was put as mistakenly mentioned mistakenly.
Okay.
Thank you so much. Let me go to proceed with our next presenter, an oral presentation by Dr. Vivek Harsukbhai Ramanandi from SPV Physiotherapy College, India. The topic is about impact of shoulder pain and disability on the quality of life among cerebrovascular accident patients of Surat, Gujarat.
Am I audible?
Yes, you are, and I can now see your screen. Please proceed, okay. Doctor.
Thank you. So, good afternoon, everyone. My topic of today's presentation is impact of shoulder pain and disability on the quality of life among cerebrovascular accident patients of Surat, Gujarat. It is a as we all know, cerebrovascular accidents can be defined as clinical syndrome, which consists of rapidly developing clinical signs because of focal disturbance of cerebral function, which are lasting more than 24 hours or may be leading to death without apparent cause other than the vascular origin. Worldwide incidence of severe cerebrovascular accidents has been estimated to be 1.5 to 2 per 1,000 population, whereas in India, the estimated prevalence is 2 to 2.5 per 1,000 population, which is higher than the global statistic. The impairments which are associated with cerebrovascular accidents can be classified under various headings, which may include motor, sensory, balance and postural control, speech, language and swallowing, bladder bowel problems, cognitive and perceptual, as well as some other secondary impairments. Now, when we talk about shoulder pain after the cerebrovascular accident, it is commonly known as post-stroke shoulder pain, which is found to be affecting around 70 to 75% of patients within first 12 months after episode of CVA, and it has been proven to be associated with poorer outcomes and increased length of stay in hospital. Therefore, in the previous studies which have been done, it has been suggested that the shoulder pain associated after CVA, it interferes with performance of self-care, balancing, transfer and ambulation related activities. Thereby, it is affecting the overall rehabilitation process, and ultimately it is going to affect the quality of life. There have been 3 different mechanisms which have been proposed in various studies. First one is because of loss of motor control and development of abnormal movement patterns, there is going to be shoulder pain development. Then second mechanism which is been proposed is because of the secondary changes in surrounding soft tissues. And third one is because of the glenohumeral joint subluxation because of the paralysis or paresis of the shoulder musculature. Now, as I have already told that because of the data which we have gathered in the previous studies which were done across the globe, the post-stroke shoulder pain and quality of life have been found to be correlated. There have been studies which are suggesting that compromise in quality of life among the patients after CVA who are having shoulder pain, which has been described. But it is not clearly established if it is directly related to the severity of the pain or higher degree of shoulder impairment, or if it is because of the other factors. When we know the physiotherapy can play a vital role in management of shoulder pain in all the conditions, even musculoskeletal or neurological, it becomes a major responsibility of a physiotherapist to understand how the shoulder pain in post-stroke patient is presenting itself. So it has to be understood that how the shoulder pain is exactly impacting the quality of life of a patient and how it is going to affect the rehabilitation process. But as we can see, there has not been many studies which have been exploring these kind of aspects. That is the indicator point when we came across that we have to do this study. So the need of this study was to fill the gap of knowledge and ideas which are currently presented in the field of post-stroke shoulder pain in India. And the objective was to assess the impact of shoulder pain and disability on quality of life of cerebrovascular accident patients in Surat city of Gujarat state. Now, this study design was cross-sectional survey design where population included CVA patients attending neurorehabilitation and physiotherapy centers, including private, hospital-based, college-based, or home-based physiotherapy setups in Surat city. Sample size, sample of convenience included 170 subjects. Inclusion criteria, both male and female patients between age of 45 to 65 years and having cerebrovascular accident for more than 1 week were included, who were having complaint of shoulder pain and who were ready to give informed written consent. The subjects who were unwilling to participate or were mentally ill or were having speech problems or associated serious pathological disease such as tumors or tuberculosis were not included in the study. Data collection, assessment and outcome measures, standard demographic questionnaire for basic demographic details of the patient was included along with the shoulder pain and disability index PADI and Gujarati version of WHO quality of life brief questionnaire. Invitation for this following image is showing the process of flow of the patient. First, the patient or participant were invited, then they were explained in detail regarding the study and were screened for inclusion and exclusion. After that, they were requested to sign an informed consent, and then after the assessment cum data collection sheet was filled up by the patient. Then the data was stored and analyzed using a statistical software. When we look at the result, the study sample included 170 subjects, out of which 63.53%, that is 108 patients were male, and majority of the subjects, that is almost, if we look at the summated figure, it is almost 60%, which is from the age of 51 to 60 years. Right dominant patients were affected more, and majority of the cases, that is 54.12%, were of the ischemic origin. Now, these are the domain scores, pain domain and disability domain scores for SPADI, and the total score, which was the summated score of both the domains. WHO quality of life brief domain scores. WHO quality of life includes 26 items in 4 different domains: physical health, psychological health, social relationship, and environment. And these are the mean scores and standard deviations for the same. Now, as per the objective, Pearson correlation between the SPARDI scores for pain, disability, and total score were correlated with WHO quality of life brief, as it is visible that pain scores were found to be statistically significantly correlated with the psychological health domain and the social relationship domain. Disability scores were found to be correlated with the physical health domain and social relationship domain, whereas total score were found to be correlated with the physical health and social relationship domains. Now we are coming to discussion. First of all, we'll discuss about the demographics of the study population. As we already seen, male subjects were more, approximately 64%, which were predominantly affected by the CVA. Around approximately 55% cases were of the ischemic pathology, and 60% of cases were found to be in the age of 51 to 60 years. These are the findings which were similar to the findings which were reported by Ratna Sabapathy and his colleagues in 2003. They conducted a study in hospital-based population and found out these factors that male are affected more, and ischemic pathology is the commonest reason for CVA. The studies in different countries at different times also report the similar findings. Here are limited references. They are showing the findings in terms of gender and type of strokes, which are similar to our study. And this is suggesting that the global characteristic of people affected by CVA are almost similar. Now, when we come to shoulder pain and disability, we can see that 61.43%, that is 61% or 104 patients out of total 170 patients reported presence of shoulder pain, suggesting high prevalence of shoulder pain in stroke patients. Right hand dominant person were affected more. Out of 104 patients, 72, that is approximately 70% patients were affected, who were affected with shoulder pain, were having pain in right shoulder. Around 34% patients suffered from moderate to severe pain. Roy, Wanklin, and John, these are the 3 authors we have, who have already conducted studies, and they have reported the prevalence of shoulder pain to be in the range of 5% to 84%. So our prevalence of 61.43% is within the range. This is a wide range, and it definitely depends upon the population which they have studied. Now Johnson and his colleagues performed study in 2006 in Sweden, and they also reported that 30% participants had constant pain, whereas 68% of participants had intermittent pain following the post-stroke situation. Now, if we discuss correlation of shoulder pain and disability, we saw that there is a significant correlation between pain and the psychological and social relationships domain of quality of life scale, and also the significant correlation was found to be between the disability and physical health and social relationship domain. Total SPARDI score was also found to be correlated. Now, all the correlations were found to be negative, suggesting there is inverse relation between the variables. That means more the shoulder pain or more the disability, lower the shoulder disability, lower the quality of life. Similar findings by Francisco et al. In 2009. They reported poor quality of life in stroke patients who had shoulder pain, because they, as per their findings, they suggested that shoulder pain is restricting patients' daily life activities and after the stroke. Azigul Barlak in 2009 also reported similar findings, suggesting
2 minutes more.
Yes, sir. Shoulder functions on affected side affects recovery as well as quality of life. And Nissen and his colleagues also reported that basic activities of daily life affected the quality of life, because the shoulder pain and disability is correlated to performance of basic activities of daily life. So in conclusion, we can see at least 97 patients suffer from shoulder pain intermittently. Most of them had been suffering from mild to moderate disability, and shoulder pain affects psychological health and social relationship in hemiplegic patients, where pain-related disability was also found to be affecting physical health and social relationships. Recommendations for future study that we can cover larger sample size and intervention to treat shoulder pain can be applied and compared with a control group. Clinically or research-wise implications, physiotherapy, as we know, plays a vital role in shoulder management, and findings of this study may be helpful for physiotherapists to focus on the prevention and curative aspects of the shoulder pain in post-stroke subjects. So patients can be more benefited and rehabilitation as a whole can be more effective. These are the references. Thank you.
Thank you so much. Questions from our chair.
I request Professor A.V. Srinivasan, please ask question to this presenter. A.V. Srinivasan is there?
You're on mute, sir. Srinivasan, Professor.
Please
you're
unmute your mic. Oh.
There you go.
Hello.
Yes, sir.
Hello.
Yes, sir.
Yes.
Yeah. Once again, what is the methodology that you used?
Sir, basically we used a cross-sectional survey method where we
Yeah, you know the limitation of the cross-sectional study?
Yes, sir, definitely.
What is it? But you could have just added it in there. And
sir, as our primary aim was just to find out how the shoulder pain is correlated with the quality of life that is perceived by the post-stroke patients, we found the methodology to be suitable for this study.
Anyway, that's fine. But
Yes.
What type of quality of life you used? Well, there are so many quality of life.
Yes, sir. Sir, we used WHO quality of life brief, which is indicating quality of life of patient in 4 different aspects. First one was physical. So as we saw that pain was not directly found relevant to the physical health aspect. It was majorly found to be relevant with a social relationship and psychological domains. So it indicates pain is affecting patient's perception and feeling of quality of life, which the patient is perceiving to be living. Whereas the disability, which is associated with the shoulder pain, was correlated to be found to be correlated with the shoulder pain. So which is indicating physical pain is because of the disability, and disability may affect the physical pain of the patient.
What is the limitation of the pain understanding? Pain, is it an emotion?
Sorry, sir?
What is the limitation of using the pain score? Have you analyzed?
Yes, sir.
What did
Sorry?
you use for assessment of the pain? How much severe it is? Did you use that?
No, sir. Basically, sir, SPADI can be used in 2 different ways. It can be in the visual as well as numerical, both the way. But we did not use numerical one, so we could not find out the exact severity.
Exactly, because that will also give you a very good additional point of view.
Yes, sir. Yes, sir.
It's a lovely one. You are from the physiotherapy school of?
Sir, I am from the SPB Physiotherapy College, Surat.
Surat, I see.
Yes, sir.
Excellent, excellent. Because
Thank you.
very common pain, the shoulder pain. Thank you.
Yes. Thank you.
All right, thank you so much. Thank you so much. And let me go ahead and call on our next presenter, oral presentation by Dr. Tanvi Banker from SPB Physiotherapy College, India. The topic is about correlation of functional independence and return to work in patients with chronic polyneuropathy.
Okay. Good afternoon, everyone. Am I audible to everyone?
Yes, you are, doctor. And I can see your screen. You may proceed.
Okay. Good afternoon to chairpersons and all the co-partners. Myself, Dr. Tanvi Bankar, and I am presenting paper on the correlation of functional independence and return to work in patients with chronic polyneuropathy. Okay, so first we will take a brief idea regarding what is chronic polyneuropathy. So, as we all know, it is autoimmune. So, chronic inflammatory demyelinating polyneuropathy is a chronic acquired immune-mediated condition affecting the peripheral nervous system. So, it might be diabetes induced, it might be alcohol induced, or it might be due to any drug, or it may be idiopathic also. And its gross symptoms are it is progressive, it affects the proximal limb weakness, and bilateral limb weakness will be same. It affects the proximal joints more than the distal one, and sensory loss is more in the lower limbs compared to upper limbs. Then, what is the patient's main complaint regarding chronic polyneuropathy? So, patient might feel difficulty from sit to stand, from sitting from the chair to getting up. Then, patient might find difficulty in the walking or stair climbing. Patient might have fear of falls, so that we can correlate with the balance issues. Then there will be reduced manual dexterity, so fine functions might be affected. Affected adults usually between 40 to 60 years of age. Men are affected more than the women, and its prevalence is quite less, that is 2 to 5 cases per 1 lakh individuals. Residual weakness will be persistent, and there will be difficulty in navigation, and sensory symptoms may be quite disabling. That means fine functions are grossly affected. So person might have difficulty in return to work. And the need of this study is to assess return to work status in patients with chronic inflammatory demyelinating polyneuropathy, as there is no evidence available for the same in the same population. Okay, so basically aim are 3 to find out the functional independence in the CIDP patient, to find out the return to work capabilities in the same population, and to find out the correlation between both, that is functional independence and return to work capabilities in the CIDP patient. If we discuss regarding hypothesis, so there is null and alternative hypothesis. So null hypothesis suggests that there is no correlation between FEAM and return to work capabilities, and alternative hypothesis suggests that there is a correlation between the functional independence measurements and the return to work capabilities. Now we'll switch over towards the methodology. Okay, so source of the data were general hospitals of the Surat, and patients who were diagnosed with the CIDP more than 6 weeks. Study design was correlational study design. Study duration was of 3 months. Sample size was 27, and sampling technique was the convenient sampling. Okay, inclusion criteria were patients who were more than 18 years of age, both male female were included, who was diagnosed with the diabetic, alcoholic, toxic, and paraprotein associated demyelinating polyneuropathy. Patients diagnosed with polyneuropathy more than 6 weeks old. Patients who was working prior to the disease. And the exclusion criteria of the study were if the patient is suffering from any of the neurological or orthopedic conditions other than the CIDP were excluded. For example, if the patient was suffering from the Parkinsonism, stroke, TBR, or patient suffering with the any of the orthopedic condition, that is fracture or severe osteoarthritis, because this condition also affects the FEAM score, and that will hamper our results. So they were excluded. Now we will switch over to the procedure. So this is the basic flowchart of the procedure. CIDP patients were selected based on the inclusion and exclusion criteria. Nature and purpose of the study was explained to them prior to the study. Informed written consent was taken in the vernacular language, that is in Gujarati. Assessment of severity of peripheral neuropathy by overall neuropathy limitation scale was taken. Assessment of functional independence by FEAM scale, and return to work questionnaire was given to the subjects. Now we'll move towards the result portion. So result data analysis was done by SPSS 60. severity of polyneuropathy was correlated with PIM and return to work using Pearson correlation coefficient, and significance level was 5%. So this is the table showing the demographic data. Gender, male and female were taken. Males were 19, female were mean age of the patients were 43.35, and mean duration of the condition was 72 weeks. This is the graph showing the components which was affected most in the PIM score. So according to graph, we can conclude that locomotion and transfer were affected most than the other components. Then third lastly affected the self-care and the sphincter activity. But the communication and social cognition has no effect in the CIDP patient. This is a pie chart correlating with the functional independence and return to work capability. So here 4% of the people return to work without any modification in that occupation. Then 78% for a person return to work with modification, and 18% individual was not able to return to work with the modifications also. This is the table showing the correlation of PIM with the severity and return to work capability. So here there is a comparison of overall neuropathic limitation scale and return to work capabilities along with the PIM. So for both, the level of significance was less than 0.001. That means it is clinically significant. And correlation coefficient, Pearson correlation coefficient for ONLS was 0.796. That means it is strongly correlated, or it is having strong positive correlation. And return to work capabilities is having Pearson correlation coefficient 0.42. That indicates it is having moderate positive correlation with the PIM. So from that, we can switch over to the discussion portion. So discussion portion, study proves that patients who are functionally dependent do not return to work, and patients who are functionally independent returns to work normally or with modifications in that activity. The most affected domain of the PIM was mobility. This restricted the functional independence and return to work status. This is the comparison of few relative studies. So R. Prasad et al. In 2001 did study in the same population and concluded that the mobility, that means transfer activity, is affected severely, that is indirectly related to the return to work capability. Kenneth C. Grosson in 2012 did study in the same population and found that there is a difficulty in walking and mobility based on the PIM scale. So this is the study also supporting the present study. Then Barbara Wolfen and Marty Grace did study in the same population in 2009, in which they found that return to work capabilities is directly reflected by the PIM score and mobility is affected in the same. And Seketi et al. Also did study in the 2000, in which they took the population of stroke, in which return to work capability ratio was 7 to 84%. That means there is a quite variation. In this study, most patients return to work with some kind of modification. This may be due to most affected patients are male. The mean age, that is 43.35 plus or minus 1.17, where most patients are bread earners of the family. As males are affected, no, they are to be considered as a bread earner of the family. So they need to be returned to work with some modification. So that might be the reason of return to work of patients of 78%. Severity of chronic polyneuropathy affects the functional independence. So this is our conclusion, that there is a direct correlation between independence and the return to work capabilities. So severity is more than return to work capabilities will be less. It ultimately affects the status of return to work. So lastly, what might be the clinical implication? So working on severe polyneuropathy patients in terms of functional independence will help patients for return to work. And these are the references. Thank you.
Thank you so much. Question from our chairs.
So Dr. Srikanth is requested to ask question.
Actually, I'm confused about the study trial actually. What you have studied actually chronic, you are first telling CIDP. CIDP is a different term, different item which has been divided, which has a different, and the incidence is very less. And second is chronic severe polyneuropathy is another term. Yeah, can you show me the inclusion criteria?
Yes, sure. These are the inclusion criteria.
Because you are telling that more than 18 years male female and most severe neuropathy with diabetic, alcoholic, toxic and paraprotein. So usually this diabetic neuropathy, alcoholic neuropathy and toxic neuropathy, these are not actually CIDPs, chronic inflammatory polyneuropathies. These are the other terms of neuropathy, which is called polyneuropathy, but not inflammatory polyneuropathy. These are not inflammatory.
Yes, sir, but they were included.
They are implemented. So you should tell that not CIDP, chronic inflammatory, severe polyneuropathy affecting this quality of life and this return to work. Okay. The study should be like that. And study population is also very less. Actually, only 28 cases you have taken, and these are the only limitations. And because you have to modify the title actually, but the study is good, but you have to modify the title. Nothing to do.
Okay. Thank you.
Thank you so much. And let me go ahead and call on our next presenter. This is a poster presentation by Dr. Ilakia M. from Vinayakam Mission Medical College, India. The topic is about efficacy of intravenous iron sucrose over oral iron therapy for anemia in pregnancy.
Ma'am, is my slide visible, ma'am?
Yes, it is visible. Please proceed.
Good afternoon. Good afternoon, ma'am. My topic is on efficacy of intravenous iron sucrose over oral iron therapy for anemia and pregnancy. I'm Dr. Vilakya from Vinayakam Mission Kribananda Warrior Medical College, Salem. Background: iron deficiency anemia is the most common nutritional deficiency in pregnancy, which influences the health of the mother and developing fetus with major morbidity and mortality throughout our country. Intolerance to oral iron, inadequate absorption, and side effects leading to poor compliance are the major shortcomings in oral iron therapy. To overcome all these limiting factors associated with oral iron therapy, parenteral iron therapy is preferred. Objectives: to know the efficacy of intravenous iron sucrose over oral iron therapy for anemia and pregnancy. The hemoglobin levels before and after 6 weeks of treatment in both the groups were compared. Materials and methods: a prospective study was taken up to compare the efficacy of intravenous iron sucrose over oral iron therapy in 50 antenatal women with iron deficiency anemia attending ANC OP, Department of Obstetrics and Gynecology, Salem. Cases belonging to gestational age of 28 to 34 weeks with hemoglobin ranging from 7 to 9 grams, irrespective of gravida, were chosen and are divided into 2 groups, managed either with oral iron tablets and or with IV iron sucrose therapy. Group A, oral iron tablets, that is ferrous sulfate 100 mg with 500 microgram of folic acid is given daily, which contains 60 mg of elemental iron. It is given 3 times a day. Group B, IV iron sucrose 200 mg and 200 ml normal saline IV infusion on alternate days, that is 3 days per week is given and calculated by the formula body weight in kg into target hemoglobin, that is 14 gram per deciliter minus initial hemoglobin into 2.4 plus 500 milligrams. Blood investigations were done in our hospital laboratory and the hemoglobin and the blood indices level before and after 6 weeks of treatment in both the groups were compared. According to the results, total number of patients were 50 antenatal cases. Oral tablet were given to 25 cases and IV iron sucrose infusion was given to 25 cases. According to the age, the women were between 20 to 30 and the mean age group is 24. According to the gestational age, we have selected 28 weeks to 34 gestational age and the mean age group was 32. By giving oral iron before treatment, the minimum hemoglobin was around 7 and the maximum was around 9 and the mean was 7.8. After treatment with oral iron therapy, the minimum hemoglobin was 9.8 and the maximum was 10.6 and the mean was found to be 10.2. Group B, by giving IV iron sucrose, the treatment before treatment, the hemoglobin was 7 and after treatment, the hemoglobin was 10.2 and the mean range was 10.8. In this study, the mean baseline hemoglobin were 7.9 by IV iron sucrose and 7.8 gram per deciliter by oral iron, whereas post-treatment hemoglobin after 6 weeks showed a mean value of 10.8 gram per deciliter by IV iron sucrose and 10.2 gram per deciliter by oral iron, and the p-value was less than 0.05, which was statistically significant. The average rise of hemoglobin is around 2.9 gram per deciliter in case of IV iron sucrose patients and 2.5 grams in case of oral therapy. Overall, increase in hemoglobin is good with IV iron sucrose, and administration of oral iron is not sufficient enough in order to reverse anemia promptly due to limited absorption, GI symptoms, and poor compliance for long treatment of the patients. As far as blood transfusions are concerned, because of the risk of infection, bacterial, viral, and prions and immunomodulation associated with allergic blood products, transfusion are used only in most severe cases of anemia and particularly in life-threatening situations. Therefore, IV iron sucrose or IV iron treatment has been considered as an alternative treatment for blood transfusion in management of iron deficiency anemia in pregnant women. Conclusion: iron supplementation in either forms improves iron status during pregnancy and postpartum period, thus providing some protection against iron deficiency anemia in subsequent pregnancy. But IV iron sucrose is highly efficacious over oral iron therapy for anemia in pregnancy, as it rapidly restores iron stores. Effective compliance ensured with injectable group, better tolerated and safe in pregnancy with minimal side effects than the oral iron. This treatment will certainly help in reducing the risk of homologous blood transfusion and treatment of moderate anemia during third trimester. My references are World Health Organization, United States University, UNICEF, Iron Deficiency Anemia Assessment, Prevention and Control, Williams, Textbook of Obstetrics, 25th edition, and Iron Therapy in Iron Deficiency Anemia in Pregnancy, Intravenous Route versus Oral Route. Thank you.
It's a nice presentation.
Thank you, sir.
It's a nice presentation. And one problem is with oral iron therapy. Always we see there is people do not tolerate a metallic taste and constipation, and also there is sometimes people develop vomiting. So in injectable formulation, do the patient develop that type of side effects? Have you ever assessed?
Sir, only patient with complaints of allergic reactions, sir. That is very rare also, sir. Only the patient will be complaining of chills, rigors. Rarely rashes they will be complaining, sir. Not much of a vomiting sensation and all, sir.
So normally with oral, that is the problem.
Yes,
then
sir.
Another thing is that when injectable preparations are being given, also sometimes deposition, if this is not properly IV given, then there is deposition and discoloration of the skin. So do you have any complications like that?
No, sir. Till now we did not see met with such a complication, sir.
Okay, thank you.
Thank you, sir.
Thank you so much. Thank you, doctor. Let me go ahead and call on the next presenter. It's still a poster presentation by Dr. J. Mehta from SMT BK Shah Medical Institute and Research Center, India. The topic is about granulomatous lesion in cerebral tuberculoma, a diagnostic challenge.
Hi, I am audible.
Yes, you are. Yep, I cannot see your screen, doctor. Please proceed.
Okay. Good afternoon, everyone. I am Dr. Jay Mehta. First of all, I would like to thank International Association of Neuroscience and Neurobiology for giving me this opportunity of poster presentation. Today, I am going to present a rare case of cerebral tuberculoma. Starting with the introduction, central nervous system involvement is the most severe form of disease, comprising 10% of all tuberculosis cases. The causative organism, that is Mycobacterium tuberculosis in CNS, occurs either in a diffuse form as basal exudative leptomeningitis or in a localized form as tuberculoma, abscess, or cerebritis. Starting with the case history, a 22 years old immunocompetent female complaining of headache and fever for a week was admitted. Her physical examination was unremarkable. A ring enhancing lesion was discovered on magnetic of her brain. Am I audible?
Yes, sir, you are.
Okay. The most significant lesion was surgically removed, and the histopathological investigation revealed granulomatous lesion favoring tuberculosis. We will discuss in this report the diagnosis of the rare disease on the basis of histopathological and microbiological findings. Going with the observation and results, the gross finding shows that the excised lesion was single, dark brown in color. It was soft and measuring 1.4 centimeter, and it was completely embedded. The microscopic finding shows that the tissue cellularity was normal and the bone architecture was preserved. There was normal maturation of erythroid cells, that is RBC, and normal maturation and differentiation of myeloid cells were seen. Megakaryocytes and lymphocytes were also observed, and the foci of necrotizing epithelioid granuloma with giant cells were also seen. Let me show you the images so that we can get a clear idea. See here, this is the caseous necrosis, which is surrounded by the epithelioid granuloma, which are surrounded by the lymphocytes. So this is the definite diagnosis of cerebral tuberculoma. Going with the discussion, cerebral tuberculoma is a dreaded presentation of tuberculosis that results from the hematogenous spread of a distant tuberculous focus. Cerebral tuberculomas may be solitary or multiple and are most commonly seen in the basal parts of the brain. It is extremely rare to find cerebral tuberculomas that are large enough to produce compressive features. Cerebral tuberculomas can be easily misdiagnosed as intracranial tumors. Furthermore, cerebrospinal fluid analysis may not be contributory, as tuberculosis bacilli are not always observable in the CSF. So we could establish the diagnosis of tuberculoma only after a histopathological examination of excised lesion in this case. The references are as below. Thank you.
So I request Professor A.V. Srinivasan. Okay, he might be Dr. Srikant. Dr. Srikant to give ask him the questions.
Yes, actually we are seeing tuberculosis more often. Commonly we are seeing tuberculosis, but how often you will do biopsy in every cases of tuberculosis? Because serious tuberculosis we are seeing lots of
biopsy.
Cases. But if why in every cases do you need biopsy? Because most nowadays the radiological investigation can also show whether it is a tuberculoma or it is a neurocysticercosis or it is a other brain abscess or any lesion like that. Okay, so because most of the tuberculomas having shows lipid lactate peak in case of MR spectroscopy, and clinically evident you can go for treatment and re-evaluate by radiologically. But why for biopsy? What is the importance? Why this patient has gone for biopsy actually?
Sir, to differentiate from intracranial tumors through the
It can be also differentiated from the radiological aspect also.
Sir, but
we should show the radiological picture first. Then it's better to see the radiological picture. Otherwise, we have to only show only the biopsy picture, because in peripheral biopsy we can also see that any tuberculoma in the periphery. We cannot exclude whether it is a true picture of brain biopsy, or it may be. You should show the radiological picture first. Then we can think whether it's okay, but it is a common, actually it's a common disease actually, not it's a rare disease. And we can, if first remind any cases of suspected tuberculosis, first treat with anti-tubercular drugs before starting in a chemotherapy agents, always, because it is a treatable condition. Okay.
Yes.
So thank you, Vijay. Okay.
Thank you, sir.
Thank you so much. Let us go on the next presenter. Still a poster presentation by Dr. M.J. Haja Abdul Nazir from Vinayaka Mission Medical College, India. The topic is about the molecular approaches in the detection and characterization of Leptospira SPS isolated from icteric patients in coastal region of Karaikal. Yep, we can see your screen, Doctor.
We are able to see the screen. Please present.
Go
Dr.
ahead.
Haja.
Doctor, go ahead, please. We cannot hear you, Doctor. You are on mute. No, we can see your screen, Doctor, but you are on mute.
Oh, sorry, madam.
Yes.
Yes, sir. Yes, madam. Yes, am I audible now?
Yes, you are. Please proceed.
Thank you, madam. So my topic is molecular approach in the detection and the characterization of Leptospira species isolated from icteric patients in coastal region of Karaikal. And coming to the introduction, leptospirosis is one of the most common zoonoses infecting both developing and also the non-developing countries. Usually, it's classified as a non-occupational diseases, and now it is being associated with the recreational activities also, where the peoples are getting exposed with the contaminated soil and also the water. Here, there is an increased number of people who are involved in the outdoor activities, which may increase the chance of getting infected with the Leptospira species. Here, the pets, rodents, which acts as the source of Leptospira organisms, who are shedding their urine in the outside regions, environments, which acts as the sources for getting the human beings to be infected. Also, the high density of rats in the markets is a potential threat to the visitors and town service workers also. The expansion of housing areas also increases the opportunistic contact with between the humans and also the infected wild animals. Hence, our environments are frequently associated with most Leptospira species, especially some more of the non-pathogenic organisms. Leptospiras are being present in our environment. However, recently the normal pathogenic species, Leptospira chemiti, has been isolated from our India, various regions of our India. Aim and objective of this study. Here, this study aims to detect and characterize the Leptospira species from the isolated from the blood sample of icteric patients who is coming from the coastal region of Karaikal. Coming to the materials and methods, totally 144 samples were collected from patients who are with acute febrile illness from the coastal region of Karaikal. These samples are being cultured in the EMJH medium and supplemented with some antimicrobial agents to reduce the contamination. And this culture was again purified, and it is being the DNA has been isolated from the sample culture, and it is being sent for the molecular approaches. The DNA sequence are then edited in the bioedit and compared with against the gene bank database using the BLAST software. And 16S RNA gene partial sequence of some our isolates, our culture isolates were being aligned with the 16S RNA sequence of the time chains obtained from the gene bank by using the muscle in the Mega6 software. And this is the result which we got. This is the result which we got from this molecular approaches. Here, the result shows that the leptospiras were about positive in 22.9% of the isolates genetically identified. And based on the 16S RNA, the gene partial sequence, the pathogenic leptospira were Leptospira alstoni was identified as 3% of the overall isolates, and the intermediate isolates, intermediate pathogenic leptospiras were Leptospira olfi and then Leptospira listeriaceae. And some of the non-pathogenic leptospiras has been isolated. One is the Leptospira meri, which is with 24.2%. Leptospira meri. And coming to the conclusion, the data presented in the present study demonstrate the presence of clinical significant Leptospira strains of Leptospira alstoni and the predominance of Leptospira mayeri. The pathogenic strain was found to not contain one of the highly conserved putative leptospiral viral gene, virulence gene. Therefore, the early prevention and the detection is necessary to reduce the risk of infection among the population. Hence, the continuous control and the surveillance are essential in lowering the burden of these diseases. These are our references. Yeah, this is the phylogenetic tree which we got from the 144 samples, from which we have identified these organisms through the molecular approaches. Thank you, madam.
Thank you so much.
I request Professor A.B. Srinivasan to ask question.
Okay.
Yeah, it's a lovely paper, and I think every one of us should know the diagnosis is difficult. Leptospirosis itself, a lot of discussions have taken place in the world literature. I think you have done it by ideally this. I only congratulate you. It's a lovely paper. I think you should collect the series and present it as a paper in any one of the standard gastroenterology journals. It will be an excellent one. Even with the case report, you can do that. That's my comment. It's a beautiful paper.
Yes, sir. Yes, sir. We will do it, sir. Actually, we are doing this study with the clinicians, where they are presenting as the case report, where we are doing as an original case study, original study. We are doing with the molecular approaches, sir. Clinicians are doing with the clinical studies.
That is the limitation of the immunoglobulin method. You have rightly chosen the molecular method because that is the real very good one.
Yes, sir. Yes, sir. they're not here. The limitation is thing is we have to wait for the culture to grow, sir. Then it has to be purified. Thing is, sir. We have done with the limited study in our region only, and we have to go with some other means we have to go correlate with some other methods which we can get the clear result. I think so, sir.
Okay.
Please. ఆ పుట్టిదేని పిల్లోడు లేదా కానీ పాప లేదా కానీ ఆ రెస్పాన్సిబిలిటీ పెట్టి వాళ్ళు తీసుకుంటారు.
Thank you so much. All right, let me call on the next presentation. It's also a poster presentation by Jaya Sakti from Vinayaka Mission Medical College, India. The topic is about the role of ankle brachial pressure index in diagnosis of peripheral vascular disease in type 2 diabetes mellitus.
Ma'am, good evening, ma'am.
Hi, my apologies, sir. Doctor, please go ahead.
Yes.
Yep, your screen is visible. Please proceed.
Yeah, ma'am. My topic is about the role of ankle brachial pressure index in diagnosis of peripheral vascular disease in type 2 DM. Background: it's a peripheral arterial disease in patient with type 2 DM mellitus is an important risk factor for vascular events like microvascular and macrovascular. Recommendation about whether angle depending of the source of ankle brachial pressure index should be performed. Therefore, it is necessary to study the importance of the risk factor associated with peripheral arterial disease, and also it is useful to perform the ankle brachial index is newly diagnosed and is clinically treated patient with peripheral arterial disease symptoms. It's a method. In a present study, the data was collected from 711 subjects. It's divided into three groups. First group 600 with type 2 DM patients with symptomatic of peripheral arterial disease. In the group 2, 61 patients with diabetic mellitus newly diagnosed. In group 3 is 50% the asymptomatic without diabetic. It's a control. Ankle brachial index medical records and physical examination was performed in all patients according to the cardiovascular risk factor. Results of this study include: the result of the present study indicates the abnormal ankle brachial pressure index in 49% more than 50 years of age, and then 42% less than 50 years of age was observed in group 1. Considering clinically treated patient with peripheral arterial disease, prevalence of 39% was observed. Among this, 48% was less than 50 years, 32% was more than 50 years. The stepwise regression model was developed with type 2 DM duration and sedentary lifestyle found to be independent variable prediction of severity of peripheral arterial disease related to ankle brachial pressure index. The conclusion of this study is nothing but it's a present study. In type 2 DM patients, ankle brachial index should be measured by diagnosis to detect the early diagnosis of developing ulcer, peripheral ulcers. In addition, that sedentary lifestyle was a strong association with presence and severity of peripheral arterial disease. That's all, ma'am.
Thank you so much. Any questions from our chair?
I request Dr. Srikant to ask questions.
This was already presented by him actually just in a PPT presentation. This same topic, similar topic. Actually, I have already asked this question actually. So I think this is the poster presentation of his PowerPoint presentation. Nothing like nothing. Is it there? Is it Jasati? It is right. Dr. Sakti.
Doctor, what was that again?
Ma'am.
Dr. Sakti, is it right? You are presenting the same poster
No.
or the PPT?
Oh, no, sir. The first presentation by him earlier was about.
First
Hold on.
presentation is was between an ankle, this comparative study, ma'am.
Comparative study.
Ankle brachial pressure index and color Doppler ultrasound. This one is about the ankle brachial pressure index in diagnosis of peripheral vascular disease. That's all, ma'am.
Yeah.
That's a comparative study.
Nearly same, because the study what we are taken the same 711 cases and the same cases. Only have to divide it the different parts.
Yeah, ma'am.
I think so. Yes.
Okay.
Okay. It's right.
Okay, this
Already asked question.
Actually, what I am asking that this is almost the same presentation. Actually, it's a PPT presentation the earlier, and this is so this you can go for. Otherwise, this will be self plagiarism. So actually, this is the problem. Otherwise, it's not okay. But that's nice attempt. Thank you.
Nice attempt. Okay, thank you.
Thank you so much, Doctor, for the feedback. Thank you so much, everyone. And I would like to say, please, yeah, my technical team will be sharing a screen. This is about the organizers. Please play the video. Oh, my apologies. My apologies. I still have one more presenter. 8. Right. Please let us welcome oral presentation by Mona Lisa Biswas from Manipal Academy of Higher Education, India. The topic is about hematological indices in risk stratification of coronary artery disease. Calling Mona Lisa Biswas.
Hello, madam.
Hi. Yes, I can hear you. Doctor, can you please unmute one of your devices to prevent the feedback?
Hello, madam. Yeah, I'll share it
All
through
right.
my. Yeah, I'll
Go
share
ahead,
it through
please.
Yeah, madam.
All right, we can now see your screen. Please proceed.
Hello, madam. Am I audible, madam?
Yes, you are.
Okay, madam. I am. Good afternoon to everyone. I am presenting my topic. Hematological indices in risk stratification of coronary artery diseases.
Mona Lisa, please actually see that whether other mobile is there in your room or other devices are there. So it is echoing. Please continue. Mona Lisa, please continue. But there may be other mobile, so it is echoing.
Yeah, if you want to use your mobile, or presenting through the mobile, please turn off the audio of your laptop.
Can you share your screen?
We can't hear you.
Hello, madam. Am I audible now?
Or please proceed.
Okay, madam. Thank you so much. I'm so sorry. Okay, I am presenting my topic, hematological indices in risk stratification of coronary artery diseases. So coming to the background, coronary artery disease is actually a vascular disease which proceeds from foam cell accumulation to development of fatty streak to plaque formation and finally rupture of that plaque, which causes the ultimate manifestation, that is heart attack or myocardial infarction. Now what happens is atherosclerosis might happen in many vessels, but why are cardiac muscles affected the most is because coronary arteries are end arteries, and most of the time there is inadequate collateral circulation. So whenever there is a plaque formation there or a thrombosis, so there is necrosis and ischemia of the cardiac muscles, which causes the infarction. Now coming to the background of the study, so this MI which happens with that develops over the years has a long silent and asymptomatic phase, which is very difficult to catch clinically, and the entire process of atherosclerosis, inflammation is said to have a role in the entire process, right from inception to the development of MI as well as restenosis. But current methods or markers diagnose ACS only after it manifests. It manifests as an acute coronary syndrome, and lipid profile has been used as a laboratory screening tool. We do assay total cholesterol and triglyceride levels. However, the predictive potential of the same to rightly forecast coronary events still remains controversial. So this was the hypothesis that our complete blood counts could be an easy indicator of not only atherosclerosis but any inflammatory process. But since we were studying on atherosclerosis, we studied that. So there are interaction of our various blood cells, and it is said leukocytes and platelets interact and help in chemotaxis, adhesion and extravasation of all the leukocytes, including neutrophils. Neutrophils have a very important role in coronary artery disease, as well as monocytes and macrophage formation. And both these platelets and leukocytes form a thromboinflammatory cascade, which could forecast any ongoing inflammatory process in our body. So leukocytes are the key drivers of systemic inflammatory cascades, whether it is acute or chronic, infectious or non-infectious, and leukocyte perturbations and altered complete blood count indices may precede clinical or subclinical inflammation in early atherosclerosis. So our objective was to compare hematological indices in troponin T positive and negative patients presenting with chest pain. So what did we do is in 1 month in our hospital, that is August 2018, whichever patient was advised to undergo troponin T evaluation, we included all those patients' data in our study, and we divided them into troponin T positive and troponin T negative patients, that is having MI, not having MI. Then we correlated those hematological indices with troponin T, and we determined the sensitivity, specificity, and the area under curve. This was a totally retrospective study, data-driven study. So we found 830 troponin T, 830 patients were advised to have troponin T investigation in the year August 2019, and we extracted the entire CBC information, as well as if there were any histopathological reports and all from the laboratory information system. We took prior ethical, institutional ethical committee approval. Both genders above the age of 18 years were included, but patients who were diagnosed with or undergoing treatment for cancer or acute infectious diseases were excluded from the study because of the very apparent reason that they will have very exaggerated inflammatory cascades in their body, which can be misleading. So the data was divided into TROP-T positive group, TROP-T negative group with the standard cutoff of 0.04 nanogram per ml. Group differences were evaluated with Mann-Whitney test. Spearman's test was used to determine correlation, and we determined the sensitivity and specificity. So these are the results. The neutrophil lymphocyte ratio in TROP-T negative individuals, I wouldn't call them healthy individuals because they came to the hospital presenting with chest pain, but TROP-T negative individuals was 3, while people presenting with MI was 6.5. Similarly, platelet lymphocyte ratio was way lower in the negative group than in the positive group. Lymphocyte monocyte ratio was higher in the TROP-T negative group, that is those patients who did not have a MI versus those patients who had an MI, because MI is a condition of lymphocyte consumption. The lymphocytes are recruited to have a immune response, exaggerated immune response, and this is a novel marker, that is systemic immune inflammation index, which is a combination of all the indices, that is platelets into neutrophil lymphocyte ratio. So that was way higher in TROP-T positive patients when compared to TROP-T negative patients. All these parameters were statistically significantly different between both the groups. So this was the correlation of these markers with the troponin T values of the patients. All of this was also significant. However, not only NLR showed a good correlation, other correlations were weak. Coming to the receiver's operating curve characteristics. So these are the specificities and the sensitivities. So we can see PLR and lymphocyte monocyte ratio showing a good specificity, while NLR and systemic immune inflammation index showing a good sensitivity. So to conclude, hematological indices, very importantly, along with the clinical picture, because these indices on its own might not make any meaning, hematological indices along with the clinical picture, a person presenting with MI or having a previous history of coronary artery disease. So these indices along with the clinical picture might be helpful in ruling out cases of chest pain as MI or not, be important in predicting, risk stratifying or prognosticating. However, there are limitations because this was a retrospective study, so this has to be done in a prospective follow-up model, and we did it only in acute patients. So if we do establish a reference range in healthy population first, and in various diseases like diabetes, many people will have diabetes, which is also inflammatory. So we have to establish the reference range of these indices in various conditions, and also do a prospective cohort study where mild CAD patients are followed up for their indices, or we find indices in various groups, mild CAD or mid LAD bridging cases, as well as STEMI and STEMI cases, unstable angina, stable angina. So we can get a full genre that how the indices will change as inflammation develops in right from healthy asymptomatic patients to premorbid patients to patients with subclinical or overt atherosclerosis. And we also have to account for the comorbid conditions like diabetes and hypertension, and find probably a adjusted model for this. I thank my college, Kasturba Medical College, Manipal, and the management of Manipal Academy of Higher Education for making this study possible. These are my references. Thank you.
Thank you so much. Any questions from our chair?
Actually, very nice approach to establish this hematological indices can be one of these indices for MI. But thing is that this MI and coronary artery disease and hypertension, diabetes, these are our brothers and sisters. They don't come alone. Most of the time, they come with a comorbid. So that is one of the problem.
Yes,
will be definitely bias will be there, because every time there will be different types of patients, they will develop this type of problem. So have you excluded this patient with that diabetes along with, and any other infectious disease or along with? So this will be problematic definitely, because there may be some other infections where the neutrophil count has been increased. So this will complicate your indices of diagnosing that hematological indication for diagnosing a coronary artery disease. So this cannot be so much
yes,
of
yes.
specific. Also, this cannot be also most that amount of specific, but nice approach. So more sophistication study may be required. Okay. Thank you for your
Yes,
presentation.
yes. Yes, sir. Thank you so much, sir. Thank you.
All right, thank you so much. Thank you. Congratulations to all presenters. Now, while we are waiting to for the session, the second session or the session 2 to conclude, here's a short video about our organizers, which is the Bio Leagues Worldwide, which is a not-for-profit professional association which prominently promotes research and development. Let's watch this. Team audio is not, no audio. No audio. Right, since our audio is not supported by this one. All right, we at the BioLeagues have brought a revolution in the field of worldwide conferences. BioLeagues worldwide conferences bring together the professional wizards and leaders who have explored all avenues to reinforce the field of life sciences and medicine technology. BioLeagues worldwide conduct events worldwide which help in enhancing the skill set of the people from diverse industries and also forms a common platform for eminent personalities, physicians, researchers, doctors, and academicians, professionals, business figures, and many more. BioLeagues conference encourages a better comprehension about improvement and progressions over the world through worldwide conferences with the speed of science and technology. We work with our motto of creating a better tomorrow. We're organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development. And we organize scientific events in association with renowned universities done in the past. Like Scopus Indexed, Web of Science,
by Twinkle Rajendra Kumar Jariwala. Uttar Pradesh University, India, topical about study to compare the effect of perturbation exercises versus
All right. BioLeagues Worldwide, BLW for short, is one of the world's largest non-profitable professional associations. My apologies, everyone. Our audio is not supported by the conference, so I will be your audio for today. In cooperation of Technorit Research, please pause. BioLeagues Worldwide Conferences, established in 2000. Okay.
राहुल 6 बजे क्या रहे
Welcome to BioLeagues Worldwide, prominently promotes research and development and have brought a revolution in the field of worldwide conferences. In this video, we want you to dive into our world, giving yourself a clear insight of the BioLeague events. But first, who are we, and what do we do? BioLeagues Worldwide, BLW for short, is one of the world's largest non-profitable professional associations operating under the Techno-Read Research and Development Association, DRADA, meant for research and development in the field of engineering, science and technology. BioLeagues Worldwide conferences bring together the professional wizards and leader bodies for scientific professionals in India and across the globe. Established in 2000, we extend to every part of the globe, with more than 28,000 professional members and 34,000 student members. Our frowning membership at BioLeagues has led to an increase in members from Europe, Asia, Australia, and Africa, fostering networking opportunities that strengthen ties within and across countries and technical communities. BioLeagues works with the motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development. Mission: to connect professionals at an integrated platform for growth to divert knowledge through our professional activities and scientific conferences. Vision: of a united platform to explore research with opportunity to innovate multidisciplinary scopes and applications of professional studies. BioLeagues widely connects researchers, exchange global innovation, and acts as a bridge between other academicians by organizing international conferences, world conferences, faculty development programs, webinars, seminars, providing membership, and more. Some of our conferences include Breast Cancer Dubai, 7th World Conference on Pharmaceutical Science and Drug Manufacturing, Nanosphere UAE, EduMIS, Indo-Oncology Summit, International Conference on Dermatology and Cosmetology, and many more. Every organized scientific events in association with renowned universities done in the past, with over 28,593 journal publication services, creating opportunities to get your research paper published in high-impact factor journals such as Scopus Indexed, Web of Science, Google Scholar Indexed journals, SCI, and many more. To make our operations smoother and more perfect, we have been supported by our associated organization, International Association of Oncology, IAO, Universal Society of Food and Nutrition, USFN, International Association of Neuroscience, IAN, International Society of Environmental Relationship and Sustainability, ISERS, Association of Pharmaceutical Research, APR, Society for the Research and Studies of Nanotechnology, SRSN, and many other research associations. Actively upcoming, Association of Pharmaceutical Research, APR, releases the upcoming 8th World Conference on Pharmaceutical Science and Drug Manufacturing. We at BioLeagues believe that there's always a better way to treat professionals, and that is what we do. If you would like to explore with BioLeagues, visit our homepage www.bioleagues.com. BioLeagues your way. Welcome to BioLeagues Worldwide, prominently promotes research and development and have brought a revolution in the field of worldwide conferences. In this video, we want you to dive into our world, giving yourself a clear insight of the BioLeague events. But first, who are we, and what do we do? BioLeagues Worldwide, BLW for short, is one of the world's largest non-profitable professional associations operating under the Techno-Read Research and Development Association, DRADA, meant for research and development in the field of engineering, science and technology. BioLeagues Worldwide conferences bring together the professional wizards and leader bodies for scientific professionals in India and across the globe. Established in 2000, we extend to every part of the globe, with more than 28,000 professional members and 34,000 student members. Our frowning membership at BioLeagues has led to an increase in members from Europe, Asia, Australia, and Africa, fostering networking opportunities that strengthen ties within and across countries and technical communities. BioLeads works with the motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development. Mission: to connect professionals at an integrated platform for growth to divert knowledge through our professional activities and scientific conferences. Vision: of a united platform to explore research with opportunity to innovate multidisciplinary scopes and applications of professional studies. BioLeads widely connects researchers, exchange global innovation, and acts as a bridge between other academicians by organizing international conferences, world conferences, faculty development programs, webinars, seminars, providing membership, and more. Some of our conferences include Breast Cancer Dubai, 7th World Conference on Pharmaceutical Science and Drug Manufacturing, Nanosphere UAE, EduMIS, Indo-Oncology Summit, International Conference on Dermatology and Cosmetology, and many more. Every organized scientific events in association with renowned universities done in the past, with over 28,593 journal publication services, creating opportunities to get your research paper published in high-impact factor journals such as Scopus Index, Web of Science, Google Scholar indexed journals, SCI, and many more. To make our operations smoother and more perfect, we have been supported by our associated organization, International Association of Oncology, IAO, Universal Society of Food and Nutrition, USFN, International Association of Neuroscience, IAN, International Society of Environmental Relationship and Sustainability, ISERS, Association of Pharmaceutical Research, APR, Society for the Research and Studies of Nanotechnology, SRSN, and many other research associations. Actively upcoming, Association of Pharmaceutical Research, APR, releases the upcoming 8th World Conference on Pharmaceutical Science and Drug Manufacturing. We at BioLeads believe that there's always a better way to treat professionals, and that is what we do. If you would like to explore with BioLeads, visit our homepage www.bioleads.com. Have BioLeads your way. Welcome to BioLeads Worldwide, prominently promotes research and development and have brought a revolution in the field of worldwide conferences. In this video, we want you to dive into our world, giving yourself a clear insight of the BioLeads events. But first, who are we, and what do we do? BioLeads Worldwide, BLW for short, is one of the world's largest non-profitable professional associations operating under the Techno-Read Research and Development Association, DRADA, meant for research and development in the field of engineering, science, and technology. BioLeads Worldwide conferences bring together the professional wizards and leader bodies for scientific professionals in India and across the globe. Established in 2000, we extend to every part of the globe, with more than 28,000 professional members and 34,000 student members. Our founding membership at BioLeads has led to an increase in members from Europe, Asia, Australia, and Africa, fostering networking opportunities that strengthen ties within and across countries and technical communities. BioLeads works with the motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development. Mission: to connect professionals at an integrated platform for growth to divert knowledge through our professional activities and scientific conferences. Vision: of a united platform to explore research with opportunity to innovate multidisciplinary scopes and applications of professional studies. BioLeads widely connects researchers, exchange global innovation, and acts as a bridge between other academicians by organizing international conferences, world conferences, faculty development programs, webinars, seminars, providing membership, and more. Some of our conferences include Breast Cancer Dubai, 7th World Conference on Pharmaceutical Science and Drug Manufacturing, Nanosphere UAE, EduMIS, Indo-Oncology Summit, International Conference on Dermatology and Cosmetology, and many more. Every organized scientific events in association with renowned universities done in the past, with over 28,593 journal publication services, creating opportunities to get your research paper published in high-impact factor journals such as Scopus Index, Web of Science, Google Scholar indexed journals, SCI, and many more. To make our operations smoother and more perfect, we have been supported by our associated organization, International Association of Oncology, IAO, Universal Society of Food and Nutrition, USFN, International Association of Neuroscience, IAN, International Society of Environmental Relationship and Sustainability, ISERS, Association of Pharmaceutical Research, APR, Society for the Research and Studies of Nanotechnology, SRSN, and many other research associations. Actively upcoming, Association of Pharmaceutical Research, APR, releases the upcoming 8th World Conference on Pharmaceutical Science and Drug Manufacturing. We at BioLeagues believe that there's always a better way to treat professionals, and that is what we do. If you would like to explore with BioLeagues, visit our homepage www.bioleagues.com. Have BioLeagues your way. Welcome to BioLeagues Worldwide, prominently promotes research and development and have brought a revolution in the field of worldwide conferences. In this video, we want you to dive into our world, giving yourself a clear insight of the BioLeague events. But first, who are we, and what do we do? BioLeagues Worldwide, BLW for short, is one of the world's largest non-profitable professional associations operating under the Techno-Read Research and Development Association, DRADA, meant for research and development in the field of engineering, science, and technology. BioLeagues Worldwide conferences bring together the professional wizards and leader bodies for scientific professionals in India and across the globe. Established in 2000, we extend to every part of the globe, with more than 28,000 professional members and 34,000 student members. Our thriving membership at BioLeagues has led to an increase in members from Europe, Asia, Australia, and Africa, fostering networking opportunities that strengthen ties within and across countries and technical communities. BioLeagues works with the motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve sustainable development. Mission: to connect professionals at an integrated platform for growth to divert knowledge through our professional activities and scientific conferences. Vision: of a united platform to explore research with opportunity to innovate multidisciplinary scopes and applications of professional studies. BioLeagues widely connects researchers, exchange global innovation, and acts as a bridge between other academicians by organizing international conferences, world conferences, faculty development programs, webinars, seminars, providing membership, and more. Some of our conferences include Breast Cancer Dubai, 7th World Conference on Pharmaceutical Science and Drug Manufacturing, Nanosphere UAE, EduMIS, Indo-Oncology Summit, International Conference on Dermatology and Cosmetology, and many more. Every organized scientific events in association with renowned universities done in the past, with over 28,593 journal publication services, creating opportunities to get your research paper published in high-impact factor journals such as Scopus Index, Web of Science, Google Scholar indexed journals, SCI, and many more. To make our operations smoother and more perfect, we have been supported by our associated organization, International Association of Oncology, IAO, Universal Society of Food and Nutrition, USFN, International Association of Neuroscience, IAN, International Society of Environmental Relationship and Sustainability, ISERS, Association of Pharmaceutical Research, APR, Society for the Research and Studies of Nanotechnology, SRSN, and many other research associations. Actively upcoming, Association of Pharmaceutical Research, APR, releases the upcoming 8th World Conference on Pharmaceutical Science and Drug Manufacturing. We at BioLeagues believe that there's always a better way to treat professionals, and that is what we do. If you would like to explore with BioLeads, visit our homepage www.bioleads.com. Have BioLeads your way. Welcome to BioLeagues Worldwide, prominently promotes research and development and have brought a revolution in the field of worldwide conferences. In this video, we want you to dive into our world, giving yourself a clear insight of the BioLeague events. But first, who are we, and what do we do? BioLeagues Worldwide, BLW for short, is one of the world's largest non-profitable professional associations operating under the Techno-Read Research and Development Association, DRADA, meant for research and development in the field of engineering, science and technology. BioLeagues Worldwide conferences bring together the professional wizards and leader bodies for scientific professionals in India and across the globe. Established in 2000, we extend to every part of the globe. With more than 28,000 professional members and 34,000 student members, our founding membership at BioLeagues has led to an increase in members from Europe, Asia, Australia.
Right now.
All right, while we are waiting everyone to join us, just a little bit about the conference. So, with an earnest objective of creating an international forum for academicians, researchers, neurologists, and budding students, BioLeagues and International Association of Neuroscience, enunciating this second international conference on neuroscience and neurology, which slated yesterday, July 17, and today, July 18. The conference enlightens on the theme Important and Revolutionary Investigations in Neuroscience. Second International Conference on Neuroscience and Neurology 2021 aims to interconnect the professionals from various parts of the world for an optimistic networking and collaboration and will provide you a wonderful forum to refresh your knowledge base and in exploration of neuroscience, neurology, and neurological disorders. Neuroscience 2021 will discuss about the perspective or has discussed about the perspective in various fields of neurology, neuroimmunology, neuro-oncology, pediatric neurology, neurochemistry, neurophysiology, what's new in future neuro healthcare, health education for neuro patients, precision medicine in neural disorders, clinical trials in neurology, and more. It is a prestigious event organized with a motivation to provide an excellent international platform for the academicians, researchers, neurologists, and budding students around the world to share their research findings with the global experts. Thank you so much, everyone. Yeah, I still have few people that are in session 2. Please come back. Please advise them to go back to this session, to the main session.
Hello, everyone. Please proceed to the main room right now. Thank you.
And for now, let me go ahead and welcome our conference chair, Dr. A.V. Srinivasan, former President, Indian Academy of Neurology, Emeritus Professor, the Tamil Nadu Dr. MGR Medical University, to deliver the valedictory and the vote of thanks. Professor, you're on mute. There you go.
First of all, I must thank BioLeagues and then the TRADA for giving this opportunity to speak to you. It's a wonderful occasion. I just want to quote what Baba used to say. Medicine plus love is Medicare. Medicine without love is medicine. S-I-N. Now, Why I say that, I think with love and fond and then the academic brilliance, it all shown here, and I find slowly but surely the academic standards are going up, and I find the people are interested in the neurosciences and the neurology and neurosurgery and the physiotherapy. To just say one outward that the physiotherapy section, I just tell you, 2 nurses were sent to England to get trained in MCSP. And they returned to India and started the first physiotherapy section in the government section in India. And his name is L. Vital now. When the Queen came in 1962, the only department which was praised was physiotherapy, because it really dawns in the morning and then goes to the evening. And the physiotherapy is an excellent one, and we have nicely brought about the papers from there also. Overall, both first and the second day, we are extremely happy, A as a scientist, B as a practitioner, and C as a complementary alternative medicine also playing a very crucial role. All the papers, I just wanted to, with the permission of the chair, I just permission of the chair of the TADA and as well as the Bio League. I am very, very happy to announce the following people have been given the awards by the Bio Leagues and TADA. The first is the Best Presentation Award goes to the Mona Lisa Mishra for her Enhancing Neuroplasticity with the NLP Communication Model, a Strategic Review. Excellent paper, and she deserves all encouragement in future awards too. The Best Poster Presentation Award went to Rajeshri Chakraborty for the post-mum extrapyramidal syndrome in an young child. I think this is a very good paper which deserves an award. Coming to sections 1, Behavioral Sciences and the Disorders, I think the names, the first prize goes to Shanprava Mohakut for his excellent paper which has been presented on the effects of metacognitive strategy training on the recovery of independence of post-stroke survivors. It's a beautiful paper. I think well done. Congratulations for you for giving this wonderful paper. And the second prize goes to Dr. Salvi Ashram, and who has had a body mass index, the physical activity and the fear of fall among the community dwelling in elderly people population in the urban Surat, Gujarat, a pilot study. I think they should make it into a full study, because fall is very, very frequent factor in the elderly. I think it's an excellent paper that deserves the second prize. And then the third prize went to Lisa Faldo for her paper on the correlation of the levels of anxiety with working memory and the fatigue in the students pursuing the healthcare profession. I think it's a worthy one among the medical students, and it should come into their fact. Now, the second, the science, especially the behavioral sciences and the disorders, the section 2, the prize goes to Dr. Hina Pranav Rathod for his paper on the comparison of one-time session with the intermittent session of sensory diet in toddlers with SPD. It's a beautiful paper presentation and deserves really the first prize. And then Rajeshri Chakraborty once again with ataxia with oculoguided crisis representing the early paraneoplastic manifestations. It's a very good one for us to analyze it in the paraneoplastic papers, because it is going to give us a clinical pearl in the future case studies. The second prize is shared now with Raman Ramesh Nair, who has had a surgical management of macroprolactinomas, indications and outcomes. This we have seen in practice. I think it's a very good practical guideline for people to approach the problem. And of course, the third prize goes to Lieutenant Colonel Sandhya B. Nair, who has presented it beautifully in the management of heart beating in the brain dead organ donor. I think these are the excellent presentation in the session 2, and in the session T with the cerebrospinal complications and the presentation title. I think the best prize goes to, the first one goes to Pooja Matar who had the effect of high voltage pulsed galvanic stimulations for constipation in acute stroke, a randomized clinical trial. I think that was a paper which I listened, which was very excellent one. And I find the second prize goes to the Vivek Harsh, the one. Hello.
Go ahead, Professor.
Sorry, 1 minute, because of the problem here. The second prize goes to we have finished Rajyasree Raman Nair Sandhya and then Pooja Matan and the Vivek Ashkulani Ramanandi for his impact of shoulder pain and the disability on the quality of life amongst the cerebrovascular accident patients of Surat, Gujarat. Once again, it is a lovely paper. And then the third prize goes to Dr. Neeti Mishra for the prevalence of psychosomatic distress and its association with the quality of life among patients of non-specific low backache in South Gujarat. I think all the papers were very good, deserves a minute, but nonetheless only 3 people can be given the prizes. The presentation title, of course, is the very good with the category 1, Dr. Tushar Palekar for the comparative study of the dry needling was the percussor in the treatment of myofascial trigger point in the levator scapulae muscle. Beautiful paper. I think it deserved the first prize, and the second prize on Dr. Vandana Rathod for the contextual factors in terms of rehabilitation services for patients with stroke. Scooping review of protocol. I think that is the best paper from the stroke management. I think she deserved the second prize, and the Kajal Shivalkar as a third prize. The effect of cryocompression and tissue flushing and hand spasticity and the function, a randomized clinical trial. I think by and large it's excellent in the presentation title from the session 4 of the neurophysiotherapy. I think the last, when we come into the poster presentation, I think the name first Sudarshan gets a prize of first prize, neuroprotective effect of Sharashwata Charna in the pilocarpine-induced rat model of epilepsy. I think it's one of the good papers deserving future study to prove the point. And first prize, once again, 3 first prizes are given. Vijita Shanai Balik, in vivo cholinergic and antioxidant property of the cucurbita pepo, that is the pumpkin seed, and ethanolic extract in the aluminum chloride induced Alzheimer's disease in Sprague daily rat model. I think it is one of the very good paper which desires only for a larger study to do that. And the third prize is, of course, Anusha Rathod, spotting signs and high risk factors of autism in elderly childhood. I think all the 3 papers deserve the first, and hence this very right that we have given the first prize to all the 3. You cannot choose between the 3. And hence we have and the last, of course, is the Puharendi Bhaktavachalam, who has done the work on the effect of Saraswata Churna on the behavioral changes in the pilocarpine-induced rat model of epilepsy. I think by and large, these are the prize winners, and we are congratulating them for the extensive work and the research. I think you have proved the point, what I said earlier in my speech, that the persons having an attitude with behavior, character, duty and dignity and discipline, excellence will be present in every aspect of thought, word and deed which we have done. I think, as I mentioned it in my earlier letter, in the welcome speech, I have clearly stated that this has really gone through so much of people, and we have found that it is a group work that has resulted in the tremendous success in this second International Neurosciences meeting. I think they have definitely changed this INA, that is 2. I think they have Association of Clinical Neurology and Mental Health Sciences. I think they have done it perfectly, and kudos to them, and in particular Rudra and his group and the bio leagues and the trade organized people. I think I wish them all a good luck. I thank once again the participants, the institutions, professors, and as well as assistant professors and the teaching faculty, and in the physiotherapy and the neurosurgical faculty. Each one of them have given their clinical pearls to all of us. I think uh, this is really lovely, and having had the opportunity of during the 25th Silver Jubilee celebration of the Indian Academy of Neurology, I'm equally pleased now today with this second conference. I wish the whole the forthcoming conferences a grand success for this, because research, the vision and the mission is very good of BioLeaks. I think we are going to have an extraordinary, better than the best conferences that we have had so far. Thank you very much. I once again thank all of you.
Thank you so much. Thank you so much, Professor. And yes, once again, I would like to congratulate all the awardees and all the presenters, and thank you so much for all the session chairs and our honorable dignitaries. Of course, you deserve a round of applause. Guys, you gave yourself a round of applause. Congratulations. Right. Now, please, my colleague will be sharing her screen, and they will be instructing you on how to, where to go on seeing the certificate and download the certificate, and how can you provide a feedback. And I recommend everyone, may it be positive or negative, please provide your feedback for or about this conference, about the speakers, and about the presenters. All your feedback, please provide it to in the feedback link. All right, team, can you go ahead and share your screen?
Jojo, can you hear me?
Yes, I can hear you.
Okay, I'll just share my screen now. Okay, so this is the link which we have already shared in the chat box. That is virtual.bioleaks.com. So once you log in, you have to enter your full name and then enter your email address and your contact number. And then submit. And there you enter the virtual platform of the conference hall. And this is the platform we have been conducting the 2-day event. So most of the listeners have been listening to the conference on this platform. So as you enter the virtual platform hall, you click on here as enter. And then we have here the presentation hall where the presentations were happening. And here we have the auditorium where the current program is going on. And here you have the selfie booth where the presenters can capture their photograph and share it on your social media platforms of your presentation that you have been done at this event. So now coming to the main point, that is most of you have the doubt of where to download the certificates. So, okay, before that, I would like to explain you that we have the conference proceeding book have been uploaded here. Once you click on the downloads, you have the Neuroscience 2021 conference proceeding, and you just have to click on it and it will be downloaded. And now coming to the feedback. Here we have the feedback. And you have to enter your feedback form here and just click on submit. Now, just a moment regarding the certificate download, we'll be sharing you another link in the chat box. Can you all please check the chat box? I have shared the link on the chat box, the certificate download link. So as you click on the link, as already announced by the chairperson, IAN Association's name have been officially transferred to the Association for Clinical Neurology and Mental Health in order to welcome more of our researchers from mental health and other related neurology department. So here you have the option of entering your email address and create a new password, which is an alphanumeric password consisting of numbers and numericals. And all you have to do is just sign in. Same like how you create an account on any other social media platforms, click on it and your certificates will be available. If you are a new person or a new member to the association, all you have to do is click on sign up and give your details such as name, email address, the contact number, the type of membership that you have availed from the association, your country, and your other details. And again, over here, you have to create an alphanumeric password of minimum 8 digits, and you just have to click on sign up. So that's it. I have shared you the link on how to download the certificate and as well as the proceeding book. Jojo, am I audible?
Yes.
Okay, thank you everyone. In case if you have any queries, please do let us know. We can clarify it, or you can connect to our help desk number in case if you find any difficulty in downloading your conference proceeding books or your certificates. Thank you.
Again, I would like to repeat. Right, I recommend everyone to please provide their feedbacks about the conference, about the speakers, about the presenters, about the whole conference, all right? And yeah, if you have any questions with the, please, everyone, please take note of the link, because once this Zoom meeting will end, yeah, it will be gone too. Please make sure to take note of it.
Sorry to interrupt, Jojo, but there is a query coming up in the chat box mentioning invalid credentials. That's because you have been entering a wrong password. You have to sign up first and then create a password. As I said, it will be a new password. You have to create a password, alphanumeric password. That is, for example, abcd@123.com, something like that. Example, I'm just putting on the chat box.
Madam, how about the prize winners?
The prize winner certificates will be emailed to you, sir.
Okay, thank you.
The presentation certificates and the listener certificate have been uploaded, as well as the 1-year free membership of ACNM. They have been uploaded on that link provided, so you can download it from there.
So this can be downloaded after this is over.
Yes, sir. The link will be valid long, and you can download as and when you require.
Ma'am, what about OPT? Where OTP? Where will it come?
Sorry, ma'am.
Will it come in the phone, OTP?
Yes, yes.
And in membership, what do we have to write?
Ma'am, if you're a professional, you have to prefer the professional membership.
Okay.
So, Jojo, maybe we can conclude, and any further queries will be taken up to the help desk. You can connect to our help desk coordinator. Yeah, thank you.
All right, everyone. Thank you so much. Again, if you have any questions, having difficulties in accessing the certificate, just access the early link and go to feedback or go to help desk. Right? And once again, everyone, I thank all the participants, our honorable dignitaries, our session chairs for joining us today for our conference success. I hope to see you guys in our future conferences. You have a great day, everyone. Help desk numbers, by the way, guys, are posted in the chat box. Please take note of them.